Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. A very good morning to all the doctors and the paramedics from all over the world who have come online for the most awaited virtual conference of the year, part one of the 7th annual Dubai Pediatric Club conference organized by Dubai Pediatric Club in affiliation with Vitavitics, Odessa from New Country Healthcare, and NMC Specialty Hospital Dubai. Myself, Tawfiq Ali, Country Business Manager of New Country Healthcare. Every year, DPC and NCH organizes the DPC annual conference physically. And since last year, due to this pandemic, we have decided to go virtual, which has given an advantage for the doctors of all over the world to attend our flagship conference. This is the first part of the annual conference, and inshallah, second part will be in the last week of November, hopefully physical, inshallah. To proceed further, I would like to invite Dr. Sahrab to take over the program. Dr. Sahrab Tomara is the president of Dubai Pediatric Club and working as a senior specialist pediatrician at NMC Specialty Hospital, Dubai. Before Dr. Sahrab takes over, I would like to play the national anthem of UAE in respect for this great, wonderful country. Here we go. Dr. Sahrab, please come online once the anthem finishes.
Thank you very much, Mr. Tawfiq. Good morning, ladies and gentlemen. On behalf of the organizing committee of the 7th annual DPC virtual conference, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries from all over the world, especially India, to this conference. This conference is organized in collaboration with NMC Specialty Hospital Dubai and is CME accredited. I would like to thank the top management of NMC Healthcare, especially Mr. Michael Davis, the Honorable CEO, as well as the management and CME team of the NMC Specialty Hospital Dubai, especially Dr. Kamran Takris, Dr. Ajit Kumar, Dr. Manoj Verma, Mr. Teja, and Dr. Ramsha for their help and support. Well, I would like to thank all speakers, panelists, and other faculty members of the 7th annual DPC virtual conference for their active participation. I would also like to thank the members of the organizing committee of DPC, especially Dr. Kalpana Sengupta, the secretary of the club, and Dr. Diari Muhammad, chairman of the academic affairs, for untiring efforts and support. A very special thanks goes to Mr. Tawfiq Ali, the country business manager of the Vitavitics, New Country Healthcare, for sponsoring this conference. This is the 7th consecutive year that Mr. Tawfiq is sponsoring DPC conferences. I would like to thank the members of Dubai Pediatric Club for their active participation in all our conferences and their support. Well, we will soon, in a special ceremony, felicitate the faculty members and present them the certificates and tokens of appreciation. I would like to thank our chief guest, Mr. Frank Delisi, the Honorable Senior Vice President of Operation NMC Healthcare, for accepting our invitation, and request him to deliver the inaugural speech.
Hello and good morning. My name is Frank DeLisi. I'm the Senior Vice President of Operations for NMC Healthcare. It is my distinct honor and privilege to welcome you to the 7th Annual Dubai Pediatric Club Conference. The DPC Summit 2021 is sponsored by the Dubai Pediatric Club in collaboration with the NMC Specialty Hospital Dubai. The Dubai Pediatric Club was founded over 25 years ago and consists of over 1,000 preeminent physicians and clinicians from across the UAE. NMC is very distinguished this year to be represented in the leadership of DPC with Dr. Sarab serving as president and Dr. Kapana as secretary. Congratulations to you both. My commendations to each of the officers, members of the executive committee, members of the DPC, attendees at this conference, presenters, and all those who are involved with the production of this virtual conference, along with special recognition to our most generous sponsors. The treasure of any nation is its children. Parents migrate from across the globe with their children in tow and join the natural citizens in the UAE in making this country home. They trust their most precious gift, their children, to your able care. As a father of 6, I have 3 daughters and 3 sons. I know the importance of having confidence in the doctors caring for my offspring. NMC Healthcare alone treats between 4,000 and 5,000 children each day. It is so important that our caregivers have access to updated, evidence-based care pathways and the most current knowledge available. That is why groups like the Dubai Pediatric Club and conferences such as this are of critical importance. What a lovely forum to share knowledge, challenge the norms, and enhance the overall effectiveness of our pediatric physician community. This past year has been a most challenging environment for the entire planet, with the health and psychological effects on our children yet to be determined. This has required innovative approaches to educating our students, along with creative techniques to evaluate and treat our young patients. Despite these unique circumstances, your commitment and compassion has never wavered. On behalf of NMC Healthcare, the parents within the UAE, and as a citizen of the world, I want to personally thank you. May you find fellowship, personal and professional growth, and a refreshed passion through this conference. With that, I declare the 7th Annual Dubai Pediatric Club Conference officially open. Please enjoy.
Thank you very much, sir, for the kind word. We are honored. Now I would like to request the founder of Dubai Pediatric Club, Dr. Cyrus Lidkoi, on whose name today's oration is named, to give his message from Sydney, Australia. Dr. Lidkoi.
Good morning and welcome to this webinar of scientific sessions and exchange of information and experience between colleagues and friends. When we started Dubai Pediatric Club about 25 years back, we were about 20 to 30 pediatricians from Dubai and Sharjah. Many of them did not know each other nor had any social or professional interaction. First few years, we had only pediatricians from private sectors to take part in our meetings. After success of our conferences with large number of participants, many doctors in other specialties started to attend our meetings. Later on, our colleagues from the government hospitals in Dubai and other emirates started attending our conferences in large number. And this was mainly due to high standard of presentation and varieties of subjects in various subspecialties in pediatric. In 2014, I decided to leave Dubai after 30 years and move to Australia, hand over the Dubai Pediatric Club to competent hand of Dubai Pediatric Club Organizing Committee, especially energetic, devoted and enthusiastic Dr. Sorab, who continue to arrange this high standard of meetings and with a keen interest and interested parties group who are participating in these sessions. I wish you an informative and successful session today and future. Thanks. Goodbye.
Thank you very much, Dr. Cyrus, for the kind word and the nice message from Australia. Now I would like to request Dr. Kalpana Sen Gupta, the Secretary of the Dubai Pediatric Club, to give her message, followed by Dr. Diari Mohammed, the Chairman of the Academic Affairs. Over to Dr. Kalpana, please.
Good morning, colleagues. It's with great pleasure that I invite you all to the 7th Annual Dubai Pediatric Club meeting. In line with the current scenario, we are having a virtual meeting, but there's always a silver lining, and that being that we've this year roped in eminent speakers from all over the world, and we look forward to interacting with them and learning with them. I will not take any more time. Let us go forward, hand over to Dr. Diari for his address. Thank you.
Thank you, Dr. Kalpana.
Good morning, dear colleagues. I would like to welcome all guests, colleagues, and viewers to this conference, and hope to have a very good academic day and feast. Wish you all the best and wish all the faculty members great success for today. Thank you very much.
Thank you very much, Dr. Diari, for the nice words. Now we start our academic program. Before introducing the chairman of the first session, I would like to give a brief account of the agenda today. Today we will have 4 presentations and 3 panels. First session will be pediatric nephrology, followed by pediatric immunology, rheumatology, then pediatric radiology, and at the end, cardiology. The chairman of the first session is Dr. Ayman Jundi. Dr. Ayman Jundi is Senior Consultant Pediatric Surgeon at Valiant Clinic and King College Hospital, Dubai. Over to Dr. Jundi. I would like to request Dr. Jundi to introduce the moderators, speaker, and panelists of the first session, pediatric nephrology, and take over the session. Thank you very much.
Good morning, everyone, and welcome to all our guests and audience. First of all, I would like to thank the organizing committee for giving me this opportunity to chair this session. Now, I would like to introduce our moderators, Dr. Kalpana Sen Gupta, who's a senior specialist pediatrician and chief of pediatric department in NMC hospital in Dubai. And she is also the secretary of the DPC. And Dr. Diari is our consultant pediatric surgeon in Latifa Hospital in Dubai, and he's the chairman of the academic affairs of the DPC as well. Our panelists will have Dr. Martin Pidzen, who's a consultant pediatric nephrologist in the Kidney Center of Excellence at Al Jalila Children's Hospital in Dubai. And we have also Dr. Intisar Al-Hamadi, who's a consultant pediatric nephrologist in Dubai Hospital, Dubai. And also we have Dr. Luay Eid, who's a consultant pediatric nephrologist, and he's the division chief of nephrology in Dubai Hospital, Dubai. Now it's over to the moderators and the panelists.
Thank you, Dr. Ayman. Thanks for the nice introductions. I would like to invite Dr. Martin now. Dr. Martin is going to enlighten us on the topic of hematuria in children. Over to Dr. Martin.
Good morning. I will share the screen. Okay. Can you see my screen?
Yes, doctor, you can go for the
Yes.
presentation view.
Presentation view. So the task I was given today is to talk about hematuria, evaluation and management from infancy to adolescence. Certainly this is a wide topic, and I hope I do justice to this topic during the next 30 minutes. I have no disclosures to make related to the topic of this morning. I will not endorse off-label use of medications or devices, and I will not use brand names for medications. The aims and objectives of my presentation will be to begin with a definition of what constitutes hematuria, what is the origin of hematuria, blood in the urine, when should we worry and when should we not worry. And then we will discuss and develop some practical diagnostic and management algorithms. And I will, in the last part of the presentation, present some vignettes of examples of hematuria syndromes, and we'll conclude with some red flags. So let's start with a trivia contest. I don't expect you to answer, but you can think about the questions. So how many RBCs do you think does it take to cause visible or macro hematuria? Is it normal to have red blood cells in the urine? And where do the red blood cells come from? Then what is the most frequent cause of macroscopic hematuria in children? Is microscopic hematuria of concern? And can newborns have hematuria? So some basic facts. Even healthy persons may excrete red blood cells in the urine, and the excretion rate is somewhere between about 1 million red blood cells per 24 hours, and this translates into less than 1 erythrocyte per microliter urine or 5 red blood cells per high power field. And that is why we have in the dipstick as normal, usually 0 to 5 red blood cells. The mechanism is not so clear. We do know though how, and we have all experienced this in everyday clinic, that fever, inflammation, and similar conditions can lead to red blood cell excretion and to usually microscopic hematuria. Now, it's a different story with free hemoglobin, which is filtered through the glomerular basement barrier. On the right side, you see a schematic diagram of a glomerulus, and you can easily make out the capsule, the capillaries that lead the blood from the afferent to the efferent arteriole. And you see here a nice diagram of a capillary with inner layer glycocalyx, endothelial cell, glomerular basement membrane, and the epithelial layer is known as podocytes. And whatever's being filtered through this barrier shows up in the Bowman's capsule and in the proximal tuber. So hemoglobin is filtered, but it usually happens only when there's hemolysis. And when haptoglobin binding capacity is exceeded, then the urine shows hemoglobin. We don't usually measure it quantitatively, but we see it in the dipstick. And some of the hemoglobin is catabolized in the proximal tuber, and it is theorized that it causes, at least in excess amount, damage to the proximal tubular cell. Now, how do we detect hematuria? So we differentiate between macroscopic and microscopic hematuria, or gross and microhematuria, but this is merely a quantitative difference. So as we all know, macroscopic hematuria means visible blood in the urine. And this can be bright red or dark brown. And this depends on various things, such as urine acidity, source of the bleeding, amount of blood. Now, in general, we assume that the amount of 1 milliliter of blood in 1 liter of urine renders this urine bloody. On the other hand, microscopic hematuria shows no discoloration. We can detect it by microscopy or chemical analysis on a dipstick or dry chemistry. And the threshold for dipstick detection of hemoglobin or of red blood cells is 0.6 milligram hemoglobin per liter, or the equivalent amount of 5 red blood cells per microliter. And here you have the various shades of hematuria from bright red to dark brown. Now, what are the epidemiology and causes of macroscopic hematuria in children? The most commonly identified etiologies, as you all know, is bacterial UTI or cystitis, irritations of the meatus, or trauma to any part of the urinary tract or kidneys. But we also have to consider less common causes, and they are hemoglobinopathies, stone disease, inflammation of the glomerulus, malignancies, coagulopathies, or cystitis due to drugs, such as cyclophosphamide, or viral cystitis, such as adenovirus or BK virus. So when we differentiate between upper and lower urinary tract, we can make the following statements. So hematuria coming from the upper urinary tract, pathological conditions is usually painless, and the color is usually tea or cola colored. Hematuria originating from the lower tract, however, is often associated with pain, dysuria, bright red blood, and occasionally blood clots. So the clinical context can already help us to decide where the origin of the hematuria might be. And this nice diagram from a recent publication does this in a schematic way. It shows on the top the glomerular causes of hematuria with an example in this glass. And there are the usual suspects such as IgA nephropathy, thin basement membrane nephropathy, Alport syndrome, post-infectious glomerulonephritis, and so on. And among others, we also see physical stress, meaning exercise-induced hematuria. The cause of it is not so clear, but it's probably hemodynamic and changes in the structure of the functional function of the glomerular basement membrane and the glomerular barrier. And also some controversial entities such as loin pain hematuria syndrome. Now, if we look at the lower urinary tract, we can have strictures or stones, and we can have pathologies in the urinary bladder, such as radiation nephritis, cystitis, or stone disease again, or in the bladder itself, diverticular, or less frequently, certainly in children, prostata problems and in cancers. Now, if we look at, these were the glomerular reasons for hematuria. If we look at the non-glomerular causes, we have pathologies that affect either the vasculature of the kidney or the pelvis of the kidney. And we find the papillary necrosis, for example, which means the area of the tip of the medulla of the kidney, renal infarction or thrombosis, malformations of the vasculature in the kidney, or cysts. And among others is here listed nutcracker syndrome. We will discuss that a bit later. If we look at the upper and lower urinary tract, so we have to always consider a possibility of a tumor or trauma and infection that can affect any part of the urinary tract. So let's look a bit more in detail. We define isolated microscopic hematuria and differentiate it from mixed hematuria with proteinuria. In general, if there is hematuria associated with hematuria, we take it more seriously. However, microscopic or macroscopic hematuria may be sufficient, may constitute a sufficient big concern for further diagnostic. So isolated microscopic hematuria is found in up to 4% of children randomly examined. It is a higher number in adults, and in progressing age, advanced age, the number rises significantly, and this is probably due to the higher frequency of cancers and of prostata problems, at least in the male. Now, the prevalence of significant disease when we find microscopic hematuria is low. It's anywhere between less than 1% and 7%. So we realize that we have a small number of patients or a small number of people who have hematuria, microhematuria, and a very small number of those have significant disease. And the art of medicine is to find out those who deserve further workup or need further workup. So we all work with dipstick, and this is a dry chemistry, a certain reaction, oxidation reaction that is triggered by the hemoglobin, and that then leads to a color change, and in the color change is correlated with the amount of hemoglobin in the sample. Now, other oxidizing contaminants in the urine might, or cleaning agents might cause false positive reactions, so we have to differentiate that. And certainly in women and teenage girls, we have to consider menstrual contamination. The test is sensitive to free hemoglobin, but also measures myoglobin and needs a minimum of 5 intact RBC per microliter urine in order to be positive. And you all know the scales that we can see in dipsticks. So let's now look a little bit, how do we approach a patient who presents with hematuria? And when I talk about hematuria, it may be microhematuria or it may be macrohematuria. And in some instances, we have to differentiate. But in general, as I mentioned, it's a quantitative problem rather than a qualitative problem. So definitely, as always in medicine, history and clinical examination are key. And in this case, we rely on urinalysis, and if the dipstick and the microscopy are negative for blood despite color change that looks like blood, then we have to search for other causes for red or dark urine. And I will relate to that a bit later. If we find red blood cells and or hemoglobin, then we look at the morphology of the red blood cells. And this is not done in all the labs, but in principle, we can decide or differentiate between glomerular red blood cell changes and non-glomerular changes. And I will show you a picture of that. And if the dipstick shows blood only without red blood cells microscopically, provided the urine was not standing for hours, it's a fresh urine sample, then you may deal with pure hemoglobinuria or myoglobinuria. So here you see examples under phase contrast and bright field or normal microscopy, where you see these abnormal red blood cells, dysmorphic red blood cells, or acanthocytes, less easily recognized in bright field, and you have exactly the same field here. And you see normal red blood cells or isomorphic red blood cells in the lower panel, and this differentiates between glomerular origin and lower urinary tract origin. Now, the percentage of glomerular red blood cells is not very high. It may be between 5 and 15% or so. And here you see an example of a red blood cell cast that is pathognomonic for acute glomerulonephritis, particularly post-infectious glomerulonephritis. So if we find hematuria, we have to ask some questions. Is it an urgent problem? May it be a tumor or something threatening? Should we refer the patient to an expert? What expert? How quickly? Now, who is the expert for hematuria? Is it a nephrologist? Is it a urologist, hematologist, oncologist, surgeons, or all of the above? And what are the signs and symptoms, and maybe the history, that help us to decide how urgent the situation is and how we can arrive at a preliminary diagnosis? And what are necessary and or most cost-effective imaging studies? You already see that only a small percentage of those people who have hematuria have a significant pathology. So we have to be rational in what invasive or non-invasive methodologies we use for further workup. So when should we and where should we refer to? Most children with hematuria represent a medical condition, so not a surgical condition. And often pediatric nephrologists would be the correct address to refer these children. However, there are indications to involve a urologist, particularly if there are stones discovered, particularly when they are not being passed spontaneously, and the threshold is about 4 to 5 millimeter. Above that, the stone will obstruct the urinary tract. So how can we approach hematuria further? We should first of all document that this is a persistent hematuria. So we need at least 2 or 3 positive midstream clean catch voidings to establish, yes, this patient has hematuria, and this is not only a phenomenon that is transient. We can look at whether the urine becomes bloody in the beginning of the micturition, so initiation hematuria or termination hematuria. And this suggests whether the source of bleeding is the urethra or the bladder or prostatic urethra, if mainly in adults. And we have to obtain, as usual, a thorough medical history. So here are some history and reported symptoms and how they correlate with pathologies. So if there's fever, we think of a UTI. We think of maybe an autoimmune disease. If there's dysuria, we think of either hemorrhagic cystitis or again a UTI. We look whether there is flank or colicky pain, and then we think of obstruction, stones, blood clots. Sometimes a child or even an infant has sand in the diaper reported, and this could be an indication that there's hypercalciuria or hyperuricuria. If there was a recent infection, we think of post-infectious glomerulonephritis or of hemolytic uremic syndrome. And if there are extrarenal findings, such as arthralgia, rash, vasculitic rash, purpura, hearing loss, gastrointestinal disease, so we have a slew of other diagnoses that can lead to hematuria, such as lupus, ANCA-positive vasculitis, Schönlein-Purpura, Alport syndrome, distal renal tubular acidosis, which is often associated with hypercalciuria and sometimes with stones, or secondary hyperoxaluria, as in Crohn's disease. And then we have this entity of exercise-related hematuria. And we have to ask in the history whether there was any recent travel, from where does the patient originate? Is there, for example, endemic schistosoma hematobium, malaria, and so forth? And finally, is there a family history? So we look into the possibility of Alport syndrome, of adult polycystic kidney disease, or thin basement membrane nephropathy, if there are several generations of parents, grandparents who have hematuria. And particularly in predisposed populations, we have to rule out sickle cell trait or sickle cell disease as a cause of hematuria. Now, this is a busy slide, but it has a slightly different approach to coming to a diagnosis in hematuria. So the urinalysis again shows whether this might be, together with the other findings and the microscopy, whether it's glomerular hematuria or non-glomerular hematuria, so intact red blood cells, or whether we have a certain fraction of so-called glomerular red blood cells. And if that's the case, then we look at glomerular diseases and we have to investigate kidney function, complement abnormalities, maybe some serological markers for recent streptococcal infection, and we have to quantify, look for and quantify protein in the urine. And if we have then a difference in C3 particularly, if the C3 is consumed, it's low, we think of post-infectious glomerulonephritis or membranous glomerulonephritis, or we think of glomerulopathy, or we think of membranoproliferative glomerulonephritis or shunt nephritis. And if the C3 is normal, then we consider more IgA nephropathy, Alport syndrome, and post-immune glomerulonephritis. Now, these are isolated glomerular diseases, but we also have to think of multisystemic diseases. And again, if we look at C3 as a marker to differentiate the pathology and the possible origin of the disease, C3 low, C4 low, and few other markers, certainly, we can suspect lupus nephritis or hemolytic uremic syndrome, particularly atypical hemolytic uremic syndrome. And if the C3 is normal, it does not exclude atypical hemolytic uremic syndrome, but we have more to think of Schönlein-Henoch purpura or IgA vasculitis, various forms of hemolytic uremic syndrome, and ANCA-positive vasculitis. Now, let's look at some causes. So we have, as glomerular cause, and we went through this list more or less already before, this list of differential diagnosis. And if we let us help with some basic studies such as C3, such as other serological markers, we can quickly come to a presumptive diagnosis and then have to ask ourselves, does this situation merit a kidney biopsy? Now, non-glomerular cause, we have already discussed, is just summarized here. And those that are particular relevance are tumors. We have to look into further workup and into the familial history of, if we think of polycystic kidney diseases, or hemoglobininopathies and so forth. But we also have to think of vascular anomalies, and we have to think of medications. So particularly non-steroidal anti-inflammatory agents, anticoagulative drugs such as warfarin or warfarin overdose, heparin, cyclophosphamide, and so forth. Exercise and trauma we have already discussed. Particular of interest is catheterization or traumatic catheterization. So here we have possibility of differentiating non-glomerular hematuria. And there we can look at symptoms and suspected diagnoses, additional investigation, and the final diagnosis. So this gives us a roadmap how we can arrive at the diagnosis. And there we can look at dysuria, renal colics, pain or painless hematuria. We have to look whether there's a renal mass, and finally whether there's bleeding tendency, and that leads us to the diagnosis. And I don't repeat all of these parameters that we have already discussed, but for example, if you see that there is renal function disturbance, we think of it, then we have to look at the creatinine. If we think of hypercalciuria, the cause, we have to do quantitative urine collections for calcium, for oxalate, for uric acid, for cysteine, and for other parameters to gauge which of these metabolic anomalies causes either bloody urine or stones. And we can also, if we have a stone, we can send the stone to the lab and obtain a very exact diagnosis at the chemical basis. So what are then the indications for a kidney biopsy? And then we are really already in the hands of a nephrologist in patients with hematuria or acute glomerulonephritis. So this is quite an erratic or let's say arbitrary list, but it gives us an idea where we have to think seriously of a kidney biopsy. So if there is, with the hematuria or hematuria and proteinuria associated severe and progressive kidney injury or kidney failure, then we have to get a biopsy histological diagnosis. If there's hypertension that lasts for more than a week or for several days, then we should also consider a kidney biopsy. Gross hematuria for more than 3 or 4 weeks needs further workup. if the hematuria is associated with nephrotic range proteinuria that persists, we have to do a kidney biopsy. Now, we differentiate here normal C3 at the presentation in order not to biopsy everybody who has a acute post-infectious glomerulonephritis, because this is a usually benign disease and the C3 will normalize within 8 to 12 weeks, and then a biopsy is not necessary. But if the low C3 continues, we have to think more of membranoproliferative disease and other glomerulonephritides, and this requires a kidney biopsy. And if you have systemic features that suggest an autoimmune disease that affects the kidney, we have to do a kidney biopsy, such as lupus, ANCA-positive vasculitis, if we see arthralgia, heart disease, and so forth. So now let's briefly think about malignancy. This is the big worry in the background, and admittedly, it's quite rare in children. So the number of the incidence of renal tumors in children is 8 per 1 million target population. So that's really rare. Now, on the other hand, renal tumors account for 7% of all childhood cancer. So it's not completely negligible. The interesting thing is that the specific renal tumor is tightly age-related. So there is some tumors that occur during the first year of life, and these are usually congenital abnormalities, such as rhabdoid tumor of the kidney and so forth. And we have clear cell sarcoma in young children. Most patients with Wilms tumor are less than 5 years old.
You've got 5 minutes more, Dr. Martin.
Yes?
You've got 5 minutes more.
Okay. And adolescents have different type of tumors. And as you know, Wilms tumor is the most frequent tumor. The incidence is 1 case per 10,000 population. I don't want to go in all the details, but usually we have heterogeneous mass, and we have sometimes a detectable mutation in genes in this tumor tissue. And here you see some images of tumor by ultrasound and by CT scan. And here's another form of a renal cell carcinoma that's quite prominent here in the middle of the kidney or peripherally. And this page is what is important is that this tumor can cause hematuria, and therefore in the differential diagnosis of our topic. Then are the rare and debated causes such as Nutcracker syndrome and low hematuria. And we have indeed hematuria in newborns. And there we have to think of renal venous thrombosis, renal arteries thrombosis, autosomal recessive polycystic kidney disease, and clotting disorders, for example, and UTI. And we have non-hematuria red urine. And these are some of the suspects, so drugs, colors from vegetables or fruits, and they have to be differentiated from real hematuria. So I don't have much time for the vignettes, and I will skip this here, briefly mention G6PD deficiency because it's relatively frequent in the Middle East. It affects about 7.5% of the world population. Usually the acute hemolysis is self-limited, and it affects mainly the old red blood cells. And it can triggered, as you know, by various oxidizing agents. And we have hemolytic uremic syndrome that is often presents with gross hematuria and is associated with significant pathology in the glomerulus. Now, there are familial forms, and one of them is Alport syndrome. And I only want to highlight that this is a disease that's due to collagen gene mutation and different because it's X-linked. It shows up very differently in females and males. However, we learn more and more that females can be affected and that there are different forms. There's X-linked, there's autosomal dominant and autosomal recessive forms. So Alport syndrome has to be looked for in females as well. And here's a nice case that has been published in 2021 in pediatric nephrology. And this group in California was really puzzled by the patient, and it took them a long time to get the diagnosis, and they were very honest in how they reported it. So it's a question and answer session, and they present a case with flank pain and gross hematuria. And this is the history, 13 years old, has dark colored urine, is repeatedly examined in the emergency room and then by nephrologists, and finally transferred or referred to urology, and they did some cystoscopy and found blood oozing from the left ureteral orifice. Concern for pseudoaneurysm, left angiography was normal, and then the patient still had concerns, came back, and an abdominal MRI was done for surveillance of the cystic lesion that had been seen by ultrasound earlier. And here's the answer to this case. The MRI showed that the previous cystic lesions had more than doubled in size, and the images is now concerning for rapidly growing malignancy. And finally, the histology shows malignant rhabdoid tumor. And this images here from MRI in the interval between initially and then 3 months later, you see the tumors here and even the right side. I'm mentioning this because it's quite instructive how all the usual steps are being done and the diagnosis escaped the physicians. And then there is an entity that's called left renal vein entrapment or nutcracker syndrome. And what you just see here, you see the kidney on the left side, you see the renal vein which is engorged, you see the aorta, and between aorta and mesenteric artery, there's very little space, and that traps the outflow of the renal vein into the vena cava, and that can cause hematuria and pain. And this is shown here in the image where you see the aorta.
2 minutes, Dr. Martin.
And
2 minutes.
I'm coming to the end, and we'll then come to the red flags. So in conclusion, hematuria is associated, and that constitutes a red flag if there's persistent proteinuria present, if there's thrombocytopenia, generalized symptoms, fever, colicky pain or hypertension, and abdominal mass or bruit, or if there's a family history for chronic kidney disease. And we should not over-investigate. And so hematuria can be transient, it can be no other symptoms, it can be just due to exercise, there may be no proteinuria, and the family history would be unremarked in these cases. Thank you very much, and thank you for the discussion.
Thank you, Dr. Martin. Now I'll leave the floor to the moderators to introduce the next speaker or the panel.
Thank you, Dr. Rahman. It's my pleasure to invite two eminent pediatric nephrologists, Dr. Intisar Al-Hamadi, who is a consultant pediatric nephrologist at Dubai Hospital, and Dr. Loai Eid, who's a consultant pediatric nephrologist, Division Chief, Dubai Hospital. Please join us for this panel discussion. Dr. Martin has very nicely, with the help of beautiful slides, explained to us how to approach a case of hematuria and the important causes. Dr. Intisar and Dr. Loai will join us now. Dr. Intisar, are you online?
Yes, I am. Good morning, everybody. Thank you, Dr. Khadna, and the organizing committee or team to invite us in this meeting. I enjoyed Dr. Martin's detailed lecture. It set up the stage to the discussion, I guess. And I think Dr. I will start. Or should I start?
Doctor. Yes, doctor, you should start. Yeah.
I should start? Okay. So I put only a couple of slides of cases because I think we'll leave the time more for the discussion, more than me presenting the data. We just want to trigger more discussion in this session, what I understood. So you can see my slides?
Yeah, doctor, can you go to the slideshow mode?
Sure. It's not moving there, but I kind of maximized the slide. It's only a couple of slides.
Yes, doctor, go ahead.
So the first case is an 80-year-old male previously presented, and I put a couple of cases only, which is, I think, a bit common to be seen by pediatrician, either as an outpatient setup or as an hospital or emergency setup. So you've seen an 80-year-old male, previously healthy, present to emergency with headaches, for 1 day. And then the blood pressure in the emergency was 140/90. Further history revealed a 3 days history of not feeling well, passing brown color urine, but he did not really notify his family with it, just they brought him because of the headache. So what more information you would like to know about this case, what investigation you would do, and then what will be your differential diagnosis. So in these cases, I think I'll just present the cases and then we will leave it later for the discussion because I want it to be more interactive with the people. So I'll move to the next one and then we will be referring to both cases during the discussion. The second one is a 1-year-old female, again, previously healthy, present with a red color urine and irritability for 2 days. The family was not well, was worried a bit about the irritability, but there were no fever, they did not bring her. Then when she started to have red color urine, they brought her to the emergency. To the family doctor who requested an ultrasound and a urine analysis and culture. So the family was not able to collect the urine. She's 1 year old, they put the bag, keep slipping, right? The common scenario. But they proceeded with the ultrasound, which showed bilateral renal stones, multiple stones, each is 4, or the maximum was 5 millimeters in diameter. So what more information would you know? So the family doctor called you as a pediatrician or as a nephrologist and asked, okay, what should I ask more? What should I do more? And what would be my differential diagnosis at this point? So I wanted really to leave it more for a discussion. So we can, Dr. Kadna, if you can see the chat box, or shall I see it to see if people are interacting with us?
Yes, Doctor, that is one limitation of a virtual platform. What I suggest is that we move on to Dr. Loai's presentation and then we take up these cases during the panel discussion.
Okay,
is that okay?
Yeah. Sure.
Thank you. Thank you so much. You have highlighted 2 broad categories of causes of hematuria that a general pediatrician has to think about. Now I invite Dr. Loai. Dr. Loai, are you online?
Hello, yes.
Good morning, Dr. Loai. You can go ahead and present your cases, doctor.
Yeah, give me a minute because actually I'm driving because I am on call and I have a case I need to do. But I want from you, please, Dr. Kalbana, if you can just move my slides, share it and move it.
Sure.
Okay.
Mr. Taufik, can you project Dr. Loai's slides?
I will do.
Thank you.
Just Dr. Loai, be careful while you are driving.
Yeah.
Today is Friday, 28th May.
Okay. Can you go back a little bit, please? I'll just tell you when to move. Okay. One small slide, so I will just tell the people. It's clear for my voice? Yeah.
Yes, doctor.
Okay. Yeah, so good morning, everyone. Thanks for the invitation, and I really appreciate to be part of this conference very early. And thanks for the people who's attending. Thanks, Martin and Difar, for your thorough presentation. So I thought actually about just giving case scenarios and the way to test the people how much they retain from Martin's talk. I know the interaction is difficult here, but I will give 10 to 15 seconds for each question, which I will go through 4 scenarios. Before I start, I just want to announce that we are hosting the 15th Asian Congress of Pediatric Nephrology in Dubai on 2023 November 22nd to 25th. And this is the first time this Congress is happening in this area and the region. We are glad to win the bid with the help of all the colleagues across the UAE. This will be a very good Congress for the general pediatrician as well as the pediatric nephrologist in the area. Include multiple topics of interest like UTI, VOR, and others, which a lot of the general pediatrician is interested in. So keep an eye for the registration and the website, which will be coming soon, inshallah. So can you move to the next slide, please? Okay. So case number 1, actually, it's in a 2-week-old male newborn. Parents report that the diaper is occasionally stained red-brown. You can just click one time so the audience will see the diaper, please. Can you move? Yes. So this is the color of the diaper where the mother is reporting this is happening frequently, especially early in the morning. They are concerned that he has blood in his urine. You reassure the parents with the suggestion that the probability he has uric acid crystals in the urine and increasing fluid intake would be helpful. This is very common complaint, especially in a neonatal period, even during the infancy, and I'm sure that a lot of you came across that. 6 weeks later, the patient returned with symptoms that the infant was irritable and that the red-brown staining of the diaper has persisted. Urine analysis of a bagged urine specimen show no protein or blood. Centrifusion of 10 ml of the urine shows a large amount of brownish red sediment. Just move it, please, so they can see. Yeah. This is after centrifusion. This is actually a rare case. Microscopic analysis showed uric acid crystal in the sediments. You should obtain the following investigation. I'll just leave 15 seconds for the audience to think about it before I move. So whether you have to only to do spot uric acid and creatinine, do 24-hour urine collection of uric acid, or request an ultrasound, spot uric acid and creatinine. Okay, I see people are interacting, good. Okay, so, okay, can you move, please? Yeah, this is the microscopic analysis, rhomboid cells, which very characteristic for crystals of uric acid. Okay, another. Just move for the answer, please. Yes. So most of the audience are right. We need to investigate further. It's not simple urate crystals that happen in a newborn. So sending for analysis of the spot urine creatinine, and we have to request for an ultrasound. All of you know that it's difficult for the infants to collect 24-hour urine. So in pediatric nephrology, we are depending on spot urine, which more or less correlate with the result. Next, please. So red diaper in neonates in the first weeks of life is often caused by uric acid crystals. Urine test is negative for hemoglobin, which is very important, and I'm sure Dr. Martin highlighted that, how to test for it. This is a benign and self-limited finding, and no therapy is usually required. Subtle hydration, dehydration, and elevated uric acid in the urine should be the cause for that. Next, please.
Dr. Luay, you've got another 5 minutes to go.
Okay. Yeah. Next, please. So this is what I want to highlight. There is another severe condition which called Disney-Hand syndrome. In contrast, is a rare X-linked recessive disorder that's characterized by persistent gritty orange red discoloration of the diaper with eventual uric acid stone. These patients have self-mutilating behavior, developmental delay, and poor muscle tone. Hyperuricemia and hyperuricosuria are present on lab, and it's caused by deficiency of the enzyme hypoxanthine guanine phospholipase transferase. So be careful about this and don't just take it lightly as a red diaper in the neonate. Next, please. So this is what we published actually during my fellowship and about that case. Next, please. So case number 2, 11. So in each cases, I'm trying just to deliver 1 or 2 messages to the general pediatrician. I'm not trying to approach which Dr. Martin did for hematuria. 11-year-old boy developed pink brown urine following an upper respiratory tract infection. Result of the cystoscopy performed in the community hospital were completely normal. His symptoms resolved in about 1 week. 6 months later, he again developed fever, nasal stuffiness, and sore throat, and visible hematuria 2 days later. Okay, he was seen in a local emergency department. Urine analysis showed +3 proteinuria, large blood +4, and numerous red blood cells cast in the microscopic examination of the sediment. So mostly it's a glomerulonephritis with a proteinuria and dysmorphic RBCs. Serum creatinine is high, 1.5. BUN also high, 39 milligram per deciliter. Normal electrolyte, ASO titer. Normal C3 and C4. ANA negative. So the least likely diagnosis here is also 15 seconds. Post-strep glomerulonephritis, IgA nephropathy, thin basement membrane nephropathy, Albert syndrome. Okay, move next, please. Good. Most of you got the correct answer. It's post glomerulonephritis because C3 and C4 are normal. So next slide, please.
Dr. Ali, 2 minutes, please.
Yeah, move, please. Next. Okay, so this is very important. I just want to let the general pediatrician know that this is the course of the development of post-infectious glomerulonephritis. Very important, microscopic hematuria is persistent up to 1 year. So be careful not to over-investigate if the persistent hematuria is still there. Next, please. So 10-year-old patient has 5-day history of gross hematuria and low edema. The blood pressure is high, 135/85. Investigation revealed urine protein creatinine excretion is 1.5 gram per 24 hours with serum C3 level or low. So most likely differential diagnosis in this patient include all of the following except. I think Dr. Martin highlighted that. So next, please. So tubulointerstitial nephritis will have normal complement, while other like post-infectious lupus nephritis and C3 glomerulonephritis is having low C3. So this complement investigation is very important to differentiate between different causes of glomerulonephritis. Next, please. Next, please. This is we highlighted. Okay, case 4, a 6-year-old male has history of recurrent episode of tea-colored urine with persistent microscopic hematuria in between, usually 1 to 3 days after upper respiratory tract infection. Urine analysis show many dysmorphic RBCs with cast, protein +1, and serum creatinine is 0.7. So what is next? Move, please.
Dr. Aid, I'm sorry, I have to stop you here to give enough time for the discussions and the other panelists.
Yeah, give me one, because this is part of the discussion, Dr.
Sure,
just
sure.
give it. Yeah,
I
just
think
one.
we will let him just highlight the important points in his cases because that is base work for his discussion. So yeah.
Yeah. Okay. So what are the possible causes of hematuria? Next, please. So sympharyngitic cross hematuria can be seen. Sympharyngitic meaning that it's associated with upper respiratory tract infection. So it's either IgA nephropathy, then thin basement membrane disease, or Albert syndrome, or all of the above. So just to keep in mind, it's not only Berger disease or IgA nephropathy who has associated gross hematuria with the upper respiratory tract infection. Thin basement membrane disease and IgA nephropathy also can present. Next, please. So all of the above. Next. Next, please. So this is the last case. An 8-year-old male has asymptomatic microscopic hematuria. He has no family history of neurosensory deafness or CKD. His father is known to have microscopic hematuria without any renal impairment. Benign familial hematuria is suspected, which is again the different name of thin basement membrane disease. Which one of the following is true of this condition? Proteinuria is common. It is usually inherited as autosomal recessive. In young children, renal histopathological finding may be indistinguishable from those of Albert disease. In this stage, renal disease is known to occur. So what is the true about thin basement membrane disease of benign familial hematuria? Okay, next please. So basically, yes. So it's very difficult initially, even if we are doing a neural biopsy, to differentiate between Albert syndrome and thin basement membrane disease. Genetic investigation will differentiate between both. Next, please. So thin basement membrane disease, it's happening in 1 to 2% of the population, affecting different family members. It's autosomal dominant heterozygous mutation in the collagen type 4, A3, or A4. Clinical presentation usually persistent microscopic hematuria, asymptomatic. Usually there is no proteinuria or extrarenal manifestation like sensory neuronal hearing loss or ocular abnormalities, which usually happen in Albert syndrome. Diagnosis usually by lab with family history, and by biopsy you see diffuse attenuation of the glomerular basement membrane, and we need definitely the biopsy for the definitive diagnosis. Treatment not required, and it's benign course. Last slide, please. Yeah, this is just when to refer for a pediatric nephrologist, which
we can take this up during the discussion.
Yes, highlighted. Yeah, thank you.
Thank you, Dr. Loai. And now I request Dr. Martin, Dr. Intisar, and Dr. Loai to join us in the panel discussion with Dr. Ayman and Dr. Diari. So I thank the speakers for this very nice presentation, and they have stimulated the audience to take part in the virtual conference, though it is a little bit, it's time consuming. So let's move on to the question and answer sessions. Dr. Diari, can you take the first question?
Yeah, sure. Thank you, Dr. Martin, Dr. Intisar, and Dr. Loai for this nice presentation. Dr. Martin, are you with us?
I am with you.
Yeah. So good morning.
Good
yeah.
morning.
So there is a couple of questions from Dr. Nelish. Good morning. Is tonsillectomy for children having recurrent hematuria? So is there any relation between tonsillectomy and hematuria?
Okay, I think this is a question we all three should comment on it, because it remains to be somewhat controversial. Data mainly published, I think, from Japan, and these authors claim that it reduces the frequency of episodes, maybe the occurrence or the severity of IgA nephropathy. This is not, as to my knowledge, really reproduced in many other countries. And depending on the age and other reasons to remove the tonsils, it is rarely, in my opinion, indicated. But there are cases where we would remove the tonsils due to frequent infections, and then we can indeed reduce the number of episodes of sympharyngitic IgA hematuria. But it will probably not have an effect on the long-term outcome of a small fraction of IgA nephropathy who have a bad course. but I would like to invite the comments of my colleagues.
Yeah, I agree with you, Dr. Martin. I think it was published mainly from Japan or the Far East because it is more common to see IgA nephropathy in that population. So they do have the largest cohort compared to the rest of the world. And they do believe that it will reduce. And according to their data, it did reduce. But as I stress on the same point you mentioned, that it did not show that the end results or preventing developing chronic kidney disease or end-stage renal disease or any kind of renal impairment would be prevented by doing this.
Yeah. So yeah, basically, I agree with both of you. Only thing which I can add that we should not consider it as an absolute indication to do a tonsillectomy or nephrectomy just to correct the microscopic hematuria, unless it's really indicated from like ENT perspective or a general pediatrician perspective, like the child has recurrent tonsillitis more than 6 times, affecting his hearing with the fluid, otitis media, and others. Then definitely we can go ahead and do it, but it's not always should be connected or correlated with the improving or resolving of the hematuria.
Thank you.
So since we are on the topic of IgA nephropathy, I just would like a comment from Dr. Martin as to how frequently do we see IgA nephropathy presenting as hematuria? Number 2, what is the prognosis normally in these cases? And if you can just let us know, general pediatricians would be interested.
Thank you for the question. It is one of the more frequent glomerulonephritides in the overall group of the rare disease of chronic glomerulonephritis or chronic glomerulopathy. The exact numbers escape me at the moment. There are certainly epidemiological data, but there are regional differences. And it was initially described by a doctor in France, Berger, who already had the name Berger disease, coined for this disease as benign glomerulonephritis or benign hematuria. It is not so benign, we have learned. As a ballpark number, I would say 2/3 do quite well, but for 1/3, we have to be careful following and treating. Now, the optimal treatment is still controversial, but if there is changes in the kidney biopsy, particularly if there is necrotizing changes, which means crescents, and if there is rising creatinine, then this needs aggressive treatment that can include various immunosuppressives, ACE inhibitor or ARB, and symptomatic treatment. But the majority of patients would not deserve aggressive treatment. But again, I would like to invite my colleagues to their experience and their state.
Yes, and the local incidence as well, Dr. Entisar. Do you see this as a common cause?
Yeah, I would say I see it, but I'm a nephrologist. Again, I'm more biased toward how much I see. And Dr. Rai can add to that also. So I don't think we have a local data about it. But I want to stress on one extra point on the IgA nephropathy, which is more common to be seen by a pediatrician, is the HSP. So children with HSP, their pathology, if they develop an hematuria or renal impairment, the histopathological finding on the kidney biopsy will be IgA nephropathy. So those patients, we have to be more careful and more keen toward doing a biopsy, especially if we have a nephrotic range proteinuria, if we have any kind of renal impairment, persistent hypertension, then as the indication Dr. Martin referred to for a kidney biopsy, those patients are more toward earlier referral because we do unfortunately till now see cases managed with a short course of the steroid by the pediatrician and then left for months and months with a persistent proteinuria without being biopsied or treatment, because we know in those patients, if we treat early, the outcome is better. Because if you refer late, those patients, they might come with interstitial fibrosis and a permanent renal damage already, which we cannot reverse by using either the steroid or the other immunosuppressant. Depends on what's the histological finding for those patients, because there is criteria and there is classification, the actual classification for those patients in regards of how to manage them and what's the expected outcome for those patients.
Absolutely. Thank you, Dr. Intisar, for bringing out this important topic that HSP is not just a transient phenomena, multisystemic disease we see with some rashes and abdominal pain. First and foremost, look for the renal involvement, and then if significant, definitely requires a referral to pediatric nephrologist for further follow-up and workup.
May I add
one more?
Oh, sorry. Yes, Dr. Loai.
Yeah. So regarding also the HSP here, I saw many cases who referred later to us to started on steroid. So keep a very high threshold for starting steroid by general pediatrician because it could mask the picture. Ideally, sometimes we don't see kidney involvement initially with the presentation. It can happen up to 6 months after the first presentation. So do not just keep the patient or start steroid just because of minimal pain or some rashes or just to relieve the symptoms, because this can mask the picture. Back to the IgA nephropathy, I did not see a lot from Emirati people, but I saw 2 cases which I can tell my experience about it. Basically, they have a severe disease, which is meaning that nephrotic range proteinuria and progressive glomerulonephritis, which again can highlight that in different than Asian population, usually the IgA presentation could be very severe, not like other, which is in a benign course.
Definitely.
Thank you. Just to conclude, maybe for IgA nephropathy, there are 2 major risk factors, and these cases have to be treated seriously if the creatinine is elevated at presentation and if there's a large proteinuria and nephrotic range proteinuria. The others do much better. So this could be a good screening way for and prognostication for a patient.
Going back to the questions, can dehydration alone be the cause of hematuria? Dehydration alone?
Yes, I mean, if it's the child is dehydrated and there is a concentrated urine, this is, I don't know, I did not follow all the Martin's presentation, but this could be false positive result. So to diagnose persistent microscopic hematuria, we need to repeat the urine sample twice in 1 week or 2 weeks to make sure that it's persistent when the child is well hydrated. After that, we can label it as persistent microscopic hematuria.
I agree with Dr. Loai, but there's one aspect we should not forget. The medulla, the deep medulla, is poorly perfused. And if somebody has volume depletion and dehydration, we may end up with poor perfusion of the kidney injury, and also with hematuria in these cases. And particularly if the patient has sickle cell disease, then it becomes quite a toxic mix.
Yeah. And one extra point, which is very rare to be seen nowadays, as Dr. Martin and Dr. Loai said, so microscopic hematuria might appear, but again, as Dr. Loai said, we have to follow over the next 2 weeks and see if it will persist or not. The only thing which is rare, that if they come with a gross hematuria and loin pain after a dehydration, then you should think of thrombosis to the kidneys, which is extremely rare. And usually associated with other things, not a straightforward dehydration, and that's it.
Yeah. There are a couple of questions on stones. So I don't know if the panelists are willing to answer the questions about stone, because I feel stone is really needs a full day of talk.
Yes, doctor, but it is important to discuss, because I think the number of questions only show that we are seeing these cases more commonly, and hence people want to know that if they come across such a case, what is the approach in short?
So, Dr. Ziar, yeah, one of my interests actually is renal stone in kids, and we have a large data which, inshallah, will be published soon.
I'm supporting you. I don't want in 2 minutes to finalize the stone. It needs 1 day, full day. So go ahead and in brief, please.
Red flags.
Yeah, please. Go ahead.
Dr. Loai, did you want to finish?
You want to start?
I don't know. What is the question? What is the question? There is 2 questions.
So, actually, may I suggest, there's a good suggestion by Dr. Manoj that can we discuss the cases presented by Dr. Intisar? In fact, your second slide, Doctor, so can we take it from there? Take that as the base and go ahead.
Sure. So the
15
case,
years.
again, to remind you, it's a 1-year-old, previously so-called healthy child, female who presented with 2 days of irritability and then had gross hematuria or discoloration of the urine. Family brought her. They could not collect there were no fever. They could not collect the urine. Inflammatory marker was unremarkable. Renal function was good. They did the ultrasound and they showed the bilateral kidney stones. So in these cases, we do see that. So stones, I would say stones is always alarming in kids. You should not take it lightly and say this is common. The younger they are, the more alarming the more alarmed you should be about the stone, because you should think: is it metabolic? Is it something genetic? Is it something related to infection? It can be, okay, or predisposing to infection, because we know it's more of a cycle. If you have a recurrent infection, you have more chances to have stones, or the other way around. If you have stones, you would have more chances of infection. And we should always think, we know in kids, metabolic and genetic factors would increase your chances. So a common one we see very common in our clinics, premature babies who are born and survived and did well in their 24, 20, 30 weeks and so stayed in the NICU and then referred to us with nephrocalcinosis, usually bilateral, usually related to prematurity. It resolved, and very rarely we require to give any treatment. Some of those will have high calcium in the urine, so we check the calcium creatinine ratio, and there is a table which is age-related for kids. And then we follow that. And some of them will require some alkylating agent just to dissolve those nephrocalcinosis. Some of them will require hydrochlorothiazide to reduce the amount of hypercalciuria. But if I see a child who is 1-year-old with multiple stones, even with a normal kidney function, I would dig more in the history, especially the family history. So if the mother telling me, yes, they are related, they have a family history of children with a kidney stone who died in a different country. And we know our population is a very mixed population. So we have always to consider the background for those patients, because we know some genetic diseases are more common in a specific population in the world. So in this child, I would be very keen to rule out primary hyperoxaluria in a normal child, even with a normal kidney function, because of coming with a multiple stone, with a full-term baby was well, and then suddenly coming with a stone, I would be very keen. So the baseline, I would do the kidney function. The baseline, I would do the urine calcium, urine creatinine, oxalate. Those the basic thing I would do. And if the urine oxalate is high, I would proceed with the serum oxalate. And if that is high, I would proceed with the genetic testing to know if this child has any, is it primary hyperoxaluria or just higher oxalate in the urine. So approaching those cases is very important, because we know that earlier diagnosis would carry a better outcome. And a few months ago, we got a gene therapy also approved for type 1 primary hyperoxaluria, which was not available, let's say 1 year ago, which will totally change the outcome for those kids. So approaching stones in infant is very, let's say we should take it on an urgent matter. We should not take it lightly and keep following those kids, compared with a child who is, or a teenager coming to me with a one single kidney stone, who's a 14, 15-year-old, came with abdominal pain, renal colic kind of picture, went to the emergency, had an ultrasound, showed stone. That child wouldn't take it as an urgent as a young child who came with a stone, because the older one might have, like when you approach an adult with a stone compared to an infant who's coming with a stone.
So basically, the younger the child, more are the chances of metabolic abnormalities, and we should do the workup. Yeah.
So, yeah, Dr. Diar, you are absolutely right. Thanks for supporting us. But like it's very hot topic in this area, especially. Our area has a high marriage, consequence marriage, plus genetic causes. Actually, they called Iran, Pakistan, and Afghanistan as a stone belt, actually, because it's very pandemic in that area. One thing just to add to Intisar's point, the younger, yes, it's high, alarming, but we need to differentiate between nephrocalcinosis and renal calculi. So it's two different entities, not for the same. Actually, if there is a risk factor as prematurity, there is explanation. But if it's bilateral, then it's more of systemic disease than unilateral renal calculi, which could be simply as like a BUJ obstruction or others.
To comment on this, so I agree with my colleagues. We are obviously living in a belt for hyperoxaluria type 1, and these babies can present at the age of 6 months with end-stage renal disease and crash and have severe disease and need dialysis immediately. In your case, Dr. Entisar, I would also, in the differential diagnosis, at least in other countries, look at cystinuria as a possibility, which is also genetic disease, metabolic, and
fairly rare in this region, but yes.
Exactly. What I would like to emphasize is, if as Dr. Entisar said, that it's to be taken seriously, but we need a complete workup and a competent workup, which is a panel of urine studies and in comparison with serum studies and genetic studies. Today we have wonderful possibilities to have panel screens for all the possible known and described stone diseases, and in young children this is really the way to go if insurance or parents can afford it. And we have now, even in the UAE, very good labs to do genetic studies.
Yeah, Dr. Martin, just one thing I will not, nice presentation, but I will not agree that the only stones as a urologist has to see for hematuria. We saw a bladder polyp, we see a urethral polyp, you see a very simple meatal stenosis in kids post-circumcision, and this, they presented with terminal hematuria. We saw these cases. And we saw a couple of cases, maybe Dr. Entisar and Dr. Loay also aware with us, how you diagnose eosinophilic cystitis, which they are presenting isolated in the blood film, there is no eosinophilia, but we see a couple of cases, or we saw a couple of cases with eosinophilic cystitis presented with hematuria. How you approach these cases?
That is a very specific question. I did not want to diminish the task of urologists in invasive in cystoscopic diagnosis. Very important. But what we unfortunately see, if this is an adult urologist, that the first thing they may do or propose is a cystoscopy in somebody else's hematuria. And there we have
two surgeons here.
We definitely need your help for many of these cases. And my examples of malignant disease, there we definitely need you for various stages for the diagnostic and for the treatment, for the surgery. Right. So, well taken. In terms of eosinophilic cystitis, I'm not completely aware of the entity. I've seen this described in the context of urinary tract tumor, but as an entity such as eosinophilic gastroenteritis or gastritis or esophagitis, I'm not aware of that. So you have to educate us.
Actually, there were a couple of cases we shared with our colleagues, Dr. Entisar and Dr. Loay. And maybe the only diagnosis is a deep biopsy.
So next, I think it's a diagnosis of exclusion, Dr. Diari, more than, and as you said, it's a biopsy, like when it affects the gut. I can't recall seeing any of those cases. I'm not sure if maybe it was Loay's patient, but I would think it's a diagnosis of exclusion. And as you just mentioned, it needs a biopsy because you will be never able to diagnose it without it.
Yeah, because even the blood film will be normal eosinophilia.
Yes.
Just a question, Dr. Diari. What was the indication for cystoscopy in these patients? Was there recurrent hematuria? Was it persistent? I mean, that the cases where you found eosinophilic cystitis to be the cause.
As just Dr. Entisar mentioned, it is an exclusion. Then at the end, you have to do something to do cystoscopy to see if there is any local, let's say, local pathology. And most of the time, by ultrasound, they can see the bladder wall is really very thickened. Sometimes it is universal, sometimes it is localized. And a deep biopsy, either by trocar biopsy or open biopsy, sometimes then you will reach. We were having these cases, and we started with a steroid for a period of time, and they respond nicely.
Sometimes.
So what Dr. Kalpana wanted to know is, presented with hematuria or with dysuria, did they present similar to interstitial nephritis, which can also invoke urine with eosinophils?
Exactly.
Or biopsy with eosinophils. I don't know whether it's an extension of that disease or whether it's something different. So what prompted you to indeed evaluate them further in the beginning?
Because of all the nephrologists, let's say there was no diagnosis for the nephrologist to refer to do something with us, to see the cystoscopy, to see if there is any local pathology or anything. And by ultrasound, we found that there is and thickening. Maybe it is an interstitial cystitis, but to have a local thickening of the bladder wall, this is also some indication of eosinophilic cystitis.
Moving forward, Dr. Entisar, can we have your first case now and the discussion on that?
So the first case is a very common case. Okay, so a previously healthy 8-year-old male who came to the emergency with discoloration, with headaches, basically. And then the blood pressure in the emergency was 140/90. Then the history revealed that there is a 3 days history of discolored brown color urine at home, which the child did not tell or disclose to the family prior to coming to the emergency. So this is a fairly common case. So can be seen in the clinic, can be seen anywhere. I want to stress the first thing on the point of checking the blood pressure. Unfortunately, we have a lot of kids coming to the, going to the pediatrician or a family physician and never check their blood pressure. And an 8-year-old coming with headache, this is a direct indication to check the blood pressure. And unfortunately, last week, I've seen a child who was an 8-year-old female who presented to 2 different hospitals before coming to us with headaches for a week. And the blood pressure was never checked up till when the family brought her to the emergency with the status epilepticus because of the headache. So, and then ultimately she had a tumor. Anyway, the end result was not the point. The point is that checking the blood pressure in a child who's coming with a headache should be done. And I want to stress on that point. And then we need to remember that in headaches, there is tables to refer to what's a normal blood pressure for related with the size of the child, mean the height of the child, the gender of the child. And then we go, and here I'm not, the headaches topic is by itself is a big topic.
Sure.
But the idea is to check the blood pressure. There is alarming sign. There is a lot of online tables to tell you what is the alarming blood pressure for an age of a child. And if it is high, then there is always a reason, okay? Especially if the child was not in pain, there is nothing to explain why the blood pressure is high. Then this child, for example, we'll go back to the case, an 8-year-old, you did the urine showed the 2+ protein, showed hematuria, numerous RBCs, okay? The bustle were 0 to 2. So this child would warrant doing a kidney function, would warrant doing a complement and an SO titer, because the top differential for this case would be a post-infectious GN. And sometimes in the history, you would get a strep infection or a throat infection or a skin infection 2-3 weeks back, or not always you will get that history. We know the history is not always clear. So your differential diagnosis will lead your investigation. So in that case, it was a post-infectious GN, C3, as Dr. Martin talked about. C3 was low, C4 was normal, ASO titer was, let's say, 800. The child, the renal function was good. They sent the urine protein creatinine ratio and it was non-nephrotic. It was 1.5 milligram per milligram. So this is a post-infectious. So here will come the second question, which we get very commonly from the pediatrician. How should I manage this hypertension? Should I treat anything for this child? So those patients will warrant, so if we go systematic, those patients most likely will require an admission because we don't know how things could progress in the next few days. So you need to keep an eye on the blood pressure. We know in blood pressure overall, we don't usually use diuretics, but in those specific category of patient, we know that the high blood pressure is related to fluid retention. So we need to give them diuretics, and usually that will manage their blood pressure. If that doesn't manage their blood pressure, then we escalate to the calcium channel blocker or beta blocker or even AC inhibitor. But first, we always start with diuretics for those patients. We monitor their kidney function over the next few days. it might get worse, or it might be majority of the cases it won't affect the kidney function. And even
5 minutes left for the nephrology session. Thank you.
okay, so I'll stop here. Maybe my other colleague want to add.
So the point well taken that blood pressure should be monitored. Just a suggestion to the pediatricians, when indicated in the clinical scenarios, when indicated, we should do it. But even otherwise, if say, for example, a child comes for the second booster vaccination, if we just take a blood, because younger children, it's really not very easy to check blood pressure or to get the correct reading. But at least at the time of second booster, if we make it a routine, just a screening, it would help. And my question to Dr. Martin, related to the blood pressure, do you see white coat hypertension in children? We have come across these cases wherein, you know, when they come to the clinic very high, and when they are monitoring at home, they bring back readings which are pretty normal. When they come back to us again, it is high, especially in adolescents. So have you seen this?
You exactly described the phenomenon. Yes, the international data show in children, it is about 15% of white coat hypertension, and you also have the opposite of masked hypertension that is not apparent in the clinic, but you can figure it out by ambulatory blood pressure monitoring. It's again about 10 to 12% in bigger statistics. Yes, this is a phenomenon, but there is a challenge to have a young child measure the blood pressure reliably, and you can actually end up having false hypertension. So there is a limit. I don't know whether it's 3 years or so where it's very challenging to get blood pressure, but we have to always think of this possibility and invest time to obtain it if there's any other red flag that we need to do it. So hematuria could be a good reason to check the blood pressure.
I think we have only a couple of minutes left. So can we take this opportunity to ask each panelist just in one sentence to tell us what is the most important thing that you would keep in mind, you know, as per the topic of hematuria? It's a vast topic. What is your message to the pediatrician? Yeah. Maybe Dr. Loai can start. He's not with us, probably.
Yeah, he was driving.
Yes, yes.
Dr. Martin.
Yes.
You're still there?
You can hear me? Yeah.
Yes.
Okay. So at the end, I just would like to thank all of you, and just one message: do not just take things lightly. Maybe you need to investigate, but not fully investigate if things are associated with other red flags, which we mentioned in the topics and discussion. Just keep low threshold to refer to a nephrologist. Thanks.
Thank you. Dr. Intisar?
I want to stress on the definition of the microscopic hematuria, because we do see a lot of cases of one episode of microscopic hematuria done on routine test of the urine, and it resolved. So if the child doesn't have any red flag in the history or in the examination, keep an eye on it for a couple of weeks, repeat it at least 3 times. And if it persists in 2 or more, then refer the patient, because sometimes over referral will create unnecessary anxiety with the families. And thank you.
Absolutely.
Thank you. Dr. Martin?
My point would have been the same. Do recognize the red flags. Don't over-investigate if there is no red flag. The second one is the single most important assay if you have the suspicion for post-infectious glomerulonephritis is to measure C3. The next point is ibuprofen. Avoid ibuprofen, particularly if there's fever, diarrhea, vomiting, volume depletion. Then you surely send the children to us for acute kidney injury. And the last one, I would like to congratulate Dr. Loai and the group for bringing the Asian Congress of Pediatric Nephrology to Dubai. It's a really great opportunity. And thank you for all listeners. Thank you for the organization.
I would also request Dr. Diari and Dr. Ayman to give their comments from surgical point of view.
Yes. Yeah, well, you haven't got anything for me to comment on, actually. Yeah,
What would you rather we don't do and refer to the, you know, sometimes people go on and on.
Yeah.
Timely referral to a surgeon.
I'll just talk about my experience very briefly. In neonates and infants, so one of the most common causes of hematuria is external hematuria, which is from the prepuce. in uncircumcised children and irritation of the meatus itself in circumcised children. And for babies, for children in diapers, please look at the perineum and the scrotum as well. Because on many occasions, babies and children and small children came to me with hematuria, and the cause was very simple, just external cause.
Sure.
Yeah.
Okay. Thank you. Dr. Diari?
Thank you very much. The same thing. I feel assessment of hematuria should be done by the nephrologist. And if they feel that this is a surgical, then to shift it to the surgeon for any cystoscopy or any further
Thank you, Dr. Diari.
evaluation. Yeah.
Yeah, thank you all for this very stimulating discussion. We could have a whole day session on this, but our time is up. As far as I'm concerned, very important points brought forward clinically to look at blood pressure, to do a fresh urine sample analysis rather than, which has been standing for some time, and look at still the common things are common first, avoid the common mistakes like using non-steroidal anti-inflammatory drugs, because we do see drug-induced hematuria. Thank you very much, Dr. Martin, for a very nice presentation, and Dr. Luai and Dr. Intisar to complement the session beautifully. Thank you, Dr. Ayman, for nicely chairing the session.
Thank you very much.
Thanks. Thanks to all of you. Now we move on to our second session of the day, which is pediatric rheumatology. And for this session, I would like to invite Dr. Sohrab, who's the chairperson. Needs no introduction. He's the face of DPC. He's the president of DPC and a senior specialist pediatrician at NMC Specialty Hospital at Al Nada. Dr. Sohrab's dedication and passion is unmatched. Over to you, Dr. Sohrab.
Thank you very much, Dr. Kalpana, for the kind words. I give me a great pleasure to introduce the moderators and the speaker and panelists of the next session, Clinical Immunology and Rheumatology. Our moderators are Dr. Rajinder Joshi, Senior Specialist Pediatrician at Prime Hospital, Dubai. He's a past president of Dubai Pediatric Club. Dr. Rafia Ovara, Senior Specialist Pediatrician at Prime Medical Center, Jumeirah. She is the medical director of that center. Well, we have one eminent speaker, Professor Surjit Singh, professor and head of Department of Pediatric, chief of the Pediatric Allergy, Immunology and Rheumatology Unit, Advanced Pediatric Center at PGI, Chandigarh, India. We have in the panel Dr. Raju Khubchandani, a very senior consultant pediatrician and pediatric rheumatologist. He is a section head at SRCC Children's Hospital, Mumbai, India. And also we have with us Dr. Ziad Ababe, consultant pediatrician and head of pediatric rheumatology, immunology and allergy unit at Mediclinic Parkview Hospital, Dubai. He is also an adjunct clinical professor at His Excellency Mohammed bin Rashid University at Dubai. Now, it gives me a great pleasure to invite my teacher, Professor Surjit Singh, to deliver the oration in the name of the founder of Dubai Pediatric Club, Dr. Cyrus Litkohi. About Professor Surjit Singh, books can be written, but in just few lines, he was president Indian Rheumatology Association, principal investigator in the Indian Council of Medical Research Center for Advanced Research, Primary Immunodeficiency 2015 to 2020, president of Rheumatology Association 2017-2019, president Indian Society of Kawasaki Disease 2020-2022, president Asia Pacific Society of Immunodeficiencies 2020-2024, coordinator Asia Pacific League of Associations of Rheumatology Center for Excellence 2020-2023. It gives me a great pleasure to invite Professor Surjit Singh to deliver the oration. Thank you very much. Over to Professor Surjit Singh.
Thank you, Dr. Sohrab.
Welcome, sir.
It is indeed a big honor to be delivering this oration today. So I shall be speaking on primary immunodeficiency diseases. These are a group of conditions that often remain undiagnosed, that often remain missed. But these conditions are definitely not uncommon. There are population data from the US to suggest that the prevalence of primary immunodeficiency diseases is somewhere in the range of 1 in 1,200 to 1 in 10,000. Even if you take it at a prevalence of 1 in 10,000, it would mean that in a country like India, there would be something like 1 million cases of primary immunodeficiency diseases. The sad part is that an overwhelming majority of these patients remain completely undiagnosed, for the simple reason that the awareness about these conditions amongst pediatricians, amongst internists, is nothing to be proud of. We are missing these disorders, and in the course of my talk, I'll try and show that if we are aware about these conditions, and if we keep a low threshold for these conditions, it's not difficult diagnosing these conditions. So I was introduced to these disorders during my fellowship at the Hospital for Sick Children, Great Ormond Street, way back in 1990. And I had the privilege of being mentored by Professor Roland Levinsky. Dr. Levinsky was very fond of saying that diagnosis of primary immune deficiency diseases is not difficult, and that it is possible to make a syndromic diagnosis of these disorders right at the bedside and with very few investigations. How do we suspect primary immunodeficiency diseases? Well, the best way to suspect them is by using the 10 warning signs given by the Jeffrey Modell Foundation. What are these 10 warning signs? Well, these are 8 or more new ear infections within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months of antibiotics with not much effect, 2 or more pneumonias within 1 year. Whenever you have 2 episodes of pneumonia, you have to rule out a primary immune deficiency disorder. Children who are failing to thrive, rule out primary immune deficiency disorders. Recurrent deep-seated or organ abscesses. Every child with liver abscess, you should think of an underlying primary immune deficiency diseases. Persistent thrush in the mouth after the age of 1. There is something seriously wrong. Need for intravenous antibiotics to clear even minor infections. Be suspicious. 2 or more deep-seated infections, for instance, skin abscesses, psoas abscesses, and last but not the least, a family history of primary immune deficiency. So whenever you have 2 or more of these 10 warning signs, think of a primary immune deficiency diseases. Once you think of these diseases, how do you identify them? Well, it's very, very simple to identify them. Go by the age of presentation, type of organism, and family history. So Dr. Levinsky, again, he used to teach us, look at the age of presentation. How does the age of presentation impact the diagnosis? Cellular immune defects would present in the first 6 months of life. So by cellular immune defects, the most important is severe combined immunodeficiency. These disorders would be there right in the first few weeks of life. If you miss these disorders, these babies would not survive. Humoral immune defects, on the other hand, usually present after 6 months. The reason is that the baby is born with maternally acquired IgG. This maternally acquired IgG falls off with a half-life of 3 weeks, so that the first few weeks, approximately 12 to 16 weeks, are covered by the maternally acquired IgG, And this is enough to protect the baby for the first few months. So humoral immune defects would usually appear after 6 months. It is for this reason that children who are diagnosed to have X-linked agammaglobulinemia, that is Bruton's disease, would generally be completely normal in the first few months. They become symptomatic somewhere around 5 to 6 months. So what are the disorders which appear in the first few weeks or months? The most important is severe combined immunodeficiency, which is a medical emergency, severe congenital neutropenia, and DiGeorge syndrome. Disorders which appear from 6 months to 5 years, most important is X-linked agammaglobulinemia, previously called Bruton's disease, Viscodt-Aldrich syndrome, and phagocytic disorders like chronic granulomatous disease. Disorders which appear after 5 years, the most important is common variable immune deficiency. These disorders appear in older childhood or in adults. The second important clue would come from the type of organism. And Dr. Levinsky would not tire out of saying that the most important clues that you can get to diagnosis of PID is from the type of infection that is there in a given patient. So cellular immune defects, as for example, severe combined immunodeficiency, infections are polymicrobial for the simple reason that there is defective cellular immunity as well as defective humoral immunity. So we get infections with opportunistic organisms like pneumocystis, mycobacterial organisms, for instance, the BCG vaccine that you give that can flare up, fungal infections, cytomegalovirus, bacterial infections, a whole battery of organisms. The repertoire is very wide as far as the cellular immune deficiencies are concerned. So you get polymicrobial infections. Clinical features are also very heterogeneous: failure to thrive, oral thrush, pneumonia, diarrhea, hepatosplenomegaly. You get very variable clinical features. On the other hand, when you have humoral defects, as for example, X-linked agammaglobulinemia, the infections are by a very narrow repertoire of organisms, the most important being encapsulated bacteria like pneumococcus or Haemophilus influenzae. You can also have problems with giardia and enteroviruses like poliovirus, but typically these children would get infections with pneumococcus and Haemophilus influenzae. These children will present with acute recurrent pneumonia. That is a typical presentation of X-linked agammaglobulinemia, or acute recurrent sinusitis. As far as phagocytic disorders like chronic granulomatous disease are concerned, the infections are with signature organisms. By signature organisms, we mean that they will either get infections with Staph aureus, Aspergillus, Candida, Serratia. The moment you see Aspergillus infection in a child, think of CGD. The moment you see Serratia in a child, it is almost always because of CGD. Staph infections in CGD, unlike the usual staph infections, may not present with a lot of features of inflammation. So you could have a pneumonia, persistent pneumonia because of staph, which you would normally not have in a child with normal immunity. So in the presentation of CGD is with persistent pneumonia, single or multiple liver abscesses, lymphadenopathy, hepatosplenomegaly. If you have seen a couple of patients of CGD, the clinical picture is so specific, you will never miss this disorder later in life. Complement disorders, again, infections are with a very narrow repertoire of organisms, Neisseria, and encapsulated bacteria like pneumococcus and H. flu. You get recurrent acute bacterial infections, recurrent pneumonias, recurrent meningitis. But with complement defects, you also get some very peculiar lupus syndromes, especially lupus in early childhood. You also get this very intriguing disease called hereditary angioedema, which is because of a complement defect. And it is possible to diagnose these conditions based on clinical findings. The third thing which Dr. Levinsky used to teach us, don't ignore the family history. Look at the family history, trace the 3-generation family details. So primary immune deficiency disorders, many of them are X-linked recessive, as for instance, severe combined immunodeficiency, X-linked agammaglobulinemia, chronic granulomatous disease, hyper IgM syndrome. These are 4 amongst many others also which are X-linked recessive. This was a child, 2-month-old, persistent pneumonia and hepatosplenomegaly. Can easily be thought to have tuberculosis or some other chronic infection. But what do you see? You see that the child has 3 generations which are affected, and this is a typical X-linked family history, and this child had X-linked CGD. So you can make the diagnosis virtually on the basis of the family history. There are disorders that are autosomal dominant, as for instance, hyper IgE syndrome and hereditary angioedema. This was a 14-month-old boy who presented to us, this was way back in 1997, with recurrent pneumonia. The history was that this child had been having recurrent pneumonias, pneumothorax, and he also used to get pyodermas. So there was no doubt that we were dealing with a primary immune deficiency disease. When we started taking the family history, we realized that the father himself had been ill since early childhood. He was now 31 years old. He had been having recurrent episodes of pneumonia, skin abscesses, thought to be TB, and since he did not respond, took treatment for drug-resistant TB, but without any benefit. So this is a typical example of autosomal dominant hyper IgE syndrome, father and son. And this family, incidentally, was our first set of patients with STAT3 deficiency, mutation-proven STAT3 deficiency due to hyper IgE syndrome. Then Dr. Levinsky used to tell us that after we have looked at the family history, after we have looked at the type of organism, the age of presentation, look carefully at how the disease has evolved. What are the clinical findings? And you'll get very important clues. A 3-year-old boy with recurrent otitis and pneumonia. This was the history. 3-year-old boy with recurrent otitis and pneumonia. The moment you have this clinical picture, you know that this cannot be a cell-mediated immune deficiency, because children with serious cell-mediated immune deficiencies usually do not survive infancy. So this has to be a humoral immune deficiency. And what do we see on physical examination? That there are no tonsils. So the moment the tonsillar fossa is empty, you know that this has to be X-linked agammaglobulinemia. There are very, very few conditions in medicine where there are no tonsils, and X-linked agammaglobulinemia is one of them. So 3-year-old boy, recurrent otitis pneumonia, diagnosis made virtually on physical examination. So once you suspect XLA, we do the immunoglobulins, there is pan-hypogammaglobulinemia. So all the 3 immunoglobulins are virtually absent. What do we do next? We do the flow cytometry. So we do a marker for the T cell, which is CD3, a marker for the B cell, which is CD19. So in XLA, the T cells are normal because this is a humoral disorder, and CD19 cells are absent, B cells are absent. So in this child with hypogammaglobulinemia, the T cells were normal and the CD19 or the B cells were absent. So your diagnosis of XLA is virtually confirmed. Whenever you have hypogammaglobulinemia, look at the B cell count, the CD19 count. If these B cells are absent, this is XLA. But when you have hypogammaglobulinemia with B cells present in virtually normal numbers, then that is what happens in common variable immune deficiency. So hypogamma with B cells absent, XLA, Hypogamma with B cells present, this is CVID. When should one suspect XLA? Well, we suspect XLA in all male children with recurrent acute cyanopulmonary infections. Onset of the disease is usually after 6 months for reasons that we have already discussed. On physical examination, you have absent tonsils and lymph nodes. This is such a striking physical finding that you can virtually make a bedside diagnosis. Bacterial infections are by a very narrow repertoire of organisms, typically Strep pneumoniae and Haemophilus influenza. But XLA need not always be a very straightforward diagnosis. This was an 18-month-old boy who was previously completely healthy. He presented with acute febrile illness and a right orbital swelling. So he was thought to have, and rightly so, orbital cellulitis. Since he had been completely well, no one thought of a primary immune deficiency disorder initially. But then, when the resident took the family history, he realized that there was death of one maternal uncle in early childhood. So this became a point of interest. So based on this, he ordered immunoglobulins. This child had pan-hypogammaglobulinemia, and the B cells, CD19 B cells, were virtually absent. So this was another presentation of XLA, that this is how XLA can sometimes present the first time. And in this baby, the diagnosis of XLA was made right in our emergency by a junior resident. The clue was death of maternal uncle in early childhood. So once we suspect XLA, we do the workup, and this is the flow cytometry, the Bruton tyrosine kinase protein expression, how it appears on flow cytometry. And then you do the mutation workup, and this was the defect in the exon 16 in this child. All these tests now are done within our department. Yet another boy with XLA. This was a 2-year-old boy who presented with fever for 2 weeks, refusal to walk and stiffness of the lower back for 2 weeks. Refusal to walk and stiffness of the lower back. Very peculiar symptoms, very unusual symptoms for a 2-year-old boy. He had had an MRI done outside, and the MRI had shown some hyperintensities involving L4, L5, and L5, S1. But that still did not explain why is he having fever and why is he having such stiffness of lower back, very unusual symptoms for any typical rheumatological disorder. Lo and behold, when we took the family history, we realized that this boy had lost 2 brothers already, and the mother had lost 2 brothers herself. So there were 4 male deaths in the family, and then we became very, very suspicious. We had a good look at the child again, found absent lymph nodes and tonsils, pan-hypogammaglobulinemia, normal T cell number, and absent B cells. So again, XLA. So normal T cell CD3, absent B cell CD19, the diagnosis is straightforward. But because this presentation was so unusual, one of our residents reported this as a letter to editor. Humoral immune deficiencies can sometimes fox you completely. This was an 8-month-old boy admitted with severe pneumonia, required ventilation, not responding to IV antimicrobials. So there was something seriously wrong. Since he was very, very unwell, immunoglobulins had been done right at the beginning. What we found, IgG was low, IgA was low, but look at the IgM. It is way beyond the upper limit of normal. We didn't realize what we were dealing with, didn't understand what we were dealing with. We got it repeated, and yet again the IgM was high. So what was the diagnosis? The diagnosis was written in the hemogram. When we had a good look at the hemogram, we realized that this child had very low polymorphonuclear count. In a child who has very severe pneumonia, why should the polys be so low? The absolute neutrophil count was only 0.83. So this is because of an entity known as hyper IgM syndrome, CD40 ligand defect, in which you get hypogammaglobulinemia, raised IgM levels with neutropenia. So this is book picture, hyper IgM syndrome. Again, the clues would come from immunoglobulin assay. This is a very, very important investigation, which all of us as pediatricians should be doing more frequently whenever we are dealing with a difficult case. This was a patient, 35 years old, and yet he came to a pediatrics department. This patient came from the state of Gujarat. He had been unwell for more than 5 years with recurrent pneumonia and diarrhea. For pneumonia, he would go to pulmonologist. For diarrhea, he would go to gastroenterologist. Ultimately, he got so fed up, he Googled his own complaints, and he realized that he probably had a primary immune deficiency. So when he reached our department, he said, I think I have a PID, can you help me? So he diagnosed his PID himself. So when you have these kind of clinical complaints, this is the typical presentation of common variable immune deficiency. He was started on IVIG and he is completely well now. However, CVID can sometimes have a more complicated clinical presentation, as in this 21-year-old patient, chronic fever and cough for 6 months, requiring several antibiotics, right ankle arthritis. Why should a patient with pneumonia develop ankle arthritis? He had also been diagnosed to have celiac disease 2 years back and had been kept on a gluten-free diet. He had mediastinal lymphadenopathy. Fine needle aspiration cytology showed a non-caseating granuloma. So what is the clue to the diagnosis of primary immune deficiency here? Multiple systems getting involved. Lung is involved, joints are involved, GI tract is involved. Whenever you have such multiple involvement of several systems, you must always rule out primary immune deficiencies. Workup was done. This patient had pan-hypogammaglobulinemia, but look at these CD19 B cells. They are normal. So as we discussed earlier, whenever you have hypogamma with normal B cell count, this is because of common variable immune deficiency. The non-caseating granuloma in this patient is very liable to be mistaken for sarcoid-like granulomas. And whenever you diagnose a patient as having sarcoidosis, please rule out common variable immune deficiency in these patients, because the granulomas of CVID can almost mimic the granulomas of sarcoidosis. A 5-month-old girl born to a 3rd-degree consanguineous marriage. So whenever you have babies born to consanguineous marriages, we have a low threshold for diagnosing primary immune deficiencies. Presented with fever, cough, rapid breathing. So you would be worried. You did the white cell count, and what do you see? The diagnosis is written in this white cell count. The lymphocytes were only 10%. So this baby had lymphopenia, had oral thrush, born to 3rd-degree consanguineous marriage. X-ray showed no thymic shadow. So this is typical severe combined immunodeficiency. No differential diagnosis, virtually no differential diagnosis. So this is the most serious form of combined immunodeficiency, presents in babies less than 2 years. And how do you diagnose it? When there are less than 20% CD3 plus T cells or an absolute lymphocyte count of less than 3,000. This is a red flag sign. So in infants, when we are suspecting severe combined immunodeficiency, we must carefully look at the absolute lymphocyte count, and an ALC of less than 3,000 is usually very suggestive of an underlying severe combined immunodeficiency. So based on the hemogram, you can virtually diagnose SCID out in the wards with no difficulty. A 7-week-old boy had cough, loose stools, respiratory distress in 7 days. So you would be worried. Why should a child become so unwell? You do the white cell count again, virtually no lymphocytes. Lymphocyte count is only 1. As pediatricians, most of us are more used to looking at the polymorphonuclear counts because we think that, absolute neutrophil count, that helps us in diagnosing sepsis and several other disorders. We forget to look at the lymphocyte count. This lymphopenia has no differential diagnosis. This has to be because of a severe combined immunodeficiency. In addition, when you look at the chest X-ray, look at these ribs here. So this is severe combined immunodeficiency because of an enzyme defect known as ADA defect, adenosine deaminase deficiency. We got the AD activity done. It was virtually absent. And this cupping at the ribs is typical of ADA deficiency. A small baby who had a discharging sinus at the neck, a persistent lymphadenopathy in the axilla, a perianal sinus, a liver abscess. When you have so many systems involved, it has to be a primary immune deficiency. This is book picture, chronic granulomatous disease, CGD. When you suspect CGD, you can prove it in the laboratory by the DHR assay, dihydrorhodamine on flow cytometry. It is such a simple condition to pick up in the laboratory. What are the typical presentations of CGD? Persistent pneumonia, which is usually because of fungal organisms, Aspergillus or Candida, liver abscesses, solitary or multiple, recurrent or persistent lymphadenitis. Now, these conditions are very liable to be mistaken for tuberculosis. So in a patient with persistent pneumonia, if you cannot demonstrate acid-fast bacilli, think of CGD. They also are prone to develop osteomyelitis. This osteomyelitis is very peculiar in the sense that it involves only the small bones, carpus, tarsus, or the vertebra. This was a small baby who presented with very scary looking non-healing ulcers. But the diagnosis was very straightforward. The white cell count showed a very high absolute total white cell count, 68,000, and 90% were polys, but there was no pus formation. There is no medical condition in which you can have such high white cell counts. Overwhelming majority of them are because of polymorphs, and yet there is no pus formation. So this is typical of leukocyte adhesion defect. This is a primary immune deficiency disorder, which again is liable to be missed, and it is more common in communities where there are consanguineous marriages. This child again was reported. This was a child from Gujarat. He had been unwell for the better part of his life. He was 12 years old when we first saw him. And these are the kind of lesions that he used to have. His legs were all scarred. Again, the point to note is there is no pus formation. So for this, he had received weeks and months of antibiotics without any response. How did we diagnose it? By simple white cell count. This patient had always had white cell counts above 50, and overwhelming majority of these white cells were polys. Incidentally, this child now has had a bone marrow transplant. He's completely well, and he's recently got married. 4-year-old boy who presented with skin bleeds, peculiar rash, which was thought to be atopic dermatitis. When we did the hemogram, we found that there was thrombocytopenia, and the platelet size was small, only 4.3 florilliter. So this is typical of Wiskott-Aldrich syndrome. Very simple diagnosis to make, provided you are clear about how these children present. So Viscott-Aldrich syndrome has a triad of recurrent infections, atopic dermatitis, and thrombocytopenia with small platelets. There is virtually no medical condition in which you have thrombocytopenia with small sized platelets. It has a very broad clinical spectrum. At one end, you have the disorder known as X-linked thrombocytopenia, which do not have infections or autoimmunity. At the other end, you have the full-blown Viscott-Aldrich syndrome with severe infections and autoimmunity. These children will never survive infancy unless you do a bone marrow transplant. A 10-year-old boy had been having recurrent pneumonia. So whenever you have recurrent pneumonia, be very suspicious of a PID. And recurrent cold abscesses, which were thought to be because of tuberculosis, had received ATT without any benefit. He was HIV negative, immunoglobulins were normal, GAM were normal, but IgE was very, very high. If you have a close look at the face, there was some coarsening of the faces. So from this and the raised IgE level, we became suspicious. We got an orthopantogram done, and this showed that this child had retained primary dentition, which happens in this condition. So they have two sets of dentitions. The primary dentition doesn't fall off easily. So these are findings typical of autosomal dominant hyper IgE syndrome. Diagnosis based on clinical findings of coarseness of faces, a very high IgE level, and the retained primary dentition. So these children present with recurrent cold staph abscesses, coarse facial features, hyperextensibility, trivial fractures because of trauma, delayed primary teeth shedding. They also present with pneumonia and nematocele formation. They may have eczema and eosinophilia, and they have a loss of function mutation in the STAT3 gene. However, there's another type of hyper IgE syndrome in which you get extensive molluscum contagiosum, recurrent episodes of diarrhea. They fail to thrive, and when you do the hemogram, you realize that they have lymphopenia. The T cells are low, CD4 T cells are also low, and IgE is high. And this is the autosomal recessive variant of hyper IgE syndrome. Severe cutaneous viral infections, and the lesions that you see are molluscum, warts, and herpes. Lymphopenia is the hallmark. So they behave like a cellular immune deficiency, and these children have a loss of function mutation in DOCK8. 6-year-old girl with a spot diagnosis, recurrent severe abdominal pain requiring many emergency admissions. On investigations, ultrasound, X-rays typically normal. How was the diagnosis made? The child had had 2 episodes of such facial swelling here. When we took the family history, we realized that her mother had similar complaints, mother's brother had similar complaints, and the maternal grandfather had had similar complaints. So typical autosomal dominant history. So this is hereditary angioedema. Diagnosis made based on just drawing up the family tree. And you confirm it by showing that the C4 is very low. So these children have recurrent facial swelling without itching. The allergic angioedema, if suppose this angioedema is because of allergic reasons, there will be itching. But in hereditary angioedema, there is no itching, recurrent abdominal pain, and autosomal dominant family history. This was our first patient of hereditary angioedema, whom we had seen in 1996 when she was 3 years old. And the diagnosis was rather straightforward because her mother also had had similar complaints. So in both these children, at that time, we did not have these facilities, but now we have proven that these mother and the child, they have a mutation in the SERPING1 gene. And this is how this child looks at the age of 3, at 11, and at 20 years. This was a child who was thought to have lupus. He was diagnosed to have discoid lupus at 2.5 years of age. He had had seizures because of cortical vein thrombosis, and this thrombosis was because of antiphospholipid antibody positive. But then he decided to have 2 episodes of pneumonia. Why should a child with lupus suddenly develop pneumonia? When we took the family history, elder sister had died of lupus at 7 years. We did the workup. C3 was normal. ANA was 4 plus speckled, but dsDNA was negative. Children with lupus should have dsDNA positive. So we later realized that what we were dealing with was a family who had C1q deficiency, early complement component deficiency, and this was one of the first few patients that we diagnosed at our center. And Dr. Amit Rawat, who is my colleague in our department, he has been following up several families with C1q deficiency. So this is one example where a primary immune deficiency disorder can have a predominantly rheumatological presentation. So children with early onset complement deficiency may present with lupus. This lupus may be associated with serious infections, and these children have positive ANA but negative anti-dsDNA. So that is how you become suspicious about C1q deficiency. This was a child who presented with these typical lytic lesions here in the bones. Biopsy from these lesions was consistent with tubercular osteomyelitis. AFB were positive, but AFB culture showed not Mycobacterium tuberculosis, but Mycobacterium bovis. We did the workup. Initial workup was normal. So this is because of a PID known as Mendelian susceptibility to mycobacterial disease, MSMD. Once you suspect this, you can prove this on flow cytometry. And in this child, we had a partial dominant interferon gamma receptor defect. Some of these children can also present as recurrent Salmonella osteomyelitis, as seen in this patient who was an Air Force officer and who used to have recurrent osteomyelitis because of Salmonella. And again, he had MSMD. These are children who have these scary looking lesions on the nails because of candidiasis. And this is an entity known as chronic mucocutaneous candidiasis. Uncommon entity, but they can have very many clinical presentations, and they can be because of several genetic defects. And in this particular child, this young child, it was because of a gain of function mutation in STAT1 gene. 3 years old child, symptomatic since 2.5 months of age, recurrent bilateral ear discharge, 2 episodes of pneumonia, developmental delay, recurrent falls. And this is a typical presentation of ataxia telangiectasia, in which you get IgA deficiency. So recurrent infections, pancytopenia. So when you do the workup, you see these granules in the white cells and abnormal hair shaft. So this is the typical presentation of Shediac-Higashi syndrome. Hypocalcemic seizures and dysmorphic facies. Hypocalcemic seizures in early infancy should make you very, very suspicious. And on physical examination, you see the receding chin, upturned philtrum, low set ears. So when we did the workup, decreased CD3 T cells and decreased naive T lymphocytes. So this is typical of DJOD syndrome. Many children with DJOD syndrome also have an underlying primary immune deficiency in addition to the cardiac defects. So coming back to Dr. Levinsky, diagnosis of PIDs is not difficult, and it is possible to make a syndromic diagnosis right at the bedside, provided we have a low threshold for these disorders. PIDs are common conditions. Look for them. They are always around. As pediatricians, we should not stay content with just diagnosis and treatment of infections. This should not be an end in itself. We should try to find out why is the child getting recurrent infections. And as they say, do not miss the forest for the trees. So I would like to finish my talk by thanking my colleagues in our unit who have been doing all the hard work. And these are some of our PhD students and clinical fellows in pediatric immunology. And I would end my talk by paying my tributes to Dr. Cyrus Litkohi. And it is because of him that I got the privilege of delivering this oration. Thank you very much.
Thank you very much, sir, for excellent eye-opening presentation. I'm sure after this, many cases of primary immune deficiency will be picked up in Dubai and UAE. And it was really an eye-opening presentation. I'm sure everybody had liked. I would like to request you to join us in the panel. Now I would like to request Dr. Joshi and Dr. Rafia to start the panel discussion. I would like to request Dr. Khubchandani and Dr. Ziad also to join the panel. So Dr. Joshi, please start the session. Mike, your mic is off, Dr. Joshi. Your mic is off.
Taufik has to do it. Yeah, he has done it now. Thank you. Thank you, Dr. Saurabh. Good morning, everybody. Thank you, Professor Surjit Singh, for an excellent presentation. The session is not only on immunology, but it is also on rheumatology. And we have two other speakers, panelists, Dr. Rajiv Khubchandani and Dr. Ziad. To initiate the discussion, what I will recommend is Dr. Rajiv Khubchandani to present a few of his interesting cases, followed by Dr. Ziad. And after that, we'll start our panel discussion. The panel will be taking questions not only on rheumatology, immunology, and allergy, and immunodeficiency disorders. Dr. Raju, kindly go ahead with your presentation.
Thank you very much, Rajendra, and good day to all my friends and colleagues who are into this meeting right now. I realize that I am speaking to an audience largely consisting of general pediatricians, and therefore today the theme of my talk, with apologies to Shakespeare, is going to be TB or not TB. That is the question. But we'll see that this is actually connected to some things that Professor Surjit Singh has already been speaking about, and in addition to some hardcore rheumatology. So let me just start very rapidly with one case, that you have this 4.5-year-old female with prolonged fever for 2 years and musculoskeletal pains. And she additionally gets small self-limiting vesicular lesions like this. Her CT chest shows mediastinal adenopathy. And with this much data, she'd obviously started on antitubercular therapy. There's no response after 5 months. A repeat CT chest shows granulomas, no caseous necrosis after an FNAC, that is. And then she's labeled as tuberculosis with delayed defervescence, and antituberculous therapy is extended 9 months. To cut the long story short, finally, on whole exome sequencing, she is identified to have DADA2, which is a relatively newly described entity, the childhood polyarthritis nodosa as it was earlier described, but now it's known to have a very wide phenotype. And why did I show this as the first case? The reason I showed this was that the usual way we function in is you have prolonged pyrexia and a tissue biopsy, you see a granuloma, you say, oh, this must be TB. Or prolonged pyrexia or a cavity or miliary on X-ray, again, this must be TB. We start anti-TB treatment, there's no response, and we say, oh, this must be drug resistance. Now, on the other hand, you already saw one child who had a granulomatous adenitis and turned out to have something else. Look at this 17-year-old female who's currently under our care. Low-grade fever for 15 days. She is somewhere in Kanpur with her grandmother during lockdown. Bilateral ear discharge with fullness of the ears. Decreased hearing bilaterally. Her CT shows bilateral mastoiditis. And she comes with a persistent cough and hemoptysis. Her chest X-ray shows a cavitary, circular, large lesion, and the lung biopsy shows necrotizing granulomas, no AFB. Sputum Manto are negative, and C-ANCA and PR3 antigen test positive, concluding a diagnosis of what used to be called Wegener's, but the name has been now changed to granulomatous polyangiitis since the eponym Wegener was dropped because he was believed to have Nazi connections. And this is a 14-year-old with fever and cough for extended duration, found to have some form of miliary mottling, again started on anti-TB treatment. But what was missed was that there is some subtle clubbing over here and a prominent parotid gland. So further workup, you do a CT, and following the CT, there are non-necrotizing granulomas in the lung on a biopsy. ACE levels are very high. Mind you, ACE levels are not diagnostic of sarcoid. They just tell you about a granuloma load, and Blau mutation is negative, concluding a diagnosis of sarcoidosis. And then, while we are on sarcoidosis, you see this typical triad. You see rash, you see an arthritis, recurrent fever, red eyes. Now, in this case, this child had interstitial keratitis, but the triad is arthritis, uveitis, and rash. And you see a sago granule rash like this. Biopsy again shows a granuloma and early onset disease. The child has Blau syndrome, hereditary sarcoidosis. And then you have this child, which I will go through very quickly, 10-year-old with refractory ITP. And this child with refractory ITP has a biopsy done of a lymph node, and this biopsy of the lymph node shows granulomas. They find the ACE elevated and they are almost about to fall into a trap of diagnosing as sarcoid. But you heard Dr. Surjit Singh tell you that these kind of sarcoid-like granulomas can be seen in common variable immunodeficiency. And when we reviewed the 4 years records, one old report showed a low CD19 and had been ignored. On history at 10 months of age was admitted for a pneumonia, and at 5 months of age had thrush for 2 weeks. And there our penny dropped. IgA was low, IgG was low, and further lymphocyte subset analysis confirmed the diagnosis of CVID. Just the moral of the story I wish to conclude with is, when you see a granuloma on histopath or miliary or cavitary lesions, think beyond TB, especially if AFB is negative. You must attempt a microbial diagnosis in every case. The response to anti-tuberculous or anti-cox therapy has been poor. The age of onset is early. There is consanguinity. You heard Dr. Surjit Singh stress on consanguinity frequently. And there's multi-system involvement, or you find multiple multifocal infections. And if you see any of these, think rheumatology. That is my message. Thank you, Rajendra.
Thank you, Dr. Raju. May I request Dr. Rafia to introduce Dr. Ziad so that he can start his presentation? Dr. Ziad has been introduced by Dr. Sorab already, so he can start his short cases first, and then we'll start the panel discussion.
Okay. Good morning, everybody. I will share my screen just. Can you see my screen?
No. Only you, your presentation is not visible.
Okay.
There's a green button at the bottom, doctor, if you can. It's written share screen. I think Mr. Taufik can present the slides for Dr. Ziad.
Dr. Ziad, come, Dr. Joshi, you can start some question till Dr. Ziad.
Yeah. By the time Dr. Ziad gets organized, we'll start with some questions. The first question is for Professor Sujit Singh.
Or shall I share the screen, doctor? Then we can finish his lecture and then we can go.
Yes, that's better.
I will do that.
Dr. Joshi, carry on till Dr.
Yeah, can you unmute Professor Sujit Singh, please? Professor, we see lots of cases with the recurrent respiratory infections. They come almost 8 to 10 times or even more with upper respiratory infections. We know these children are healthy, but the parents are asking for the immunity workup and some medicines to boost up the immunity. For this group of patients, what is the basic test that you recommend, and is there any role for medicines which boost immunity?
Well, if the infections are only upper respiratory, the child is thriving well, there is no history of any hospitalization, one would generally not worry and do no investigations at all, just follow up.
Right. I will just, one of my experiences I will share. One child brought like this only, recurrent respiratory infections, absolutely no indication to do the test. But parents insisted and I did the immunoglobulins and serum IgA levels were 0. Now, does it?
Yes, IgA deficiency has to be interpreted in the context of the patient. And if only the IgA is low, I would just follow up. And in these children, we need to work up further and do IgG subclasses. Some patients with IgA deficiency have isolated IgG subclass deficiency. So one would just follow up. But for IgA deficiency, we generally don't give any immunoglobulin support.
And a role of any other medicines to build up the immunity for?
No, none. For, you would just follow up. And if the child is doing well, I would not be worried.
I will hand over to Dr. Ziad for his presentation.
I guess you can see my screen now.
Yes, very well.
Okay, so I will start my short talk. It's less than 10 minutes slot. So it's a case actually during our practice in pediatric rheumatology here in Dubai. So I choose this case because of a message that I want to just to get to the audience. Thank you for giving me this chance. And this is the outline of this short talk. Nicole is 11 years old. She was referred in last July 2020 to our practice. She's been diagnosed as juvenile dermatitis since 2015. And because of the recent severe flare of weakness, she was referred by an adult rheumatologist. Back to her beginning, she was diagnosed after weeks or few months of muscle weakness, followed by rash on the knuckles and elbows. So the clinical presentation was typical. Back then, they did skin biopsy, which showed connective tissue disease, but muscle biopsy, MRI muscle, and EMG, which are standard of care for diagnosis, were not done at that time. And she was started in treatment. When we received her, this is a picture of muscle MRI. She of course, she had severe weakness, and the muscle MRI was showing these white streaks in between muscle fibers, suggestive or consistent with muscle edema. And that's also in going with the diagnosis. But there was no rash. These X-rays or CT scans actually of the chest after a few months of immune suppression or immune suppressive treatment for the girl, we had to load her for severe weakness with loads of steroids, pulse therapy, then anti-inflammatory dose, and we utilized methotrexate, of course, and we added after 6 weeks, because of no response, we added rituximab and TB cell therapy, which is the most studied biologic treatment in refractory dermatomyositis. But after a few months of treatment, she was admitted with difficulty breathing, fever, and what seems to be as chest infection with the background of this heavy immune suppression. She needed an ICU, ventilated for a few days, then kept on high flow nasal cannula. Initially, in the era of COVID, we thought of this might represent COVID infection, but lab studies were done at our sister hospital in Mediclinic City, pediatric intensive care, and it showed TB PCR was positive, and pneumocystis jirovecii PCR was positive. This patient was not covered with prophylactic antibiotics when we had to load her for steroids. We were concentrating on trying to get her out of her severe weakness and severe flare, and Septrin, which should be standard of care, was not given to her, and she ended with this pneumonia shown on the chest CT. Luckily, she survived that and she improved. She was put in Septrin and anti-TB treatment, and she did well thereafter. And this is just to show you the response of her treatment when we started here. We started, of course, we load her with IVIG, and rituximab was added later. And this is creatinine kinase was more than 3,000. And after 2-3 months of treatment, it is down to 74. This is the AST, and clearly showing good response. This is the previous one is the LDH actually, and this is the ALT and AST, showing good response with the treatment. So this sign, I would like to highlight this important sign, which is looking at the capillaries at the nail bed. This is very important in terms not only of diagnosis, but of prognosis and response to treatment. This is the normal pattern in the A part, and down we have the juvenile dermatomyositis, showing this vasculopathy, dilatation, and enlarged lobes of capillary. This is a bedside test, can be done with the ophthalmoscope or a dermoscope. And this is with the scleroderma, and see that loss of capillary density is there as well. So this is very important sign that I encourage all pediatric rheumatologists or practicing rheumatologists to adopt in cases of vasculitis, because not only important in terms of diagnosis, but you follow that up in 3 months. If there is still these abnormalities, this predict severe course or poor response to treatment and reflect poor prognosis as well. So I just want to introduce few slides about juvenile dermatomyositis. It's uncommon autoimmune vasculopathy involving the skin and muscles. And there was a huge project going for the last years, several years, which is called Myogen. It completed recently the first genome-wide analysis for inflammatory myopathies, including children with dermatomyositis. And they could come to conclusion of the risk and protective alleles in the genes. and they identified that, and this will predict the response to treatment as well, because they include the cytokine genes and the lymphocyte signaling. Autoantibodies is a very important tool that should be used also. It is positive in more than 60% of children who suffer inflammatory myopathies. And this is, there was some debate in the previous years about the need for biopsy, especially in children, as it is an invasive tool, because you see this is the original Bohan and Peter criteria that was put back in 70s, and since that time it was not changed much. Children will have definite dermatomyositis if they have rash and 3 other criteria out of these 5. And they have probable diagnosis if they have rash and 2 other criteria, and they have possible if they have 1 criteria besides rash. So rash is a prerequisite for diagnosis. You cannot make diagnosis of dermatomyositis without rash. Now, the question, if we have weakness, clinical, and we have biochemical myocytes, raised CK and LDH and AST, aldolase, etc., and we have EMG findings, then do we need muscle biopsy? Because these are 3 criteria and they will put the patient in the definite diagnosis. In the past 10 years or 15 years, some centers were abandoning doing biopsy because of the invasive nature and because of the demand for specialized histopathology lab, and sometimes failure of biopsy, the surgeon could not take a representative sample of the muscle. So they were depending on doing MRI, doing EMG, besides biochemical and clinical myocytes, in addition to the rash, and this will diagnose definite dermatomyositis.
2 minutes,
But,
yeah, please.
yes. But recently, the value of biopsy is also brought to the surface, and you should have a biopsy to look into the exact histopathological type, and it is again important to do biopsy. I think this criteria will, in the coming few years, will be changed towards in favor of doing a biopsy. This child did not undergo biopsy. Autoantibodies is very important, as well as whole exome sequencing, trying to define the risk alleles, and this will lead to to predict the clinical phenotype and the course, and will lead to personalized therapy approach. The poor prognostic factors, the chronic course, active damage, calcification, oropharyngeal and involvement, severe GI involvement, and persistent abnormal capillaroscopy at 6 months, as I mentioned. And these are some of the antibodies. Our patient was having anti-ROSA, SSA in low titers. These are the different antibodies type, and each antibody will lead to different clinical presentation in terms of whether skin is predominant, whether muscle, whether calcification is predominant. So we have to carry out extensive autoantibody screen.
Thank you very much, Dr. Ziad. Now we'll give time for the discussion. Thank you very much. Yes,
these are the take-home messages. We should not forget the septrin prophylaxis for this, and this is this is a classic example of secondary immune deficiency, and the importance of biopsy and autoantibodies should be kept in mind as well. Thank you for letting me presenting this short case.
Dr. Joshi, please.
Thank you, Dr. Ziad and Dr. Raju. We'll start with the panel discussion. Of course, there are so many common and uncommon cases, so there will be plenty of questions. Going back to Professor Surjit Singh about the primary or immunodeficiency disorder, do you recommend any panel of tests, or you go case by case for the investigation?
Yeah, I think that's a very relevant question. We would not do a panel of tests for the simple reason that for majority of the patients, this is not required. So you come to a syndromic diagnosis based on the clinical presentation, based on the infections that you have in a given patient, and based on the syndromic diagnosis, you then order one or two very specific investigations. So for instance, if a child has had a liver abscess, the child has had persistent lymphadenopathy, you would suspect chronic granulomatous disease. So in that case, we would straight away do the nitroblue tetrazoline dye reduction test and the dihydrorhodamine flow cytometry test and do nothing else. Similarly, if you're thinking of X-linked agammaglobulinemia, again, a syndromic diagnosis of a humoral immune deficiency, you would order just the immunoglobulins, the serum IgG, A, and M. So in these patients, you have to be very specific what you are requesting for, and then interpret those tests carefully. Otherwise, one is liable to get into difficulty.
Yeah, here I may just add, one of my teachers, Professor N.B. Kumta, is also attending the conference, I believe. This is in 1980s when I was a student and I just started pediatric term. I had presented a case to him, a child who came to us with the third episode of pathogenic meningitis. And of course, as student, we prepared for all the rare diseases and we were ready. He said, you take the history and ask one question. The question was very simple. He asked because we had a language problem with that patient. Mother said that whenever the child bends down, the water starts dripping from his nose, and of course, the diagnosis was very clear that child had CSF rhinorrhea. So, I mean, all cases with recurrent infections may not be because of immune deficiency. You have to think of local cases as well. And Dr. Rafia can go through the questions if you have any, and you can ask them. Meanwhile, in the morning presentation, we had some cases of vasculitis presenting with renal involvement. Do you want to comment anything about rheumatology and vasculitis? Dr. Sujit Singh? Vasculitis cases and rheumatology.
Yeah, Dr. Rafia, you want to take that?
Yeah, please. Yeah, I want to ask you, Doctor, first of all, thank you very much. Very nice presentation, actually. And I have one question is, what about if we need genetic diagnosis for all the cases that we put the diagnosis of the primary immune deficiency?
Yes, I think again, that is a very important aspect of diagnosis. So increasingly, once we make a molecular diagnosis, increasingly we have to now make a genetic diagnosis also. So I have seen a distinct change in our investigative workup. So 10 years ago, we were not doing genetic studies that frequently. But these days, to confirm the diagnosis, we end up doing the genetic workup in many patients of primary immune deficiency, more so because we now have the facilities of offering prenatal diagnosis to affected families. So for instance, if we have diagnosed severe combined immunodeficiency in a family or chronic granulomatous disease in a family, we now have the wherewithal to offer prenatal diagnosis to the parents before the next pregnancy. So that is a very important aspect you have raised, Dr. Rafia. Genetic diagnosis is now virtually an integral component of the workup of these patients.
Doctor, can this disease be diagnosed later in childhood, later?
Yes.
Not in the infant's time.
Quite often in countries where the diagnosis of primary immune deficiencies is not being made frequently, many of these children get diagnosed in adolescence or even in adulthood. So there are well-documented cases of X-linked agammaglobulinemia getting diagnosed in their second decade or even third decade. Similarly, disorders like hyper IgE syndrome, these children may keep on suffering, and you may end up diagnosing them much later on in life. So unless
yeah, sorry, but if they are having these recurrent infections always, it will definitely affect their development. They will have delayed development. So how can we make any prevention for them also if they are diagnosed early in the infancy time?
So, for instance, if you have a child with X-linked agammaglobulinemia, XLA, if you make the diagnosis in infancy, that means before the first birthday, you will give that child a very good prognosis. These children will lead completely normal lives, provided you can give them immunoglobulins every month. Similarly, if you pick up chronic granulomatous disease, hyper IgE syndrome in early childhood, these children lead virtually normal lives. Severe combined immunodeficiency, if you transplant these patients, Viscott-Aldrich syndrome, if you transplant these patients, they are cured. So we have large series of severe combined immunodeficiency now from most of the developed countries. In the Middle East, Saudi Arabia, they have so many patients of severe combined immunodeficiency whom they have diagnosed and treated with BMT in early infancy, and these children are cured. So these are disorders that are eminently treatable, eminently curable. And as pediatricians, we need to have a very, very low threshold for these disorders because they are not rare. It is just that we are missing them.
Yes, thank you.
Dr. Binu wants to ask, what is the cause of severe monocytosis in the case with lymphopenia? That is the case of severe combined immunodeficiency.
Well, whenever one cell line is affected, the other cell lines tend to overcompensate. So this is a phenomenon which we see in many hematological and immunological disorders. So nothing more than that as far as that patient is concerned.
I would like to ask, thank you, Professor, for the comprehensive talk, actually. You covered all parts of immune deficiency, but I know BCG is still given in many developing countries, like here and in India as well. So how frequent you are encountering baby who are immune deficient and got the BCG and then they complicated with the BCGosis? I remember from our practice and experience in Jordan, we were the only center caring for kids with immune deficiency. And we have a bone marrow we had a bone marrow transplant back then when I was there. We published more than 15 to 20 cases of children who got BCG without being aware that they are having congenital immune deficiency. What's your experience in that regard? This is the one question. The other questions I want to ask, are you still adopting the NBT test for CGD before going to the DHR, or you are just going to do the DHR assay immediately?
Yeah, the second question is simpler to answer, so I'll take that first. For screening purposes, we would do the NBT test, nitroblue tetrazolium direduction test, and we generally count 200 neutrophils. It is a very sensitive test for CGD. If the NBT test is normal, in majority of the patients, we do not do the dihydrorhodamine assay. If the NBT test is not conclusive, yes, we would do the DHR straight away. So NBT test is very inexpensive, takes hardly 20 minutes. So that is a very good screening test. And once you have some clues, either clinical clues or on the NBT, then we would do the DHR. And if the child has CGD, then of course we would do both NBT and the DHR. NBT test can be done by any hematology laboratory. It is such a simple test. It can, in fact, it can be done by any pediatrician himself. It takes hardly 20 minutes. As far as BCG is concerned, the point that you have raised is a very important point. If there is a child with a cellular immune defect, especially severe combined immunodeficiency, and if the baby gets BCG, this BCG is likely to disseminate. And in these children, it is very difficult to salvage such patients, save such patients, if the BCG has disseminated. So in fact, the first baby in a family with severe combined immunodeficiency is often diagnosed based on the disseminated BCG infection that you get in the child. And once you start investigating the BCG infection, you realize that what you're dealing with is a severe combined immunodeficiency. So in some countries now, there are thoughts on whether you should give BCG to all babies at birth. And what they say is, because screening for severe combined immunodeficiency is now being done in many countries. So the entire USA, all 50 states of the United States, they screen for severe combined immunodeficiency at birth. Similarly, many of the Scandinavian countries, in the Middle East, Israel is screening, Qatar is screening for severe and combined immunodeficiency. And they say that you should prove that there is no lymphopenia before you administer BCG vaccine. Otherwise, if the child has an immune deficiency and he gets a BCG, it will be very difficult to save that child. So thank you, Dr. Zayad, for raising that issue. It's a very important point that you have raised.
So are you frequently encountering that in your institution, Prof?
Well, not very frequently, but yes, some of our SCID families, we were able to make a diagnosis of SCID based on the disseminated BCG infection.
Yes, likewise in Jordan also.
Yeah.
Likewise in Jordan.
A question for Dr. Raju Kurchandani. This is regarding rheumatoid arthritis in children. Do you have any update on the diagnostic criteria and the newer modalities of treatment?
So, Rajendra, that's a very broad question and can actually be a separate talk by itself. But the most important point that I wish to state is that as of right now, it's still the ILR criteria that are used for the diagnosis, though there is work in progress even as we speak right now with modified criteria coming up. And there's a very beautiful article for anybody who would be interested in Nature Reviews Rheumatology about 2 months ago, which gives the movement towards the new classification of JIA. Essentially, the most important point I wish to state is that JIA is a clinical diagnosis. Investigations are not diagnostic of JIA. Investigations more help to stratify certain forms of JIA. For example, the ANA test in oligoarticular disease only tells you about those children who are more likely to develop uveitis. And the rheumatoid factor, which is positive only in about 5% of children with JIA, helps you to just classify those polyarticular patients into RF positive and RF negative. In terms of the management of JIA, the 2013 recommendations of ACR are still the current ones, though I am aware that right now there is a writing committee which is writing up some new recommendations and guidelines. But essentially, let's summarize to say that methotrexate still is the sheet anchor for most of the forms, but quickly escalating to biologics in cases who are non-responsive, typically using TNF blockade or IL-6 blockade. TNF using, for example, etanercept or adalimumab, and IL-6 using tocilizumab. There is a major problem in resource-challenged countries with the use of biologics because these are very, very expensive drugs. Though with biosimilars now available, the costs of therapy are progressively reducing, and we therefore have to resort to certain unconventional therapies to treat these children.
So I would add, thank you, Dr. Raju, for commenting on this. I just want to highlight one point regarding classification of GIA. Since a few years, or many years actually, the European colleagues are trying, and they are adopting to try to remove the systemic GIA from juvenile rheumatoid arthritis and to classify it as part of autoinflammatory disease. Because of these peculiarities of this form of rheumatoid arthritis or juvenile rheumatoid arthritis, they are believing that it must be put with other autoinflammatory disease or periodic disease. This is one point that I just want to add to Dr. Raju. And of course, the threshold for starting biologic treatment is lowering every year and year. Even the methotrexate is still standard of care as non-biologic DMARD. I just want to ask Professor Singh, do you run bone marrow transplant service in your institution by yourself as immunologist, or this service is carried out by oncologist? This is one part. The other part, do you accept to host trainees from outside India in your center? This is probably not related to scientific content of the talk.
Yeah. So bone marrow transplantation in our institute is being done in the BMT unit, which is under the internal medicine department. And this unit does bone marrow transplants both for immune deficiencies as well as for leukemias and other malignancies. So we don't have a separate BMT unit dedicated only for immunology, the way it should be and the way it is in most of the developed world. Yes, we host trainees and trainees from all over the world. They can come to our institute because it's a central government institute, so trainees are welcome. And we get trainees from several countries, so they do their sabbaticals with us. Some trainees come specifically for a particular subspecialty. They are welcome. So you just have to apply. There is a set procedure, and they can stay up till 6 months. But for the postdoctoral training program also, we have a 3-year training program in pediatric clinical immunology and rheumatology. We have a few seats, especially for overseas fellows. So, but then these fellows have to appear in the competitive exam and they will get the degree just like any other fellow from our institute.
Thank you so much.
A question for Dr. Raju again. Which are the conditions mimicking rheumatoid arthritis in children? Do you want to touch base upon those?
So, as I mentioned again, Rajendra, rheumatoid juvenile idiopathic arthritis is a clinical diagnosis. And I'll tell you, there are so many mimics that we have, plenty of mimics, but there is one mimic I must highlight to my listeners today, and the one that we fear the most, and that is leukemia. You see a child with a low-grade fever, few joints which are painful and swollen, but most importantly, these are nocturnal pains. These are not the early morning pains of inflammatory arthritis, but these pains wake the child up at night. And you see that the age and sex is wrong for a diagnosis of oligoarticular GI. Typically, it's a female with between 2 and 5 years for oligo GI, but here you see a 5-year-old or a 7-year-old male or an 8 or 9-year-old female. And you find that this fever is not the quotidian fever of systemic GIA, and the white cell count looks probably normal or low. And if this count has been done 2 or 3 occasions, you may just notice a subtle drop in hemoglobin occurring over the 2 or 3 times that the child has been tested. And more importantly, the lymphocytes are creeping up and the polymorphs are creeping downwards. So it's lymphocyte 60, polymorphs 40, then it's lymphocyte 75, polymorphs 18, and your platelets, which were 230,000, are now 170,000. Immediately your antenna should go up. This is a cranky, irritable child. The most important message I want to give is no steroids. Because if you do this, your bone marrow diagnosis is going to be delayed. And I've seen diagnostic delays as long as 6 months just because somebody inadvertently used steroids.
Question for Dr. Raj.
Yeah, sorry, go ahead.
So go ahead, Dr. Joshi. Go ahead.
Okay, you have any comments? Please go ahead.
Okay, Dr. Raju, just how frequent you are doing bone marrow aspirate and biopsy for those kids with the prolonged fever that you are suspecting to have systemic GIA, as we are all aware that we cannot make definite diagnosis until the arthritis or arthropathy is evident. But sometimes you can't wait because it's a duration of weeks or months. So how frequent you are performing this procedure, as it's invasive? Many people may would like to avoid it, but apparently it might be necessary before starting steroids, and still the arthropathy is not there to definitely diagnose systemic GIA.
So even though you may not have arthropathy, but the very typical quotidian fever where the child has maybe 1 or 2 spikes in a day and is absolutely well looking between the spikes, or may have an evanescent rash that comes up along with the fever and disappears, are very striking. And if these are there, and notably you see a polymorphonuclear leukocytosis along with a thrombocytosis. However, we are entirely aware that occasionally and rather rarely, and some of these series have been described from Saudi Arabia, where the initial presentation of systemic GIA was with macrophage activation syndrome. Now, at the same time, I must add a word of caution to say that even to diagnose macrophage activation syndrome, the bone marrow, to document hemophagocytosis, it is a very specific test, but it is not sensitive. In your sample, you may not pick up hemophagocytosis at all, which does not rule out the diagnosis. And therefore, to diagnose MAS, you need to do a ferritin, you need to do triglycerides, you need to do liver enzymes as your 3 primary things, along with a dropping platelet count, which would give you an answer. So to answer you directly, in the garden variety of systemic GI, I have, even when there is no arthritis, I have seldom ever, I can't recall a child in whom I needed to do a marrow, because polymorphs at 88% and lymphocytes at 12 versus polymorphs at 12 and lymphocytes at 88. That's the one in whom I would do the marrow.
So you mean basic investigations can direct your decision to do bone marrow aspirate and biopsy? That's the bottom line. Yeah, I have one more question. Sorry to make it long, but regarding kids with rheumatological conditions on methotrexate and biologics, what's your experience when they contract COVID infection? That's because of this. This is a COVID era. And this question also for Professor Singh, kids with immune deficiency, how can they accommodate, or how can they survive in the COVID era?
So we have been keeping a log of our children who have contracted COVID while on immunosuppressive therapy. And as of just now, over the last about maybe 7 or 8 months, I have approximately 11 children in my series who are following up with me and who are active treatment who have developed COVID positive state. And I'm uniformly absolutely happy to tell you that they are the kids with the least symptoms. And if at all, they've had fever for 1 day or 2 days and completely settled beautifully after that, which is again leading us to believe, as most people are believing, that it's not the virus but the immunological response to the virus which is bothering them much more. And possibly because they are immunosuppressed, uh, they don't have too much of trouble. On the other hand, in immunocompetent individuals, I've seen a child come with sudden onset blindness and he had anti-MOG antibodies. I've seen a child with anti-phospholipid antibodies and thrombotic phenomena following COVID. But these guys were immunologically competent, healthy kids. My cohort of rheumatologic patients have fortunately stayed unscathed so far. But I hope I'm not speaking too soon.
Okay, good. This is our feeling, although we don't have enough data, probably from few patients we got. And regarding kids with immune deficiency, Professor Singh, do they do well with the COVID, or do they manifest more severe manifestation?
Yes, I think I would echo what Dr. Raju has said. Most of our patients with immune deficiency seem to have done well even after contracting COVID. So we have had no major problems in this subgroup.
So, sorry, I'm interrupting. We are having about 7 minutes. So, Dr. Joshi, to come up with the concluding remark of the
question about the role of genetics in rheumatology. How relevant is genetics in rheumatology, Dr. Raju?
So, Rajendra, as I always say that if for those people who are the youngsters and learning in this crowd or are possibly undecided in what direction they wish to go, I will tell you that there are only two branches of medicine that are going to invade everything. One is immunology and the other is genetics. So, genetics has a brilliant tie up with neurology, as we have been always aware for several years. But over the last approximately maybe a decade or so, with availability of cheaper genetic testing, we are diagnosing a lot of auto-inflammatory diseases. And at my center already, I have over 50 children with hereditary autoinflammatory diseases, what used to be called the periodic fevers. And we have a wide range of these kind of patients. But besides the hereditary autoinflammatory diseases, there are several children who come with mimics, skeletal dysplasias, for example. And you have some rare arthropathies, camptodactyly arthropathy, Coxavara pericarditis syndrome. You have another syndrome called MONAS, that is multicentric osteolysis with nodulosis, and several such syndromes. This morning we had a child with brachydactyly and early onset osteoarthritis due to a certain mutation that is known to cause early osteoarthritis in adults. So all these diagnoses are being made possible, uh, who maybe 15 years ago we would have just said gee, okay, which meant God only knows. But now, besides God, we have started finding out more and more. And I'm telling you that this is going to open a huge box. And just as genetics has invaded neurology and immunology, primary immunodeficiencies, like you heard Surjit saying just now, it's going to be, or rather already is, a very integral part of what we do in rheumatology also.
Dr. Joshi, we have 5 minutes.
So, Doctor, we've run out of time actually.
Remarks of the speakers, Professor Surjit Singh, Dr. Ziad, Dr. Khubchandani, concluding. Now it is 2:00 midnight in the United States, and Dr. Khubchandani is talking from there. We are thankful to him. By the way, I would like to inform the viewers that Dr. Khubchandani is running online course. Those who are interested, they can ask us. We will send the email. Professor, Dr. Dr. Joshi, please conclude by final remarks.
Yes, thank you very much, Professor Surjit Singh, Professor Khubchandani, and Dr. Ziad. It was very interesting presentation and nice panel discussion. There are lots of questions I can see in the Q&A, and I will try to answer them individually. And thank you very much. Dr. Afia, if you want to say anything?
Thank you very much. Can I have the last question, Dr. Suhrab?
Let us ask the distinguished speaker and panelist remarks. If it is very short, you can ask, then we'll ask the request them to give the final remarks for office pediatricians from this session, what take-home message they should take. You please ask.
Yeah, this is actually because now we are in Corona pandemic, so we want to ask the last question about for Dr. Ziad, how to evaluate a child who had Corona infection with leukopenia for immunodeficiency.
Just 1 minute, or just answer very short.
This for me, yeah?
Yeah.
Leukopenia in setting of COVID, who is having immune deficiency?
Yes.
I think we have to evaluate as a whole the patient with all the parameters he's having. Is he presenting with severe manifestations? Leukopenia alone might be part of any viral infections, whether in immune competent or immune deficient patient. We have to be cautious, of course, how low is the leukocyte count and what type of leukopenia is having, in addition to the clinical presentation, of course. But I cannot highlight leukopenia specifically in a COVID, in a kid who is having immune deficiency. What immune deficiency? Is it cellular? Is it humoral immune deficiency? And how the patient is presenting and what type of differential he's having and how low is the cell total white blood cells count. So this question will open to many questions.
This we'll discuss in the WhatsApp group. We can discuss. Now, Professor Surjit Singh, I would like to request to give the final remarks and message for the pediatrician, followed by Dr. Khubchandani.
Well, my message is that as pediatricians, for too long have we been, just treating infections in children. We have to think beyond infections. We have to think beyond sepsis. Pediatrics is too wide and too complex to just confine ourselves only to infections. Thank you.
Dr. Raju, final remark for pediatricians, your take-home message for pediatricians.
The most important thing is if you see recurrent symptoms or if you see multi-system disease, please think of the immunologist or the rheumatologist.
Thank you very much. Dr. Ziad, you have any comments?
Yeah, I just want to highlight that unlike what people are thinking, that juvenile idiopathic arthritis or rheumatological conditions are uncommon, they are quite common surrounding us in our daily practice, emergency visit and outpatient department. But we have to think of the diagnosis. As the professor and Dr. Raju stated, that you cannot make a diagnosis without thinking of it. So you see what you look for, you recognize what you look.
Thank you very much. I would like to thank Professor Surjit Singh, Dr. Khubchandani, Dr. Ziad, Dr. Joshi, Dr. Rafia for excellent discussion. Today, really, Dr. Surjit's talk was an eye-opening. I'm sure from tomorrow, we will see a lot of cases of primary immunodeficiency diagnosed and published in the journals. Thank you very much once again. In the near future, we will have a ceremony and inshallah we will felicitate those in India. We'll try to invite, if not, to send the awards and certificates there. Thank you very much. Thank you very much for joining us.
Thank you. Thank you.
Now I would like to request the viewers, before announcing the next session, which is pediatric radiology, we'll have a brief video. I would like to request Mr. Tawfiq to present that video, and then we will proceed with pediatric rheumatology. I will introduce the chairperson of that session, Dr. Bushra Azam. Thank you very much.
Vitabiotics, an award-winning nutraceutical company. It is the first nutraceutical company to complete 50 successful years. Well Baby Vitamin D3 Drops is a unique vitamin D3 supplement in an olive oil base. No peanut oil, no castor oil like other formulations. Well Baby Vitamin D3 Drops provides 400 international units of vitamin D3 in 0.5 ml and 800 international units per 1 ml. Devoid of any artificial flavors and colors. It contains no artificial sweeteners. Suitable for vegetarians. Suitable from birth onwards. It contains easy-to-use measuring syringe. Well Baby Vitamin D3 Drops is covered in all insurances, including PCP, RN3 and Abu Dhabi Basic Plan. Well Baby Multivitamin Drops is the ideal supplement formula for babies from 1 to 12 months. It contributes to normal cognitive development of babies. Supports normal growth and development of bones in babies. Helps to boost immunity in babies. It is an appetite enhancer. Supports overall health and wellness in babies. Contains no artificial colors or sweeteners. Dose. For babies from 1 to 12 months, give 0.5 ml twice daily. Vitabiotics is proud to present the comprehensive multivitamin formula for babies aged 6 months to 4 years. Well Baby Multivitamin Liquid. It contributes to normal cognitive development of children. Supports normal growth and development of bones in children. Helps to boost immunity in children. Provides required nutrients for picky eaters. Supports overall health and wellness in children. Dose. For 6 months to 4 years, give 5 ml daily. 1 teaspoonful. Vitabiotics has recently launched its comprehensive multivitamin formula for school-going kids aged 4 to 12 years. Contributes to normal cognitive development of children. Supports normal growth and development of bones in children. Helps to boost immunity in children. Provides required nutrients for picky eaters. Supports overall health and wellness in children. Has natural orange flavor. Dose. For 4 to 10 years, give 1 teaspoon 5 ml daily. For 11 to 12 years, give 2 teaspoons 10 ml daily. WellKid Immune Chewable is a comprehensive combination of botanical ingredients with iodine and vitamin D3 to safeguard your child's nutritional intake. Contains flaxseed oil powder, which is high in omega-3 fatty acids that help treat constipation and diarrhea. It has citrus bioflavonoids to treat allergies, viruses, and other inflammatory conditions. Contains natural mixed carotenoids which increase the T cell count. It has grapeseed extract, the richest antioxidant to protect against oxidative stress, tissue damage, and inflammation, and also prevents disease. It can also improve kidney function and inhibit infectious growth. It comes in a great tasting orange and lemon flavor. The recommended dose is for children 4 to 12 years of age, chew 1 tablet daily.
Thank you very much, Mr. Tawfiq. Mr. Tawfiq, can you, oh, thank you very much, Mr. Tawfiq. I would like to announce here that this conference is sponsored by Vita Biotics. I would like to thank the country business manager of this company, Mr. Tawfiq Ali, who is sponsoring Dubai Pediatric Club conferences for the last 7 years. For the last 7 years consecutively, he is supporting and sponsoring the DPC events. All of us, we are thankful to him. Now I would like to go to the next session. Next session is a very exciting session, pediatric radiology. The chairperson of this session is Dr. Bushra Azam. Dr. Bushra Azam is joining us from Canada. She's a specialist pediatrician. She was a member of executive committee. Today, a speaker is very famous and well-known in pediatric circle, Dr. Vikrant. In a short while, Dr. Bushra will be introducing him, the moderator and the speaker. Over to Dr. Bushra. Welcome, Dr. Bushra from Canada.
Thank you very much, Dr. Zahrab. Thanks a lot for inviting me to chair this session. In fact, both the moderator and the speaker are very precious for me. So let me introduce first Dr. Leila. She will be the moderator of this session, and she's my close friend, and also she's a pediatric specialist pediatrician in Green Life Clinic and also in International Modern Hospital. She's the new addition and the new precious addition to Dubai Pediatric Club. Welcome, Dr. Leila, for the Dubai Pediatric Club meetings and future meetings. And of course, Dr. Vikrant is really, really very high. He's really a very precious person. Dr. Vikrant is very well known for his very interesting lectures, starting from the first till the last session. I don't know if, are you seeing me? Because, let me see, yeah. His lectures are really interesting. Dr. Vikrant is a specialist radiologist, and he's the head of radiology department from NMC hospital. All of us know him, and all of us enjoy his lectures. So let us stay tuned and welcome Dr. Vikrant.
Thank you, Dr. Bushra. Thanks a lot for the kind introduction, and it's nice to see you. Hello, Dr.
Thank you very much. Thanks.
Nice to see you as well.
Thanks.
And I would like to thank the Dubai Pediatric Club for giving me this opportunity to present my cases and to be on this platform and to present my cases and to just share with you some of the interesting cases. Some of the cases might be repetition of what I already spoke in the last presentations, but I've repeated these cases because the audience is much wider this time, and these cases have got a lot of teaching potential. So thank you once again, the Dubai Pediatrics Club, especially Dr. Saurabh, Dr. Kalpana, and all the members. Thank you once again. Let me share my screen now. Done. Sivani, please.
Not shared yet, Dr. Vikrant.
Yeah. I hope you can see my screen now.
Yes.
So yeah, So the topic of today's presentation is interesting cases and the diagnostic pearls. So let's start the journey. I have nothing to disclose. So the aim and objectives for my presentation would be, I would present and review some practical and the interesting cases from pediatric radiology, which we have encountered in the past 6 months or 1 year. And we'll just discuss some points. I'll give you some practical tips. Then I will talk a little bit about pediatric radiology in COVID infection. Everybody is talking about COVID nowadays. Followed by a quiz. I'll have 5 spotters. Everybody would be allowed to vote. They can write their answer in the chat box. Mr. Tawfiq is the judge. He will pick up the fastest contestant who has answered their question correctly. And in the end, if time permits, we'll talk a little bit about the artificial intelligence related to pediatric radiology. So let's start the journey. I must also tell you that I've included these cases. They are not very complex cases. They're more important from the practical point of view, which we encounter in the day-to-day practice. And let's hope everybody learns from this. To start with, before the cases, let's see what are the challenges and peculiarity in the pediatric imaging. We all know that children are not young adults. Physiological and pathological variations extend through a long age group. It starts from the newborn, then extends to neonate, then to infant, then to child, then to adolescence. The tissues are evolving, and so is their appearance on radiology. So it's pretty complex. And we need to keep in mind that the normal radiographic changes for adults might be normal in pediatric age group and vice versa. Again, it is very important to note that there are extremely low percentage of pediatric radiologists which are available as compared to the other specialties, approximately 20 versus 38%. This is as per the National Imaging Board, National Health Services.
So your voice is a little feeble. Can you speak a bit louder? Thank you very much. Sorry.
Yeah, almost there is no dedicated pediatric radiographer course, and the tissues are always evolving with the variable ultrasound, CT, and MRI experience and the changes. Hope it's fine, sir, now. Dr. Saurabh, I hope the voice is better.
Yes, it's good. Yeah.
Okay, so we go ahead.
Yeah.
So let's start the pediatric cases and with the take-home points and some tips. We start with the case 1. This was a 22 months old child. It was a girl who presented with the fever and with a very abnormal or maybe the peculiar history for pediatricians. The mother used to tell that the child just keeps hitting her head as if the child is irritable or she's having headache or there's something wrong with the head. But right now I have come with the fever. So as a baseline, a chest X-ray was obtained. Can you just all look at the X-ray carefully? I will just pause for a few seconds. Just have a look at this X-ray. Can you find anything abnormal? This is a 22-month-old female child coming with fever and irritability and a persistent habit of hitting her head with the hands. Okay, so now if you look at the X-ray of the chest, the lungs are pretty clear. You look at the heart looks fine. We are, as a radiologist, we've always been told, always look at the corners of an X-ray. You might pick up something, you might miss something. Just look at the corners. We see the top corners are looking fine. Now we come into this corner. Just look at this corner carefully. Can you just find some motile calcifications here? Good. If you guys have picked it well done. So after this patient X-ray, she has a fever. So everybody was looking for a source of sepsis and ultrasound abdomen was also done. So to our surprise, we found that just close approximating the left kidney, there was a large calcified mass, which was either arising from the left kidney or it is arising from something which is superior to the left kidney and probably the kidney is pushed inferiorly. Now we see X-ray shows calcification, abdomen ultrasound shows a big mass in relation to the kidney. You already know where we are heading. The lab parameters, everything was normal except there was increased in lactate dehydrogenase. I was told that this represents the tissue breakdown, and in most of the cancers, the LDH is usually high. So this is again the ultrasound which shows the left kidney is separate from the mass. The mass is quite big, almost 9 to 10 centimeter in size, and has got motile calcifications. CT scan was done, showed a big calcified lesion on the left side. And this is the pre-contrast, this is the post-contrast. The lesion shows calcifications and a lot of areas of necrosis, which are non-enhancing on CT. This is again the coronal image, which shows a big mass lying in relation to the upper pole of left kidney with calcifications. We all know what we are dealing with. Since the patient also complained of irritability and hitting the head, our pediatrician said, let's do a CT scan as well. When we did the CT, we found there are some extradural deposits which were enhancing. And when you look at the bone window, you see the inner table is not very clear. It's been eroded. You can see there's some hair on here and on appearance. So this is another coronal image of the same child, which shows extradural deposits and with some involvement of the bony calvarium. Orbits were normal. There was no proptosis. So you all know we are dealing with a calcified mass in relation to the kidney with metastasis to the bone and dura. Yes, this was a case of metastatic neuroblastoma. Now, some key points about neuroblastoma. This is the most common extracranial solid childhood malignancy, secondary to brain tumors and leukemia. Though neuroblastoma calcify approximately 90% of time, but only 30% of calcifications are picked up on plain scan, on a plain film. So in a pediatric X-ray, it's very important to look at these calcifications. And this is usually associated with other syndrome. This is a critical concern. One most important differential diagnosis for radiologist is neuroblastoma, and for the pediatrician also, because the prognosis and the treatment varies. Now just see what are the features in favor of neuroblastoma. Neuroblastoma calcifies 90% of times, whereas the Wilms tumor calcifies probably 20-30% of time. Neuroblastoma involves a younger age group, less than 2 years, whereas Wilms tumor is about 3 to 5 years. With neuroblastoma, you have more common to have extension into the chest, and you have bone metastases are very common, also described as Hutchinson syndrome. Lungs metastases are relatively common in case of Wilms tumor. Extension into the spinal canal can be seen in neuroblastoma, whereas it is not heard of in case of Wilms tumor. Retroperitoneal lymph nodes may be big in the case of neuroblastoma, but not with Wilms. And with neuroblastoma, you see less common extension into IVC and renal vein. And in our case also, IVC and renal vein were patent. So we move to the second case. 10 years old athlete boy, he came with limp and there was a pain in the right hip and the right leg. Probably the clinician thought it is some trochanteric bursitis, and in the leg it is probably shin splints. We call medial tibial stress syndrome, which usually find where you find the edema along the shin of the tibia, and is usually seen in the athletes. So as a baseline, X-ray pelvis was done, which was unremarkable. After X-ray, the next modality you order for musculoskeletal condition, we all think is MRI, right? So we did an MRI. When we look at the MRI, this is a T2 coronal stat-sat image. You see some narrow edema here, hyperintensity close to the lateral trochanter, and you see a little bit of soft tissue edema in the surrounding soft tissues. So you are dealing with some inflammatory pathology. This is an axial image. This is known as GRE sequence, which clearly delineates the cortex and medulla. This is a very good sequence. When you look at the cortex here, it looks fine. When you look at the right side, you see there is some cortical thickening, and you see a faint hyperintensity here. Now we know what we are dealing with. We are dealing with a cortical lesion, which has got a central lucency. Okay, so we thought of something, and then we went back to another modality, which is CT scan. We did a CT scan. CT scan showed periosteal thickening, there was cortical thickening and a small central lucency. We also call it central nadus. And this is the corresponding image for this MRI, just to correlate with the CT scan. So this patient also had the pain in the leg. So now we know what we are dealing with. We didn't go to MRI. We did the CT straight away. In fact, the X-ray also retrospectively also showed some cortical thickening. There is some lucency here. CT scan showed this lucency is much clearer. On the axial images, you show cortical thickening and central lucency is also known as central nadus. So now we know what we are dealing with. We are dealing with the entity which is a benign bone tumor, also known as osteoblastoma. But since this lesion is involved in two bones, this entity is known as polyostotic osteoma. Now it is important to know that osteoblastomas are almost always solitary, but when they occur in multiple bones, it's usually the same bone. So, but this is an atypical case where we find osteoblastoma in the two bones, but on the same side of the body. Another important thing to understand with this case is there is a limitation of MRI in the diagnosis of osteoblastoma and maybe for other bone tumors also. So this is a general thing. Everybody says that, oh, you don't see anything on X-ray, just see MRI. So every modality has its importance, as we saw that the CT was more diagnostic in this patient rather than MRI. And another thing, radiofrequency ablation is the treatment of choice for osteoblastoma. The lesion in the trochanter was biopsied. It came as osteoblastoma and the treatment was started and both the lesions disappeared. Now we move to the next case, a 5-year-old girl. She had pharyngitis. She was on antibiotics. She developed fever and dysphagia and vomiting. And she was very irritable. She had some pain in the neck. As a routine, the first X-ray was done, cervical spine. This is a lateral view. Now you should look at the X-ray carefully. There is straightening of the cervical curvature, which suggests there is the vertebral muscle spasm. Look at the air shadow. This looks pretty okay. But do you think this is normally situated? No. This looks a little anterior, to the vertebral column. So this is what we call a retropharyngeal space or a prevertebral space. So roughly the prevertebral space at all level, the anteroposterior dimension of the prevertebral space is equal to the anteroposterior dimensions of the same vertebra at the same level most of the times. So if you look at here, C1, you see this is the measurement here, but this measurement is increased. Even this measurement is increased. Even this measurement is borderline. So
Again, a request a little louder, please.
Yes.
So interesting. Thank you.
So we are dealing with something which is in the retropharyngeal space. So this next modality would be CT scan. We did a CT scan and we saw that there is some collection, hypodensity just in the prevertebral space. Probably there is some collection or there is some abscess formation. Again, we did the same, and the other section shows this collection is going and extending down, probably going into the mediastinum. We extended the CT scan. We saw this collection is extending down into the posterior mediastinum. We took the axial section. The collection was going inside the posterior mediastinum. So what is this? It is a retropharyngeal abscess. Yes, it is a retropharyngeal abscess, but it is a particular type of retropharyngeal abscess which needs special consideration. We call it a danger space abscess. Again, this is a post-contrast T1 sagittal MRI where you see this collection and some granulation tissue and something enhancing within this collection. Probably there was some few faint foci of calcification also. So what is this danger space abscess? This is unique to infants and young children, usually between 6 months to 6 years. It starts with the upper respiratory tract infection and it corresponds to adenitis, then it goes to abscess. Now we should know that there are a lot of lymph nodes in the retropharyngeal space. The culture is usually mixed aerobic and anaerobic. But in the case of adults and older children, this space is usually closed and this is not very accessible. So peritonsillar and parapharyngeal abscess are more common than the danger space abscess. Just to show you guys what the danger space means, the yellow one is the retropharyngeal space, which we call true retropharyngeal space. And this is the red one is the danger space, which extends from the clivus and extends down into the mediastinum. Please note that the true retropharyngeal space doesn't go inside the mediastinum and it usually ends at C7, T1 or at the most T2 vertebral body. So what is the dangerousness of this danger space abscess? It can lead to a descending necrotizing mediastinitis. It can lead to thrombosis of the jugular vein. It can lead to the compromise in carotid artery, sometimes rupture also, pseudoaneurysm also. Can lead to pericarditis, tamponade, bronchial erosion, and pneumothorax. So in the case of deep abscess, danger space abscess, what is the take-home point? Whenever you see an abscess in the retropharyngeal space, which is extending below T2 level, you have to think of a danger space abscess rather than a true retropharyngeal abscess. So whenever you get a child and when a radiologist tells you the report, please ask the radiologist, doctor, is it going below T2? If it is, yes, you're dealing with a danger space abscess and you need to have a more aggressive treatment because there are potentially fatal complications like mediastinitis. There may be a carotid artery or jugular vein compromise and it can lead to pericarditis or pneumothorax. You go to the next case. Now you have a 12-year-old girl. She came with a backache. This is the X-ray which was ordered. This is the X-ray lumbosacral spine. We have an AP view and then you have a lateral view. Just look at this X-ray. Can you pick up something? This X-ray was reported as normal. We go to the next X-ray. She came a week later again with a low backache and pain in the right hip. So the X-ray pelvis was taken AP view and frog lateral view. Can you see anything abnormal in this X-ray? You know, the beauty about radiology is the body is bilaterally symmetrical. You know, if you have a midline, you have a symmetry on both sides. So you can always compare left with right and right with left. So if you compare both sides, just see if you can pick up this lucency here, which is not here. Right? So this doubt was raised and the patient's symptoms were also on the same side. Even the lateral view showed a little bit of X-ray here. Probably there is some lesion here which surrounding sclerosis with pain. Probably we are dealing with an infective or inflammatory etiology. The next modality in this case would be an MRI. So the MRI was done. These are the coronal images. You just see close to sacroiliac joint on the iliac aspect. You see some abnormal marrow edema. Further section again shows some narrow abnormal edema on both sides of the sacroiliac joint. Again, you see this narrow edema. These are the fat side images where the edema appears like intense. So you have the narrow edema, you have it on both sides of the joint. So this was a case of chronic recurrent multifocal osteomyelitis. It's important to know because it is also a non-bacterial osteomyelitis. It is a non-infectious cause and the culture is usually negative and the inflammation is because of the autoinflammatory process and not because of infection. It usually affects the long bones, pelvis and the spine, and in the spine it also produces vertebral plana. Lymphoma is also another common cause of vertebral plana. The inflammatory markers are elevated and the treatment is symptomatic and it's based on the pain and disability, and its NSAIDs are usually given, corticosteroids or disease-modifying antirheumatic drugs. No role of antibiotics. This was proven on biopsy. We move to next case, a 10 years old girl. She came with dysphagia for both solids and liquids. Dysphagia is very rare in pediatric age group, but this girl presented and a chest X-ray was done. The chest X-ray, just look at this X-ray carefully. Can you pick up something? We look at the lungs, everything looks fine. When you look at the mediastinum, can you see this widening of mediastinum here? And you can see some faint lucencies here. So we are dealing with something which has gas inside. Probably there is a mediastinal abscess, or we are dealing with some hollow organ, viscous, which has gas, probably esophagus. So the next modality would be a barium study. We did a barium swallow study. We saw there was markedly distended esophagus. This is the AP view, this is the oblique view, this is the lateral view, and this is the oblique views. You see markedly dilated esophagus with multiple filling defects, likely due to food residue. And there is smooth narrowing beaking, which we call the bird beak sign. So this was a case of primary achalasia. Now, primary achalasia cardia in children is rare and usually no cause is identified. The diagnosis is usually based on a classical barium study and manometry. So it's basically because of there is a failure of the organized esophageal peristalsis secondary to the impaired relaxation of the lower esophageal sphincter. There is the esophagus dilates and there are a lot of foods and secretions and the child complains of dysphagia. So the diagnosis is by characteristic radiograph finding plus the manometry. The treatment is by pneumatic dilatation. You can do it once, you can do it twice, but if the child needs more than 2 dilatations per year, then the surgical procedure should be taken. It's either higher Heller myotomy or it is combined with the fundodilatation plus or minus. It's very important to keep this in doubt, do this diagnosis in consideration, because not every time the patient is malignant, there is some organic cause also. We go to another case, 12 years old girl. She's got a severe abdominal pain and she has a distension. When you look at the X-ray, abdomen was done, erect and supine. We see a large bowel loop which is gas filled. There is some fecal matter also which shows that this is a large loop. There is relative paucity of the small bowel gas. You again see a large loop. So probably there is some cause of large intestinal obstruction. So the next modality would be a CT scan. We did CT, we saw there is a large loop, large bowel, which is dilated. This was the sigmoid tube. We gave a rectal contrast and we saw there was leaking on either side and there was a slight twist with a narrowing in the center. This is what is known as a sigmoid volvulus. The pneumatic reduction was done and this is a post-procedure X-ray where you see the colon has been deflated and the patient is fine. So just a few points about sigmoid volvulus. The median age is about 7 to 12 years. The patient usually presents with acute symptoms and the duration of symptoms is usually 1.5 hours. Spontaneous detortion is usually followed by passage of stools and flatters. So this condition is usually misdiagnosed as constipation. So whenever you have a patient which is giving a history of passing of stool or flatters, and he had a distension, then he passed stools, he got better, always keep sigmoid volvulus in mind. Some points about sigmoid volvulus. X-ray abdomen is the initial X-ray which you should do, but the diagnosis only picks up in 70 to 30% of case versus the 60 to 90% in adults. Barium enema obviously increases the radiological diagnostic sensitivity. Treatment is, if the patient is stable, you just do a non-operative reduction, pneumatic reduction, either by the endoscopy or by barium enema. If there is conservative treatment failure or the patient becomes unstable, like signs of peritonitis or he has perforation, then the surgery is the method. We move to next case. A 12-year-old girl, she had loose motions and she had pain in the lower abdomen. She had similar episodes in the past, and her total leukocyte count was raised, and so was the CRP. So the X-ray abdomen was advised. Just look at this. X-ray abdomen was advised, and it was we could not pick up anything on that. After that, we thought we'll do a CT scan. These are the images taken from a CT scanogram. See if you can pick up any abdominal bowel pattern. I just pause for a few seconds. This is first scanogram, and this is the second scanogram. Okay, when we look at the scanogram, the bowel loop looks fine. There is no pneumatosis, there is no pneumoperitoneum, there are no abnormal dilating of loops. But when you just come little down, you see this right abdominal area, you see few lucences here. When you look at it carefully, you again see few lucences here, which are going down, 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 almost overlapping the right ischium. This is not a place where a normal bowel is. So probably you are dealing with some bowel which is going there, which has gas, probably some internal herniation, or we are dealing with some inflammatory process which is producing these gas bubbles. So let's see what the CT shows. When we look at the CT, the bowel is dilated, there is large bowel thickening. This is the descending colon, which shows circumferential wall thickening. Then we go into the pelvis, we see the circumferential wall thickening of the rectum. Plus, this is the main lumen, but we see a small centric lumen also, which contains some gases. Some air is there. Again, you see this air is tracking down, which is external to the lumen of the rectum, going into the perineum, almost reaching the pubic symphysis. So we're dealing with an inflammatory process, which is causing thickening of the large bowel with a surrounding abscess or fistula formation. So the MRI was ordered just to rule out any fistula, which shows a lot of inflammatory changes. These are all axial or coronal post-contrast images. The enhancing tissue, the tissue which looks bright or white, is the abnormal one. We see the bowel thickening. We see a lot of inflammatory changes. This is the abscess formation. This is abscess formations here also. Then we see a small fistulous tract which is going down. So this is a case of Crohn's disease. We move to the next case. The patient, a girl, she was mentally retarded. She presented with upper abdominal pain. She's 9 years old. Just look at the X-ray if you can pick up something. X-ray abdomen was done. This was a supine view. We don't see any abnormal dilated bowel loop, but if you look at carefully at the epigastrium or maybe the left hypochondrium, you can see a small soft tissue density here, which is probably indenting the bowel, underlying bowel, probably the colon. So what are the organs which are lying here? Maybe colon, maybe you're dealing something with the stomach. So the next modality which was offered was we did the ultrasound for this child.
Ultrasound. We got 10 minutes more so that there will be 10 minutes for question and answer also.
Okay. So we go faster then. Huh? So we have a lesion in the epigastrium which shows a echogenic shadow, which says probably there is some gas inside. We did a CT scan. We saw a distended stomach with a hypoattenuating lesion. Please note that the lesion is completely surrounded by the normal air and there is no attachment to the wall. This was a case of essentially removed the full bag of hair plus which is going inside the small bubble also. So this was a case of trichobezuar, also known as Rapunzel syndrome. Yes. We have another 20 days old child who came with a respiratory distress. X-ray was done. It shows a consolidation on left side. The left hemidiaphragm is not fully well visualized, and there is a small opacity on this side. The patient had since had the pneumonia. The X-ray abdomen was also done. In the X-ray abdomen, the left kidney was not visualized, but when we extended the ultrasound to the chest, we saw the kidney in the left hemithorax. CT scan was ordered and showed the left kidney in the hemithorax, which is going along with the bowel. So this was a case of congenital diaphragmatic hernia with the ectopic left kidney in the left hemithorax and some ectopic changes in the left lung. Another case, you have 10 years old girl who presented with a cough with previous history of reported pneumonia. We saw a plain X-ray shows a little bit of haziness on the right side. It is normal or abnormal. We see the clavicles are equidistant from the spine, so probably the patient is not rotated. So a lateral, everybody thought that this is some middle lobe pathology. A lateral view shows nothing here, but shows some shadow anteriorly. CT scan was done, shows a pectus excavatum deformity, nothing wrong with the lungs. So pectus excavatum, just look at this normal lung and first look at this pectus excavatum. In this case, just see the left apex is elevated, the right hard border is not very clear. And you look at this rib, the ribs are vertical rather than being horizontal. So whenever you see this picture, just think that you might be dealing with a chest wall deformity rather than with the lung lesion, because this child has taken a repeated antibiotics despite any treatment, despite any improvement. The take-home message is when interpreting chest X-ray, in the case if you find a disparity between the visual and clinical findings, chest wall abnormalities should be kept in mind. Another case could be a Poland syndrome where you don't see a pectoralis region. So we have another case, 8 years old boy with scrotal pain and swelling. There was history of recurrent abdominal pain. Testis ultrasound doesn't show any torsion. When we looked at the small bowel, we saw a lot of bowel edema. The muscle is thickened. Even the CT showed bowel thickening and bowel edema. There was characteristic lesion on the skin. Yes, you all know we are dealing with IgA vasculitis, also known as hemoptysis. Next case is 11 years old girl who complained with the plain abdomen, raised CRP and TLC. There was no fever. She presented with loose motion. Abdominal X-ray was normal. 1 week later, again, she came with the loose stools and fever. You look at the sigma, the lower descending colon. You see some wall thickening, which is normally described as the thumb printing. Probably you're dealing with inflammatory pathogens with large bowel. A CT variant study was done, which shows the wall thickening and the thumb printing and the descending in the transverse colon. Coronal CT scan again showed the wall thickening and some inflammatory changes. Yes, 1 month, so we know what we are dealing with, probably ulcerative colitis or a Crohn's disease, and she was to put on the treatment. 1 month later, she came with an abnormal fever and some rankle in the chest. The chest X-ray shows a ill-defined haziness in the right apex. 1 week later, this haziness has increased. We did a CT scan, we find multiple nodules in both lungs. Please note that these nodules are all cavitating. Just look at the other images. So this was a case of ulcerative colitis with necrobiotic pulmonary nodules, which is an extra abdominal manifestation of ulcerative colitis. Another case would be 11 years old child with cough and fever. You look at the X-ray. This was not picked up before, but when you look at it retrospectively, there is probably a small cavitating area in the left suprahilar location. Came back with, after 2 years, we did a CT, there were bilateral cavity lesions, probably pulmonary tuberculosis, put on treatment. 3 months later, she came with a neck abscess with the destruction of vertebra and a perivertebral abscess formation. These are the MR images. Then you look at the CT, you look at this destruction of the vertebra and this vertebra and soft tissue collection.
But we got little voice. I think there is a background noise in your this thing muffling your nose. If you talk louder, that will be muffled. Thank you.
So this was a case of tuberculosis, pulmonary and extrapulmonary tuberculosis. So take home message is this case is a back pain in a child is a red flag and it always necessitates an MR imaging. Another case, there was a 9 years old girl with respiratory distress. You see a haziness of left eye. The X-ray was done, haziness on left side. We have a small nodular opacity on the right side. CT scan showed multiple cystic lesions in both lungs. Yes, we know we're dealing with hydatid cyst. It was operated and multiple daughter cysts were excised. So this was a case of pulmonary hydatid cyst. Another case, we have a 3-year-old small child, small for gestational age female child with simple umbilical artery presenting with convulsions. A neurosonogram was obtained and you see a few tiny hyperacute areas which are abnormal, maybe some hemorrhages, maybe revolving infarct. Then an MRI was done. These are diffusion weighted images where you see multiple areas of restricted diffusion on both sides of the hemisphere. These are the skin area where you took the photographs. You can see these characteristic skin lesions. I've been told by pediatricians these are characteristic skin lesions. These are in the upper limb and the lower limb. Then you have ischemic strokes. So this was a case of incontinentia pigmenti. Probably they have done a genetic genomic sequence. The result has not come, but this is most likely a case of incontinentia pigmenti. So this presents with the 4 classical cutaneous phases with microcephaly, ischemic strokes, and genetic mutation as the cause. Another case, we'd see a 9-year-old girl with the colicky pain. Abdomen X-ray doesn't show anything. CT was done, shows dilated bowel loops and a small bowel loop which is not distended with contrast. Another, you see this in the same area of the bowel loop which is not distended with contrast, you find paucity of the bowel loops. We are dealing with something internal herniation or torsion. This patient had severe pain. She was operated and she was found out to having a C loop obstruction secondary to a congenital band. This is a CT and this is the correlative intraoperative picture. You see this bowel loop which has in a C loop which was obstructed due to this band. This is the C loop and these are the bands, congenital bands. Another, we have a 6-year-old child who presented with the flu-like symptoms. There was a cystic lesion in the lung, probably thought to be a CCAM, congenital cystic adenomatoid malformation. But after 6 weeks, it increased in size, and after 6 months, it became a big mass. So this was a case of pleuropulmonary blastoma. Just few words about pleuropulmonary blastoma. This is a type of congenital cystic adenomatoid malformation. There are about 4 types, and it is associated with the gene mutation. So basically, the take-home point is that any cyst or pneumonia which is unexplained, or any pneumothorax which is again unexplained for 2 to 3 weeks, which doesn't reduce or increases in size, will need a further investigation. Another case is a 10-year-old boy with history of fever and status epilepticus. You see the CT scan was done, edematous thalami, edematous brainstem. This was a case of acute necrotizing encephalopathy of childhood. This is a rapidly progressive encephalopathy. The causes are influenza, herpes simplex, and mycoplasma. I have been told that COVID is also causing this type of encephalopathy in some parts of India, though I have not encountered anything in Dubai. And diagnosis is based on the lab and CSF analysis. Another case, an unconscious 12-year-old boy came with a bleed in the left hemicerebellum. This MRI was done to prove that is there any mass which is bled. There was no mass, and it was thought that maybe we were dealing with AVM. DSA was done. You can see these arteries, and you can see the nidus here, and then you can see the draining veins. Again, you can see all the arteries. We are reaching the nidus, and you can see the draining veins. So this was a case of AVM. So let's talk a little bit about pediatrics and COVID infection very fast. Children with COVID-19 disease are less symptomatic, we all know, but they can be potential agents of transmission. Now we have the variants which might be affecting kids, but still they are less effective and symptomatic than the others. Most children with symptoms from COVID disease, cough, fever, respiratory difficulty will show abnormalities in chest X-ray. So findings in chest X-ray are usually non-specific and are superimposed on the other viral pneumonias. Peripheral distribution of the lung abnormalities is not a distinctive feature in a pediatric population as compared to the adults. And chest X-ray does have a role in management of the disease in children. So when do you do a chest X-ray? In a neonates, if neonate has a fever and a respiratory symptom, do a chest X-ray. In a child, if you are suspecting COVID with mild symptom, don't do a chest X-ray. But if you are suspecting COVID in a child with a moderate or severe symptoms, which you feel needs hospitalization and follow-up, or you want to assess the evolution and treatment response, please do a chest X-ray. CT scan also has a role in imaging, but this is only limited to answer some clinical questions as the radiation is involved. So CT scan is indicated when you have acute symptoms or you have some worrisome abnormal laboratory findings such as the D-dimer is raised, or you want to evaluate a child which is demonstrating clinical deterioration or is not responding as expected to the supportive treatment. And also we want to evaluate any pulmonary or extrapulmonary complications of COVID or after an invasive procedure. So the radiological pattern in children in order of the decreasing frequencies are peribronchial thickening, this is the most common thing, groundless opacities, which are usually peripheral and subpleural, which are usually seen in adults, which is the most common manifestation. While in kids, peribronchial thickening, which is central, is the most common manifestation, though the sensitivity is very less. Now, other findings you can find is consolidation, chest will be normal, and you can find infusion. Now, just to show you how does a peribronchial coughing looks like, you look at the central bronchi, they are echogenic, wall is thickened, and you see a thickening and echogenic walls. Again, you look at the peribronchial coughing, you look at the bronchi, you see the wall is thickened, it's like a ring line. This is the peribronchial coughing. The ground glass opaciness, we all know these are ground glass haziness, where you can see the vessels through that. When it becomes more, it becomes a consolidation, which is again subpleural. This is just a good slide, just I came through just to show the extrapulmonary involvement of COVID now. So you see almost all the symptoms are involved. This is pretty interesting. We have a multisystem involvement and a Kawasaki-like disease in about 20%. This has been taken from Journal of Pediatric Radiology and pretty recently. So extrapulmonary COVID manifestation, just to name of them, there is something known as pediatric multisystem inflammatory syndrome, autonomic PMS. Then there are coronary artery dilatation, aneurysms. This mimics Kawasaki-like syndrome. The patient can present with SGH or SKH. The child can have pulmonary hypertension, cardiomyopathies, and thromboembolism, just to mention a few extrapulmonary COVID manifestations. Now I have some few quick quiz questions. Should I go ahead, Dr. Saurabh?
Yeah, with loud voice, because there is a background noise muffling your voice.
Okay.
Maximum, you put your voice to the maximum volume.
Okay, so this is a quiz. This is a spotter. I will put 5 cases here so that everybody can just mention the answer in the chat box and Tawfiq will pick up the winner. So this is a newborn with the X-ray abdomen and X-ray chest. So I want you to mention 3 salient abnormalities. I will wait for 30 seconds. This is a newborn with respiratory distress with an X-ray abdomen and chest. I want to pick 2 or 3 salient abnormalities.
You can go to next cases.
Yeah, so this is the quiz second. This child came with wheeze and abnormal heart murmur. Just look at it. Do you think this is normal or abnormal? And if it's abnormal, what is the abnormality? Do you think the mediastinum is abnormal or the heart is abnormal? I just need one diagnosis. I will give you one clue. Are we dealing in something in the mediastinum or we are dealing something with the heart? Please mention your responses in the chat. Okay, you go to third. It's a pretty simple spotter for meditation. Abdominal distension. I think we move on to next quiz. This is a 1-month-old child with torticollis. This is a ultrasound of the neck. It shows thickened sternocleidomastoid muscle. I need one word for this entity. Thickened sternocleidomastoid muscle as compared to the other side, causing torticollis. Okay, this is quiz number 5, the last one. Newborn with respiratory distress. Something wrong with the thorax? I want you to pick up the abnormality. Just one word. Newborn with respiratory distress.
Dr. Bushra, Dr. Leila, 5 minutes time we have for question and answer.
Okay, so we just go briefly to mention the artificial intelligence in pediatric radiology. We all know if you look at this is pretty complex. Even artificial intelligence has ventured into almost all aspects of pediatric radiology. You start with oncology, then you have emergency care, then you have pattern recognition of small muscle lesions, then you have brain mapping, then you have developmental disorders. The list is never ending. Just to mention a few, this AI would help us to find faster and the more sensitive and specific detection of some of the early fracture in pediatrics. It can detect the early cancer, especially in the lungs, using a low dose CT. It might be very helpful in determining the bone age. So the take-home message from my presentation is always ask for the imaging workup whenever you encounter any red flag sign or symptom. Backache is one in kids. Please do talk to a radiologist before, during, and after requesting any imaging modality. Please help us to help you guys. Please help a radiologist with the history, sign and symptoms to help you, because after all, it's a teamwork. These are my references, and thank you very much.
Dr. Bushra, please.
My video is not functioning. The video is not functioning, but do you want us to? Yeah,
Dr.
now,
Lena,
yeah.
you can-
Okay. Thank you very much. Thank you very much, Dr. Vikrant, as usual, very nice. And congratulations for the medals behind you. Are they for radiology or something else? Anyway, yeah. So Dr. Leila, can you join us, please? I don't know. Dr. Leila?
If
Yes.
anybody has any questions
Yeah.
from
Yes. So there are questions, Dr. Leila, from Dr. Ayman. Can you please?
Yes. There is one question from Dr. Ayman Al-Jundi. What are the radiological characteristics of Crohn's disease in children?
Okay, so we've not had many cases of Crohn's disease in children in our setup. We have probably seen only 2 cases. For me, the wall thickening, especially of the large bowel, especially the rectosigmoid, and perirectal fat stranding and inflammation, formation of abscess, fistula formation, and skip lesions, along with mesenteric lymphadenopathy. These were the main findings which I saw in a case of Crohn's disease in the abdomen. Yeah.
Okay, thank you. Actually, we need this presentation with more time, not in hurry like today.
I had to rush it up. Yeah, I had to show all.
Yes, it is very.
Yeah, time is there. Now, I want to ask one question, if Dr. Bushra permits me. Dr. Vikrant, when we get a plain X-ray of the abdomen and plain X-ray of chest, what pediatrician should look? Suppose they kept an X-ray in front of me, what we should look not to miss?
So that's what I said, see, pediatrics is not easy, sir. And pediatric radiology is certainly not. So when you look at the pediatric X-ray or an abdomen, the beauty about a radiology or an X-ray is that it is bilaterally symmetrical. So what you see on the left side, you compare with the right side and vice versa. So you should always have a checklist. You should always have a checkpoints. Like you start with the chest X-ray, you always look at the lung, then you look at the mediastinal contours, then you look at the aortic arch, then you look at the apex, then you look at the diaphragm, then you look at the hidden areas which are supraclavicular and the infradiaphragmatic region. Then you decide which one is more opaque or which one is more lucent. Then you look at the bony thorax. I know theoretically it is very easy, but when it becomes a habit, you pick it up, And if you X-ray abdomen, you should pick up pneumoperitoneum. You don't want to, miss that. And then you pick up intestinal obstruction if any features is there, abnormal bowel shadows in it. Yeah. And second important, which I said, is abnormal calcifications. Which
Leila, please.
Diagnosis.
Dr. Bushra.
So it's just one question, Dr. Vikrant. The dangerousness abscess, what happened to that girl? Do you know? And do we need to do X-ray like after surgery, or any radiology modality? What happened to that patient with dangerousness abscess?
Yes. This patient X-ray, they put her on antibiotics, aggressive treatment. She did not respond. Then probably they had to open her up and they had to do the transmediastinal drainage of this abscess. And after that, she improved. And then she left to India. She was lost in follow-up. But I was told that a follow-up CT showed a significant improvement. And she's doing much better now.
Yeah, okay. So we will need to repeat the CT scan.
Yes.
Okay. Regarding the case with Crohn's disease, was the X-ray supine?
Yes.
Or erect?
No, it was a supine X-ray, yeah.
Supine X-ray, yes. So, Dr. Zohrab, I mean, we have questions. Can we continue, or you said it's the prayer time? So whatever you...
We have to stop. I'm very sorry. We can do one thing. We'll arrange another session with Dr. Vikrant, only radiology during DPC. Then we'll discuss 1.5 hours, because now is the prayer time. We have, I mean, to stop. I'm very sorry for that. But Dr. Vikrant is with us. We won't leave him.
Doctor, what about the quiz questions? People are asking if you can quickly tell them the diagnosis of the 5.
Okay, I will just go back.
Dr. Vikrant, tell the diagnosis of the 5 quiz. Loudly, please loud. Your voice today is not, I mean, audible.
No, his voice is okay. It's just the background noise.
Okay. So, this is the first one. Oh, sorry. Yeah, this is the first one. I wanted you guys to pick up 3 abnormalities. First is we have pneumothorax. Second, we see a then you see the liver on left side. This is situs inversus. So 3 things. Next is this quiz. This is a very dear X-ray to Dr. Sohrab. He was the one who diagnosed. We all thought that this is a boot-shaped heart of tetralogy of Fallot, and a CT scan was also done. This is just a thymus. This Dr. Sohrab very rightly picked it up. He said this is thymus. This is not a boot-shaped heart of her. Now let's see what is going against a boot-shaped heart. You know, in a boot-shaped heart, you will always find the apex, which is gone a little up. You know, it's lifted up, and the pulmonary conus is concave. But it's everything complex here. And when you look at the right heart border, you see it is little wavy. You know, we call it wave sign of Mulvey. This is the area where the thymus touches the costochondral junction and it gets indented by the costochondral junction. So it shows a wavy sequence. So this was basically an enlarged thymus. This we all know, necrotizing enterocolitis. There is pneumatosis intestinalis. This is fibromatosis coli. You can call it a stenomastoid tumor. And this is Dr. Bushra already knows. This is pneumomediastinum. You saw the Gulving sign. This is the thymus which is lifted up because of pneumomediastinum. This is very difficult to pick up, but this saves the life of a child. So this is pneumomediastinum. That's it. These are the 5 quizzes.
Thank you very much, Dr. Vikrant, for excellent presentation, but we won't leave you. We will have another session. Thank you very much, Dr. Bushra. Very sorry this session, you know, because of
But we will not leave him, as you said.
Thank you, Dr. Leila, Dr. Kalpana. I would like to request all viewers to join us at 1 o'clock. We are going to have pediatric cardiology session with eminent cardiologists from India and from UAE. So sharp 1 o'clock, we are going to start. We'll have a panel discussion. So see you at 1 o'clock after break time. Once again, Dr. Vikrant, thank you very much. I know that, I mean, it requires 2 hours really time to discuss. Dr. Bushra, Dr. Leila, Dr. Bushra from Canada, thank you very much.
Thank you very much.
So we will see you at 1 p.m. Thank you.
Thank you. Thanks, everyone. God bless you all. Bye-bye.
Thank you. Thank you. Thank you. Thank you very much.
Good afternoon, ladies and gentlemen. Welcome to this afternoon session of the 7th Annual Dubai Pediatric Club Virtual Conference. I would like to welcome you once again. This afternoon, we have a pediatric cardiology session. We have eminent speakers from India and from Dubai, UAE. Dr. Debadatta from India, Calcutta, and Dr. Muhammad Sulaiman and Mahmoud Sufi, well known from Dubai. Well, this session is chaired by Dr. Srinivas Bandari, one of the senior most pediatricians in Dubai. Dr. Bandari is a senior specialist pediatrician at NMC Specialty Hospital, Dubai. He is a member of organizing committee of the Dubai Pediatric Club. Now I would like to request Dr. Bandari to join us and introduce the moderators and the speaker and panelists of the pediatric cardiology session. We will have presentation for half an hour, followed by panel for 1 hour. Dr. Bandari, please welcome. Dr. Bandari. If Dr. Bandari has not joined, I can go ahead and introduce the moderator and speakers. Mr. Tawfiq.
Yeah, Dr. Bandari is joining, Doctor.
Joining, okay. So we'll have a very good presentation and discussion. Dr. Mahmouda Sufi is going to talk about the management of congestive heart failure from newborn to adolescent, followed by a panel discussion. Of course, the panelists also will present interesting cases and there will be a very good discussion. Dr. Bandari, welcome. I would like to request you to introduce the moderators of this session and the speaker and panelists. Welcome. Yes, Dr. Bandari. Good afternoon, welcome.
Good afternoon. It's a great pleasure to join the cardiology session. At the outset, I would like to thank the President, Dr. Sohrab, Dr. Joshi, Dr. Kalpana, all the organizing members for giving me an opportunity to chair the session. And till now, we had a wonderful session. And now we are going to have a cardiology session. Let me introduce the moderators of the session. Dr. Muhammad Amir Suleiman, the specialist pediatrician, Emirates Hospital, the clinic Dubai, and Dr. Rashid, Dr. Khalid Rashid, specialist pediatrician, Dubai Police Associated Healthcare Service, Dubai. And the speakers, Dr. Muhammad Al Sufi, the consultant pediatric cardiologist, Al Jalila Children's Hospital, Dubai, Dr. Devdutt Mukhopadhyay, consultant pediatric cardiologist, associate professor, West Bengal University of Health Science, visiting consultant pediatric cardiologist, Apollo Gleneagha Hospital, Calcutta, India. And Dr. Muhammad Suleiman, assistant professor, Columbia University, New York, USA, and the co-founder and CEO of Kids Heart Hospital, Heart Medical Center, and co-founder of Medical Health Center, Dubai, UAE. I welcome you all. And now I'll hand over to our moderators to go on to the procedures.
Okay. The presentation will be given by my very precious friend, colleague, and colleague, Dr. Mahmoud Sufi, is a consultant pediatric cardiology at Al Jalila Children's Hospital. He will speak about heart failure therapy. Move to Dr. Mahmoud.
Thank you, Dr. Amir. Good afternoon, everyone. I would like to thank the organizing committee for inviting me to give this lecture and to participate in such a wonderful event, Dubai Pediatric Club, 7th annual meeting. Let me share my slides. Can you hear me?
Yes, please. Yes.
Yes, doctor.
Can you see my slides?
Yes, doctor.
Okay. So actually, as you know, heart failure, it's a subspecialty in cardiology. It's not a disease because there is a wide range of pathophysiology, of different mechanism, different etiology, different treatment options. So you cannot cover the heart failure in one topic. However, I will try to focus on about the presentation and the management of heart failure in pediatric age group. My presentation will contain the following, like the definition of the heart failure, pathophysiology of the heart failure from fetal to adulthood, different mechanism, different presentation, the management of the heart failure, what about the rehabilitation in the heart failure, which is a new concept, and what are the new devices in the management of heart failure. As you know, heart failure, according to the new definition of American Heart Association, it's a syndrome. It's not a disease because it affects the all organ, all over the body. So the heart failure, by the new definition, is a syndrome characterized by either or both pulmonary and systemic venous congestion and or inability to meet the metabolic demands at rest or during exercise, caused by either structural or functional impairment of the cardiovascular system. So it's a big definition for the heart failure. What about the normal physiology? As you know, the heart acts in two phases to supply the oxygen demands to the whole body. The diastolic phase, which is a filling phase, what we call it also the preload. During this phase, the heart will be loaded by the blood. Then the heart, as a pump, ejects this blood against pulmonary and systemic vascular resistance. And this is what we call it the afterload pressure. So to achieve such a great job properly, you have to have a normal preload, you have to have a normal pump, normal and healthy pump ejects the blood against normal afterload. If there is any abnormal components, the oxygen supplier or the supplement of the oxygen to the whole body will be affected, and the heart failure symptoms will be present. This is the same, just to like a cartoon about what do we mean by preload, the volume of the blood in the ventricles, which can be increased in hypervolemia, valve regurg, afterload, which is a resistance against the ventricles, which can be increased in hypertension, vasoconstriction. And we can conclude from this diagram that the main mechanism or main pathophysiology of the heart failure, it can be due to volume overload like left to right shunt congenital heart disease, or due to valve regurgitation, which may load the cardiac chambers and increase the volume overload, or due to failing pump like different types of cardiomyopathy, or due to increased pressure overload like left ventricle outflow tract obstruction or right ventricle outflow tract obstruction. What are the causes of heart failure in children? According to this paper, which was published from CHOP, Children Hospital of Philadelphia, in children, we have wide variety of heart failure etiology. But the commonest etiology of heart failure in pediatric age group is congenital heart disease, as you know. 57 of those patients has a congenital heart disease. Cardiomyopathy in 26, acquired heart disease in 14%, and arrhythmia contributes in 3% of all mechanism of heart failure in pediatric age group. Those patients with heart failure in pediatric age group may be admitted to heart failure, acute heart failure decompensation with 16% mortality in ICU, 20% ICU readmission, about 60% mechanical ventilation, and 10% required CPR. That means the etiology or the causes of heart failure in pediatric age group is totally different from adult, which is mainly related to acute MI or inflamed myocardium due to myocarditis. Just a quick review about the different causes of volume overload, like left to right shunt, ASD, VSD, PDA, AVSD, valve regurg, AV malformation. As you can see, this is a AV valve regurg, and this is a atrial septal defect loading the right heart with extra volume. What about the not moving? Okay, I'll go back one slide. Okay, so pressure overload, either due to right heart outflow obstruction, like a pulmonary stenosis or pulmonary venous stenosis, total anomalous pulmonary venous return with obstruction, or mitral valve stenosis, left heart outflow tract obstruction, like critical aortic stenosis or severe coarctation of the aorta. So those lesions may cause significant pressure overload and leads to signs of heart failure. Pump failure, if the myocardium got affected due to different types of cardiomyopathy, dilated, hypertrophic, or restrictive cardiomyopathy, of course, this leads to varying degree of heart failure, rheumatic fever, Kawasaki, myocarditis. Recently, we have what we call it MSC, MESC, or MESC, or whatever you want to call it, metabolic diseases, which may affect also the myocardium in different ways and leads to failing pump and heart failure. On top of that, some patients, they have a genetic contribution, like Turner syndrome, Down syndrome, Holt-Oram syndrome, Noonan syndrome, and Williams syndrome. Those patients has high risk to have a congenital heart disease. On top of that, they have a shared genes which may affect even the myocardial cells and cause cardiomyopathy on top of a congenital heart disease. Also, we have to remember that there is acquired pathology, like some patient with congenital heart disease. On top of the congenital heart disease, cyanosis itself, it may affect the growth of the myocardial cells and the function of the myocardial cells, perioperative hemodynamic instability, and the treatment. All treatment, it has effects and side effects, as you know, surgical trauma during the surgical procedure, and the myocardial damage during the cardiac bypass. On top of that, the reperfusion injury. All of those pathologies can be added on top of the underlying congenital heart disease or acquired heart disease to add more pathophysiology to the myocardium. Heart failure may present in all ages, including fetuses, infants, early childhood, until adulthood. Yes, there is different list of differential diagnosis according to the age group. For example, in fetuses, the main mechanism or pathophysiology of the heart failure is arrhythmia. Then maybe an inflammatory disease, but the congenital heart disease will not present, as you know, during fetal period. Infancy and early childhood, the main mechanism, a congenital heart disease, mainly the complex congenital heart disease. Moving to elder age group, maybe the acquired heart disease like rheumatic fever or inflammatory mechanism like myocarditis, or even those who has a congenital heart disease and they reach the adulthood, what we call it adult congenital heart disease mechanism. On top of that, they have also, if we move toward the adulthood, the coronary disease pathology. Heart failure in fetuses, what's the main features or presentation? IUGR, ascites, or hydrops fetalis, as you know. So the failing heart during fetal period due to whatever the mechanism, as you can see from this diagram, there is fetal tachyarrhythmia, which may lead to heart failure, hydrops, and ascites. And this is also bradyarrhythmia due to congenital complete heart block. In infants, the main presentation will be tachypnea and diaphoresis during feeds, early fatigability and irritability. The baby will be unable to complete the bottle, and there is variant degree of poor weight gain and failure to thrive, and even this may affect the mental growth or mental development of the infants. Early childhood period, those patients may present with signs of congested digestive system, like abdominal pain, nausea, vomiting, and poor appetite, poor weight gain, easy fatigability, recurrent chest infection, recurrent wheezy chest, which may mask sometimes the common non-cardiac pathophysiology like asthma or hyperactive airway disease. So we have to be careful that some of those presentations may be related to a failing heart behind. Moving toward older children, of course, they will start to participate in competitive sports and more activities, so they will get tired much easier comparing to the normal child. Anorexia, abdominal pain also due to congested stomach and bowel, wheezing, dyspnea, edema, palpitation, signs of variant degree of pre-syncope or syncopal attack due to inadequate cardiac output, also may present in older children. Now, how to diagnose the heart failure? Of course, the key of the diagnosis to get a full and detailed medical history about the symptoms when it was started, followed by a complete family history to rule out any familiar congenital heart disease, then a detailed physical examination, and you know all about the steps of cardiovascular examination, so no need to mention that. Of course, to support your clinical diagnosis, you have to ask for some investigation tools like chest X-ray, ECG, echo, biomarkers like CKMP, BMP or PMP, troponin, and sometimes we have to be more advanced and ask for cardiac MRI or cardiac biopsy to define what's the main mechanism of the heart failure. Those are some examples about the heart failure chest X-ray. You can see huge cardiomegaly on the chest X-ray and different degree of congested lungs and pulmonary edema. By ECG, what we have to look for, we have to see signs of left ventricle strain like very tall, R and left leads, ST changes, all signs of LV strain, left axis deviation. Sometimes we have to be very careful about malignant arrhythmias like ventricular arrhythmia. Also, please don't forget a very important mechanism of heart failure in children, which is Al-Kappa syndrome. Al-Kappa, just look at the ECG in any infant or newborn with heart failure and see if there is any deep Q wave in lead 1 and lead AVL. Just keep in mind that these patients may have Al-Kappa, and such type of patient, as you know, should be diagnosed as early as possible to correct the anomalous coronary artery and protect the heart from further damage and failure. By echocardiography, as you know, as a cardiologist, we have to focus on cardiac anatomy to rule out any abnormal anatomy, arterial and venous connection, if there is any AV or VA discordance, origin of coronary arteries, as I mentioned earlier, to rule out any Al Kappa or coronary fistula, presence and amount of shunt. We can calculate what we call it QPQS to see how is volume overload on either systemic or pulmonary circulation, presence and amount of valve stenosis or regurg. Also, it's very important. Atrial and ventricular size, what's the chamber size as a sign of volume overload, or thickness as a sign of pressure overload. Left ventricle and right ventricle function either globally or even segmentally. We have to remember that there is systolic function, but also there is diastolic function, which is very important in like a restrictive cardiomyopathy, which is very important. The systolic function will be okay, but the diastolic function will be impaired. Estimation of right ventricle and pulmonary artery pressure to rule out any signs of pulmonary hypertension, atrial and ventricular thrombi, which is very, very important also in patients who have a poor ejection fraction and stasis inside the ventricles, and pericardial effusion also should be ruled out in any patient with heart failure. Just quick examples about volume overload. You can see there is a significant AV valve regurg here, and the right atrium, it's hugely dilated, as you can see, as a sign of pressure overload and dysplastic and stenosed aortic valve. Let me run it. Yeah. You can see thick myocardium, dysplastic aortic valve, and this is a clear sign of pressure overload. Of course, followed by detailed Doppler study to quantify the severity of the disease. HOCM, hypertrophic cardiomyopathy, you can see this is a huge thickened left ventricle wall, and some of those patients, they have obstruction at the outflow tract as a complication. As you can see, there is a bulky myocardium at the left ventricle outflow tract obstructing the left ventricle outflow, and this is what we call it SAM motion, with systolic anterior motion of the mitral valve, and it may cause also more obstruction to the left ventricle outflow. This is a dilated cardiomyopathy. You can see as very poor contractility, and we have an echogenic shadow inside the left ventricle. This is a thrombus in the left ventricle because of poor contractility and poor ejection fraction. So we have to be careful that such type of patient are prone to have a thrombus, and of course either systemic or pulmonary embolism as a serious complication. This is an example of restrictive cardiomyopathy, huge atrium comparing to the left ventricle and right ventricle size, as if the atrium became bigger than the ventricles, which is a very important sign of restrictive cardiomyopathy. Sometimes, as I mentioned earlier, we may ask for a cardiac MRI, and Dr. Suleiman knows very well about how we can detect the poor perfusion or poor, let us say, dye intake and the dead myocardial cells, and sometimes we can quantify the viability of myocardial cells by special technique in cardiac MRI. Biopsy for some cases when we are in doubt, is it a cardiomyopathy, is it a myocarditis? Of course, it's very, very important investigation tools, but as you know, it needs very advanced lab to take the biopsy and to read the biopsy, which is the most important things, and look for Dallas criteria, infiltration within the myocardial cells, and there is a myocytes degeneration, just to specify the mechanism of the myocardial damage. And according to that, you can classify the degree of the damage and what is the suitable treatment options. Clinically, as you know, in adult, we have what we call it New York Heart classification as a physical, let us say, classification of the severity of the heart failure from grade 1 to grade 4. In pediatric, we have Ross, modified Ross criteria to classify patient with heart failure. As you know, in grade 1, when there is no symptoms and heart failure was discovered accidentally, moving to grade 2, grade 3, when the symptoms became slightly obvious and the patient start to become more symptomatic during exercise, and ending by stage 4, which is the most advanced stage of heart failure, more symptoms, and the patient became symptomatic even during rest and during normal physical activity. How to manage the heart failure? All of us has, an idea how to help the affected heart or the failing heart with diuretics, just to decrease the preload and let the heart pump less amount of blood and relieve the extra volume from the heart. Sometimes digoxin to support the heart and to support the myocardium, to eject more blood to the body. ACE inhibitors to reduce the afterload and make the heart pumping against lower resistance, so the cardiac output will be better. Same for angiotensin receptors blockers. Aldosterone and angiotensin also, it will be helpful to reduce the afterload and enhance the cardiac output. Beta blocker, it's not really a new treatment. It was considered initially as a contraindication tens of years before, but after that they considered that beta blocker is very important medication in the management of the heart failure, because it will reduce the heart rate, it will reduce the oxygen demands of the affected myocardium. And also, as you know, beta blocker, it's a class 2 antiarrhythmic drugs, so it will protect the patient with heart failure from malignant arrhythmias. Inotropic support, either IV or oral, depends on the severity of the heart failure. And we have different protocols when to use dopamine, dobutamine, noradrenaline, adrenaline, milrinone, etc. There is
interrupting 5 minutes, please.
Please.
5 minutes more.
Okay, 5 minutes more. Okay, so that means I have to move very quickly. There is new agents in the management of the heart failure. No need to talk too much about them. We have to remember that we have to give some anticoagulation treatment for those who has a poor cardiac output. Specific type of ventilation may helpful to decongest the lungs, like CPAP or non-invasive ventilation. Reversible causes should be treated, or like anemia, hypertension, malnutrition, respiratory disorder, thyroid dysfunction. Also, as a general pediatrician, you have to keep in mind that there is a reversible causes which can be detected and treated properly. Pacemaker for those patients who has advanced degree of heart block, either second or third degree, will be indicated. Cardiac resynchronization therapy, when we have like asynchrony between the lateral wall and the intraventricular septum, we can insert leads, like there is a generator here with the 3 leads, 1 lead in the intraventricular septum, another lead in the lateral wall. These generator will, resynchronize the contraction between the intraventricular septum and the lateral wall, as you can see, to achieve better cardiac output. Also, ICD, implantable cardioverter defibrillator, acts as a guide inside the heart. This is a generator here. There is a lead inside the heart just to detect the malignant arrhythmia, and I give a DC shock in those patients with VTAC on VFib. Also, there is a specific indication, ECMO, which is extracorporeal membrane oxygenation. for children with heart failure, especially those who has like inflamed myocardium and there is a chance for recovery. So we may put them for some period on ECMO just to let the heart recover, then we can connect him back to the heart. There is a new device, what we call it Impella. Impella also, it can decompress the left ventricle. It's a catheter actually inserted in the left ventricle, suck the blood from the left ventricle and inject it to the ascending aorta. So we can deload the congested left ventricle and enhance the cardiac output and improve the organ perfusion like a brain and kidney and avoid acute kidney injury. Of course, we have Berlin heart also, which is a special artificial heart where different sizes starting from the neopore until adult. It can help as a biventricular assistant device or left or right ventricle assist device. There is a different indication to put Berlin heart. There is a small also pump we call Jervik infant pump outside the ventricle. Cardiac transplantation as a end stage for those patients who has end stage heart failure refractory to surgical and medical treatment. Also, it can be considered for complex congenital heart disease. Nutritional status, we have to support those patients with good calorie intake because the outcome will be much, much better. Cardiac exercise, I know sometimes just give me a few minutes to focus on this slides. Shall we allow those child with, with congenital heart, with heart failure to run, to play, to participate in sports, or we have to protect their physical activities? There is a lot of studies in adults about cardiac rehabilitation program, and they conclude that cardiac rehabilitation program in adult reduce the mortality, reduce the heart failure hospitalization, improve the functional capacity, improve the exercise capacity, and improve the quality of life. And they found that lower functional status is associated with poor outcome. In Philadelphia, since 20 years back, they have a special program for heart failure in children. They noticed that pre-transplant exercise training improved the respiratory muscle strength, and this leads to shorter time of extubation and shorter time of hospitalization and decreased ICU stay. And how they can apply this program, they will do like a baseline cardiopulmonary exercise test. Then they will design a special exercise program for this child, which is different from other according to the baseline test. They will put this patient on this rehabilitation program 2 to 3 times per week. After 6 to 8 weeks, they repeat the cardiopulmonary exercise test, and they notice that there is a much better improvement in the cardiac output and exercise activity. And for Fontaine, particularly, they noticed that lower extremity exercise augments the peripheral muscles pump. And this is very important, as you know, for single ventricle patient. Just 2 slides remaining. Long-term management, we have to remember that those patients should be immunized, either standard or optional. Let us say vaccination. We have to monitor their growth. We have to monitor the cardiac symptoms. We have to give them anti-bacterial endocarditis prophylaxis. We have special device also nowadays. We can monitor the cardiac output inside the heart. Also, there is a special indication for that. And they have to have a special like a fitness form before traveling. So in conclusion, yes, the causes and the clinical presentation of heart failure in pediatric is different from adult, but it looks like sometimes the outcome in pediatric age group, because there is some reversible or treatable causes, will be better. Yes, still we need more and more investigation about what is the best treatment, let us say, the new advance in the medical treatment, because most of the paper or most of the new medication now was taken from the adult experience. So yes, we need more investigation in this field to see the safety and the feasibility of such a devices and medication in pediatric age group. Thank you very much.
Thank you, Dr. Mahmoud, about this very informative, very comprehensive presentation about heart failure, causes, pathophysiology, symptoms, diagnosis, and management.
Thank you.
Now we will continue with the panel discussion with Dr. Muhammad Sulaiman or Dr. Dibadata. First with Dr. Muhammad or Dibadata. The screen for you, Dr. Dibadata.
Ladies first, ladies first.
Ladies first, okay, the screen for you.
Dr. Mahmoud and Dr. Sulaiman, they are hosts.
Okay.
Thank you.
Thank you. Am I audible?
Yeah, you are audible.
Thank you, Dr. Mahmoud, for this wonderful presentation. And I think very little needs to be said after this very comprehensive presentation that you have given.
Thank you very much.
And I really thank the organizers, Dr. Tomarai, the president of Dubai Pediatric Club, and also Dr. Kalpana and the entire team of Dubai Pediatric Club for giving me the opportunity to participate in this platform. I apologize for because my voice has left me today morning, and I have a few interesting cases that can be discussed. So with the permission of the chairperson and the moderators, I would like to proceed. Would that be all right?
Yes, doctor.
Yes. Just give me a moment, please. Is my screen visible?
Yes, it's visible.
Yeah. So after this wonderful discussion by Dr. Mahmood, I would just like to highlight a few important cases that I found in my daily practice. Unfortunately, the patients don't come reading the book, so it becomes a real diagnostic dilemma at times. I had this term baby with mom had polyhydramnios and high pressures. Baby was floppy at birth, had a poor cry, tachypnic, and needed bit of oxygen. And we can see that the X-ray is rotated film, not very conclusive, excepting there are few increased vascularity in the pulmonary beds, and also there's a bit of cardiomegaly. The child was very dysmorphic, as is evident here, with macrocephaly, low set ears, hypertelorism, long philtrum. We was thinking it could be a syndromic child. From the second day onwards, the baby developed some ventricular premature complexes, as is evidence here by very white complex QRS complexes over here. And the echo showed this huge hypertrophy of the interventricular septum. As you can find here, this grossly hypertrophied septum, this is the left ventricular outflow tract, and it is causing a lot of flow turbulence in the left ventricular outflow tract. So it is a case of hypertrophic obstructive cardiomyopathy, as Dr. Mahmood had well illustrated in his findings also. And it was giving us a gradient of about 35 to 40. So we had started on some low dose beta blockers, but in a few days, the baby also developed these kind of narrow complex QRS complexes, but they were junctional in nature, not preceded by P waves. And here in the long lead 2 of the ECG, we can find that the P waves are having different morphologies as well as different PR intervals. So we were really confused, and towards the end of the second week, the baby had developed very frequent ventricular premature complexes, as well as short runs of incessant ventricular tachycardia. So this incessant ventricular premature complexes with short runs of VTAC was really interfering with the left ventricular was interfering with the ultimate effective cardiac output. So added on to the left ventricular outflow tract obstruction, it was showing features of heart failure and hepatomegaly. So after consultation with an electrophysiologist, we did hike up the beta blockers as well as add amiodarone. The arrhythmias was well controlled and the features of failure dissipated, though a few ventricular premature complexes still persisted in the next few days. The baby also had a host of other things like poor sucking, delayed coordinated swallowing and all. So I must thank the consultant who insisted on the genetic test, and the genetic test showed evidence of HRAS mutation. That is a case of Costello syndrome. Though a close differential is Noonan syndrome and glycogen storage disorders, but this has been found to be an established cause of hypertrophic obstructive cardiomyopathy in newborns and early infancy. So in our case, the important thing was that the tachyarrhythmias, along with the left ventricular outflow tract obstruction, was actually precipitating the heart failure. So these are the few cases of left ventricular outflow tract obstruction, which if severe can cause duct-dependent systemic circulation in the babies. The critical valvar unicuspid or bicuspid valve may cause critical aortic stenosis, hypertrophic obstructive cardiomyopathy, which is usually accompanying syndromic babies or inborn errors of metabolism. There may be a critical coarct. There may be various forms of interrupted aortic arches and the entire spectrum of hypoplastic left heart. So our second case is again picked up by my very dear pediatrician colleague. He referred this child, a 7-month-old girl, who had otherwise failure to thrive, a hyperdynamic precordium, gallop, and a soft systolic murmur in the left sternal edge and apex. You can see from this nose, this typical nose, I was thinking this could be digeorge. But then the baby had other features like a low set eyes, long philtrum, and also this typical arachnodactyly. The X-ray showed both right as well as left atrial enlargement in addition to this huge cardiomegaly. So if we can see the videos, if they are playing, then we can see the myxomatous valves, the tricuspid as well as the AV valves being redundant and myxomatous, and they are prolapsing into the atria. There is huge tricuspid regurgitation as well as mitral regurgitation. So this was a case of infantile Marfan's, where in addition to the mitral and tricuspid valve prolapse and regurgitation, we also had this aortic root dilatation, which was about 3.5 Z-scores. There was only trivial regurgitation in the aorta, but the root was definitely dilated. So this was the echo, and again, it has been enumerated, and the baby improved with diuretics and enalapril. My last case was actually picked up by a sister on duty. This was a more or less asymptomatic 35 weeks, 2.4 kilo baby, borderline term, maintaining good saturations in air. But the sister pointed out that, doctor, this baby has got persistent tachypnea, especially after feeds. There was not much finding in the precordium, but when I did the echo, I saw it was a case of coronary sinus type of TAPDC. Here we can find this is the dilated coronary sinus where all the pulmonary veins are coming and meeting. In the echo, we can find this small left atrial chamber at the back, and it is separated from this huge dilated coronary sinus by this white kind of a boundary or wall, and all the pulmonary veins are forming a confluence and draining into the dilated coronary sinus. This child was immediately referred for surgery. I have just enumerated the various causes or the various presentations of a low cardiac output state in newborn period or very early infancy. Here, all of them were newborns. On my extreme left is a duct-dependent pulmonary circulation with very oligemic lung fields. And this child had crashed 36 hours with saturations not improving with oxygen, and very classical with not much cardiomegaly, but very oligemic lung fields. So this was a duct-dependent pulmonary circulation or pulmonary atresia. In the middle is another baby who had crashed at around 30, just after birth, a few hours, with SATs very low, 56%, not improving with oxygen, bit of plethoric lung fields, and this typical egg on side appearance. The egg on side appearance of the transposition with intact septum and with a very restrictive PFO. This child was immediately referred for a balloon atrial septostomy and taken up for switch surgery. On my extreme right is another newborn presenting with shock metabolic acidosis 8 hours after birth with very poor saturations and a huge hepatomegaly. Very classical is this very ground glass appearance of in the X-ray, the ground glass appearance of the of the lung fields. There is not much cardiomegaly, and this is very typical of an obstructed type of TAPVC, which is typically found in the infracardiac type in the newborn period. So the echoes on my left is the tricuspid atresia and pulmonary atresia with small globular hypertrophied right ventricle. And on my right, the two pictures showing typical transposition with intact interventricular septum. This is the left ventricle giving rise to the pulmonary artery, which is dividing into the two branches. So these can cause duct-dependent lesions and cause the babies to have low cardiac output state in the newborn period or even in early infancy. So to sum up, not all cardiac failures are because of a large left to right shunts or VSD or PDA. It may be because of maybe a very severe regurgitant lesion, or a low cardiac output state may be precipitated due to a duct-dependent systemic or pulmonary lesions or mixing lesions such as a transposition. Tachyarrhythmias may complicate heart failure in newborns and young infants. They may even precipitate heart failure. And lastly, silent tachypnea, in addition to feeding difficulties and all, may be the only clue to the initial underlying congenital heart disease. Thank you so much for listening to me so patiently. And I'm very happy to be here and sharing these.
Thank you, thank you. Thank you, Dr. Rupida, for...
Dr. Khalid is not joining. I will be replacing him in between. I'll be interfering. And thank you very much, Dr. Devata. Dr. Amir, continue, please.
Okay. Thank you, Dr. Beta, for the interesting cases of pediatric cardiology. Now move to Dr. Muhammad Sulaiman to continue the screen with you, Dr. Muhammad.
Thank you very much. Thank you for the DPC for inviting me to be part of this beautiful and nice, informative meeting. And thank you to Dr. Sufi and Dr. Dipata for their great presentation. Of course, thank you to Dr. Sohrab and Dr. Kalbana for their continuous effort to make this conference behavior and yearly behavior, bi-yearly behavior, things that we are all enjoying. Honestly, I did not prepare for to do any presentation for case presentation, and I was thinking it will be a mutual discussion. However, since we are talking, I'm going to share with you the last case probably I saw a couple of months, 2 or 3 months ago. The patient still currently is under treatment. Do you see the screen?
Yes, yes. Slide mode, please.
Okay, so I will try to divert the message directly to our pediatrician when we talk about congenital heart disease, congestive heart disease, and all of these kind of things. So the message right now, I'm not going to direct it really to our pediatric cardiologist, rather to the general population for our pediatrician to learn something that from this case. So this is an 18-month-old boy with a history of poor weight gain. So he has a normal spontaneous vaginal delivery, no complication after birth. He went home. So his developmentally seems to be okay as per parents. He sit at almost on time and has a good weight gain, has no good weight gain. And at 18 months, his weight was only 8.4, while his weight, birth weight was 3.3. So the patient has been seen by many pediatricians, and he was advised for different modality of feeding, high calories, Pediasure, and all of this kind of different way to feed the child. I don't know how to. I don't know if my computer froze or just froze. Hello? Froze.
Yes, Dr. Mohammed, slides are not moving. Yeah, it's okay now.
Okay?
Yeah.
Okay.
I cannot move my screen.
Just wait for a second, Dr. Muhammad. Sometimes it takes time. Okay, I think this is a first slide about the clinical background of the patient.
Okay. Okay, so the patient was referred to GI doctor who also diagnosed him with some form of celiac disease, was still under investigation, and he finally decided that, because he was just in front of me on the clinic, and he said, "Do you think you should see this patient with us?" I told him I don't mind. It's the end of the day, I need to go, but I will see this patient before I go. So he sent the patient to for evaluation for pediatric cardiology. So the patient seemed not much in distress and only mild subcostal retraction on physical exam. And family reported he gets sick more when he get URI and had 2 previous admissions for wheezing. So in his physical exam, his chest has mild wheezing and occasional rales. His liver about 4 to 5 centimeters subcostal margin, and he has a S1 and loud S2 with no split. He has 3/6 systolic ejection murmur left upper sternum border with 1 to 2 diastolic murmur at the apex. His femoral pulses was barely felt, and almost, just with our skills, I can feel like a thread of pulsation. Otherwise, I cannot feel anything. His EKG show sinus rhythm. I don't have a copy of it. Sinus rhythm with right ventricle hypertrophy. So this is part of the evaluation that was done later on for this patient, which basically showed complex congenital heart disease with significant mitral stenosis. So this is the mitral valve here. This is a TEE for this patient, and has a significant gradient, about 18 millimeter mercury in mean. This is the gradient here. So this is the mitral valve. So it has a significant severe mitral stenosis, and subsequently left atrial dilation, subsequently pulmonary edema, and mild to moderate tricuspid regurgitation. So basically this patient was in a form of pulmonary edema, even though his clinical condition on my clinic really did not suggest that bad picture. His tricuspid regurgitation gradient was about 80 millimeter mercury, which is almost close to systemic pressure. Of course, his echo for the arch was not so clear. We suspected also that the patient has a coarctation of the aorta. So I sent this patient for a CT scan, and this is the result of the CT scan. Here we have a significant severe coarctation of the aorta. This is a part of the X-ray that just look congested for the heart. So the patient has a significant, from the picture that we are showing, significant right ventricle and left ventricle heart failure, obstructed from the left side and congested on the right side, so has a mixed surgery, so a mixed picture. We referred this patient, the family insisted to travel abroad, unfortunately, even though we offered them surgery in the country, but they insist on going abroad, and I told them that I really cannot be sure if this patient will be safe to travel. They still insist. And they finish with their surgery. I'm getting feedback from them. The patient right now doing very well and has only mild mitral stenosis. And the coarctation has been repaired. So the point from this case is that, you know, when you have something that for a long time that doesn't make sense to everyone, and we keep pushing to bring the patient for different things consisting on malnutrition as an example, or weight gain. Remember, this is the most challenging part and most likely symptoms for any patient with congenital heart disease that not easily detected. It surprised me how this patient spent 18 months, nobody felt the pulses, the femoral pulses, how they are. And I believe they were not difficult to check. Also the heart murmur, which was very obvious and very strong to detect, which means that sometimes we take things for granted and we assume that, you know, the patient just has malnutrition, probably he's not feeding well and so on. And that's, we just need to keep feeding. So be aware that if things doesn't make sense for a long period of time, go to the next step and try to figure out if there is any other problem. So this is the case that I discussed with you. There is another case, actually, Dr. Mahmoud Al-Soufi already kind of talked about this kind of case in a general perspective. And this is a trick for us as a pediatric cardiologist. I just want to tell you that the picture that in this case are not the real picture of the patient, because I really did not have a time to get all of these pictures, but I want to give the message. So this is a 12-year-old girl with a history of dilated cardiomyopathy and heart failure. This patient was diagnosed in infancy in one of our hospital in Dubai and by a pediatric cardiologist, and subsequently continue to take medication for congestive heart failure, which mainly looked at left ventricle poor function with ejection fraction of 35 to 40%, and was taken Lasix and captopril. This patient continued to do overall stable from the heart point of view, with no progression of congestive heart failure and nor improvement of the heart failure. So she has been stable throughout, and then echo reported suggested initially that she has a normal coronary arteries, and the EKG only show read as left ventricle hypertrophy. So the patient was referred to our colleagues in Jalila Hospital, who asked for cardiac CT. So I did for the cardiac CT for them because I believe they suspected anomalous or something related to the coronary arteries. Just looking at this picture, this is what we see in the normal situation. So this is the aorta, and this is the left main coronary artery, which branched to two branches, the circumference and the LAD. And here we have the right coronary artery going. This is the normal situation where we have the normal coronary arteries. So what we see here is, I'm sorry. You see here the normal coronary artery. It's running. As you see here, you have the aorta here, and you have the normal coronary artery. the left coronary artery, and you see here the pulmonary artery. While you see in this picture here, this is the aorta, this is the right coronary artery, this is the left coronary artery coming from the pulmonary artery. So we diagnosed this patient actually with anomalous LAD from the pulmonary artery. This is an EKG that Dr. Mahmoud Al-Sufi has presented earlier in the day, similar EKG, which include the Q wave and lead 1 and AVL. When you have these two waves, you should always suspect until proven otherwise you have patient with a picture of Al-Kaaba. And this picture just to show us the different type of coronary artery anomaly, which we are really not discussing in this presentation. So bottom line on this case is a second case who luckily she survived. This patient, usually they die with anomalous coronary artery. They die in infancy in the first 3 to 4 months due to congestive heart failure. And this patient, luckily she survived until she was 12 years old, where we made the proper diagnosis, and subsequently she went to Al Jalila for cardiac surgery. And I believe she's doing well. Dr. Muhammad Sufi probably know about her outcome more than me. And I think this is the second case. And thank you very much for listening.
Thank you, Dr. Muhammad, for sharing these interesting, practical, and informative cases. Now we can move to some question. You hear me?
Yeah.
Okay. There is a question from Dr. Robia about what are the latest validated digoxin indications for its use in children with heart failure. Dr. Mahmoud, maybe answer?
Yeah, thank you for this question. Actually, digoxin is still one of the mainstay in the management of the heart failure. There is no contraindication. We do prefer, of course, it's an oral medication. We do prefer to give oral digoxin without loading dose in those patients who has chronic signs of heart failure. For those patients who have acute heart failure, we do prefer the stronger IV inotropic support like milrinone, dopamine, dobutamine, and etc. But those patients with chronic heart failure, yes, we do recommend digoxin oral without loading dose to be given. If there is no contraindication, just keep in mind, you have to observe the digoxin level in those patients after a couple of days to be sure that you are in the therapeutic level.
May I add something historically?
Let me comment because I am not a big fan of digoxin, and I find it a good opportunity for me to talk about this issue. So from the digoxin, there is always a controversy, should we give digoxin or should not? For children, what we know is that the effective, the plasma level for the digoxin that we depend on monitoring, which usually less than 2, is not the actual dose where what the cells enjoy inside the cells. So you could get a normal digoxin level, but you still have a toxic effect and many other problems. So the digoxin is not really as safe as we think. It has been probably more than 100 years. A lot of people don't use it for congestive heart failure. Maybe some of us use it, some of us don't. I rarely personally use it. I don't know how much benefit we are getting from it. We still lack of a proper study to document. We know for adult, as an example, that the digoxin will decrease the chance for staying inside the hospital, but it will not prolong the life expectancy for this patient. For pediatric, again, we don't have a clear studies on what is the benefit of digoxin. And you get other side effects, starting with vomiting for the patient and nausea and not being able to eat very well, and end up by, for abnormal toxic effect with a significant arrhythmia and could cause even bad very outcome arrhythmia. So this is one of the things that, you know, I generally don't recommend myself to use the digoxin. Well, Dr.
I'm going to
Mahmoud.
say something.
Yeah.
Something you said, if you allow me.
Yeah.
The 18th century, William Wittering, who developed the digoxin, he was going from London to Edinburgh. They showed him a lady swollen. He saw, he said, I don't know anything. This lady will die. He went and while coming back said the lady is walking in the fog. So what happened? Then they found the foxglove leaf. She boiled that one and gave, that was the history of digoxin, how it was introduced in the 18th century until now it is continuing. The history of medicine is very interesting. Yeah, please.
Yeah, as Dr. Muhammad mentioned, yes, most of the studies in pediatric came from adult experience. This is number one, and we all agree about that, especially in the new medicine. So giving digoxin, if there is no contraindication, I don't think will be harmful. Of course, if the patient develops some side effects, we have to stop. Yeah, and what we do recommend to avoid like a toxicity or significant side effects, don't go with loading dose, then maintenance dose. You can start with maintenance dose, keep your eyes on the digoxin level and see if there is any, let us say, unfavorable side effects. Shall we use it as, is it a mandatory to use? Of course, no. It's case by the end. Yeah.
Can I just make a comment over here?
Okay.
Please.
Actually, we have occasionally used it under the advice of an electrophysiologist for arrhythmias, especially fetal arrhythmias. We have used it in the mom for fetal SBT. So that is strictly under guidance of a cardiac electrophysiologist. But rarely we use it for systolic failure. That's all.
For tachyarrhythmia and fetuses, yes, there is some paper about using digoxin. But as you know, there is a very narrow, let us say, space between the therapeutic and toxic level. You have to give the mother very high dose to reach the therapeutic dose in the fetuses. There is maybe more or safer medication to be used in fetus tachyarrhythmia, as Dr. Suleiman knows. Maybe sotalol or another type of beta blocker can be used safely with good efficacy.
Just to comment on the fetal, it's usually not the first line of treatment, as you mentioned, but sometimes if we add it, if you try to use flecainide or you try to use sotalol, and you want to add something to help to control the arrhythmias, then you may consider digoxin. The only way for the digoxin to work, and it could work for arrhythmia, for fetal arrhythmia, only if you make the mother really throw up on and on and on and on until she hit you and she hit the hospital and she hit the pregnancy.
Or hit her husband.
We can take a second question from Dr. Amir Ahmed Malik. What about choice of ionotropic in children as a first line of choice, whether catecholamines or dopamine, dobutamine? Dr. Mahmoud?
Again, it's a good question and difficult to give an absolute answer. It depends on what you want to improve. You want to improve the myocardial contractility. Yes, you have to may use melatonin and epinephrine, norepinephrine. If you want to improve or to increase the blood pressure, of course, you can use also dobutamine and to enhance the myocardial function. If you want to enhance or increase the blood pressure, you may use more vasoconstrictor like norepinephrine or epinephrine. So there is no absolute inotropic medication which can be given for all patients. It depends on what you want to achieve. So, and you have to know, or you have to be well known about the effects and the side effects of each inotropic support. Usually, our colleague in ICU, they they used to carry on the management of the inotropic support in the ICU. Of course, there is new also inotropic support like levosimendan, which can enhance the cardiac function and reduce the vascular resistance. There is a special protocol, when to use it, how to use it. So yes, there is plenty of inotropic support. You have to select according what you want to achieve and what your patient needs.
Thank you. Thank you. To conclude this session, please, any advice, Dr. Muhammad, Dr. Debata, for general pediatrician and pediatric cardiology, any advice?
You have 20 minutes for discussion. Let them.
I have really a special.
There is a question on MISC.
Dr. Suleiman has a question or advisement, I think.
No, I have advice, really. I really have advice for all of us, not just for the pediatrician only.
Happy to hear.
Use your stethoscope. Don't just carry it to show that. Use it and listen carefully. You know, learn how to listen to the first heart sound, second heart sound. Good history, always the best thing. So this is the advice that I will say for all of us. We carry the stethoscope on and on and on from the day that we get into the medical school, and everybody, it's like our identity. And many times we miss so many things just because we didn't listen properly, and we assume only the patient has a wheezing, that's it, or pneumonia. There is a heart inside the chest. Please don't forget it.
And put your finger on the femoral pulse also. Yeah.
You have to put two of them.
Yeah.
To feel better.
Yes, Dr. Deba.
Yes, there is a question on MISC, coronary aneurysm and MISC, I think.
Yeah.
Dr. Malay has asked. Well, we have found a lot of cases of MISC, and in this second wave particularly, we are finding the more complicated ones. The first wave MISCs had less of coronary involvement from our experience and more of left ventricular failure. But in the second wave that we are experiencing now in India, from our institutions, we are getting a lot of babies, especially young babies with more than one, that is multiple coronary aneurysms, as well as left ventricular failure. The left ventricular failure sort of magically improves with IVIG. It just magically improves. But the coronary artery dilatations can persist and needs a very long follow-up. Another point is that I have not found anything very large. Like, it's always small to moderate aneurysms, maximum say about 4 to 5 Z-scores. So that's my experience. And again, I apologize for my voice.
Dr. Suleiman has a comment, I think, because he already show us a lot of interesting coronaries, actually, in MISC patient.
Yeah, I asked Dr. Sohrab and Dr. Kalbana if I can present. This is probably something that's still in the market. And they said, no, you have to stick to the subject. Okay, fine. So,
Doctor, we will give you another.
Right now, I can't talk.
No,
well,
if you have 5 minutes,
we have a few
5 minutes to present. You have 5 minutes to give from my side to present. You have now to present. No.
So, you know, MIS-C in children, usually 5 to 10 years are the most affected, as we know. A little opposite of the Kawasaki. And then we have the less than 5 years and the more than 5 years, you know, maybe quarter and quarter. But half of the cases usually between 5 and 10. What we have seen, many cases, there is a huge, amazing, the biggest aneurysm I have seen in my life. And I am following at least about 5 patients with this huge aneurysm. To the point where one of the patients, just for us as a cardiologist will understand how bad it is, that was confused, it was read, this is the ascending aorta. That's just how it was during the presentation. And then they thought, no, this is the pulmonary artery. And the patient was sent for cardiac CT just to check what's going on. And then finally, we have this huge, amazing coronary aneurysm. This patient with coronary aneurysm, really, they just follow the same standard of what we see in huge coronary or giant
Kawasaki.
coronary and Kawasaki patient, where they need multiple medication, including warfarin and aspirin and so on. And they are very difficult to, I follow them personally currently every month, and I don't know if I am doing right or wrong. And I don't know what I'm doing in every single visit. I have repeated CT scan for some of them with no significant improvement. It includes both the right and left coronary arteries. So it's a very bad disease, and I don't know where we're gonna head with it. I have even asked one of the patient, we have really, that's not my patient, was admitted to SKMC, and they stopped the Coumadin to be able to do some form of cath. And the patient, you know what happened? He clotted and he basically arrested. So you're stopping the warfarin to try to do a cath to delineate the anatomy of the coronary artery. The patient ended up by being basically arrested and went to ECMO. I heard he recovered, but I'm not sure what's going on with him at this time.
Suleiman, Dr. Devadatta has done a lot of work on aneurysm in Kawasaki. In fact, she presented in one of the centers, PGI. Can you explain that? About your cases, aneurysm in Kawasaki.
Oh, yes. Oh, thank you. Thank you for allowing me. Actually, I did find a lot of cases like in different season. First, I did for about 1 year. 1 year, I found a lot of cases, especially the infants. We had found giant aneurysms in infants. We had found multiple aneurysm in infants. And we had to actually give them not only IVIG, but also infliximab. We also found Kawasaki in association with various other systemic infections, such as dengue, such as staphylococcal infections, then also scrub typhus infections and other tropical infections. But one important thing I found that there was usually single coronary involvement in the older children, while in the younger children and the infants, it was multiple involvement and more extensive involvement. And we found a few cases of Kawasaki shock syndrome also, but there were few. But in MISC, we found almost all cases had left ventricular dysfunction, especially like Dr. Suleiman had said, the older ones presented with left ventricular dysfunction, which magically improved with steroids and IVIG.
Thank you.
Thank you.
Can I just share the picture of the coronary aneurysm? I think I just found it. If you don't mind, I can share it with you.
Yeah,
Okay,
sure. I'll tell you one historical aspect. You said stato. Laennec invented in 1816 stato. It was called stat. Stat means change. Oscope means examining. Bronchophony, egophony, raised rhonchi, all he explained with a piece of wood. Still, we can't diagnose those. Those names means rhonchi became V's, rail became crepitation in 1978. In the Crafton Douglas, they changed the terminology. There is a big history, but still we can't. I mean, 1816, what has been described, we cannot even diagnose those. Means raised means dead rattle. When the patient was dying of tuberculosis, means going to die. He explained, you're right, stato we are not using. Surgeons, they never use a stato. Dr. Diari is there, he may laugh. Yeah, a stato, egophony, bronchophony, whispering pectorally, which part of a stato, which sound we hear, these are described. But nobody uses, you are right.
We are using knives, no stethoscope.
Do you see my screen?
Yes.
Okay, so this is one of the patients that with huge LAD aneurysm. This is the left coronary artery here. This is the aorta in this area, and this is the circ, and this is the LAD. So you see from here, from the origin until this area, you have almost close to normal coronary artery size, and then you get this huge and massive aneurysm By measurement, it was about length about 2.8 centimeter, I believe, and the width was about almost 2 centimeter. So for me, this is the hugest and the biggest aneurysm that I ever seen. And again, there is no magic what to do with this patient. He's still in the air, just expecting anything to happen at any time for them. I am done.
Lovely. Thank you for the lovely case.
Is there anybody discussing anything else?
Okay, there.
Mahmoud,
There are
anything
some
from your side?
questions in
Anything?
the
There's a
chat.
question here about, I think, difference between compaction and non-compaction cardiomyopathy.
Well, what I did not understand compaction. There is non-compaction, yes. Non-compaction, that means it's there is immature or abnormal myocardial cells with abnormal function leads to varying degree of impaired cardiac function. Of course, there is mild, moderate, severe form of non-compaction. That means the myocardial cells was or were replaced by like a spongiform muscular tissue. This tissue, of course, or the function of this tissue is abnormal. So this is what we usually mentioned in our report, non-compaction myocardium. That means there is abnormal form of myocardial cells congenitally leads to heart failure. Compaction, that means the cells already designed or formed well. However, there is another cause of myocardial damage, either myocarditis or toxic causes or what volume or pressure loads damage the myocardial cells and leads to heart failure.
Okay.
So in non-compaction, we have congenitally abnormal myocardial cells. In compaction, we have normal myocardial cells, but there is another causes of heart failure damage them, the normal myocardial cells.
Okay. I think
Dr. Suleiman,
can conclude.
Dr.
One
Suleiman.
interesting thing I want to show, you showed so many ECGs. Actually, in 1923, Eindhoven then discovered this ECG. There was a patient was so sick, could not be moved, and the machine was so big, could not be carried. They took 1,500 meter wire and they recorded the first ECG. This is the history of the ECG.
Dr. Suleiman. Dr. Suleiman, I have a question.
Said about the non-compaction, basically, what we look at, the left ventricle, we always look at it as a smooth borders, okay, from the posterior and the septal component. And usually we are allowed to have some compacted portion of the muscle and some non-compacted, which basically like a spongy portion. So we have to read when we say non-compaction with a little bit reservation that is it really above specific number? Like if you have 2 to 1 non-compacted to compacted, then we call it non-compaction. Everybody almost, if you do for adult as an example for all of us, and you specifically look at the apical area of the heart, you will find a lot of patients who has a form of non-compaction or the forgetting heart issue, which we don't do anything about them. So the majority of the non-compaction patient, they will do just very well. If we are in any doubt of that patient have a significant non-compaction, or we want to establish a diagnosis, then we usually do a cardiac MRI, and that's usually the gold standard for the diagnosis to decide this is 2 to 1 portion.
Dr. Suleiman, I have a question.
Yes.
Hello, you hear me?
Yes.
Yeah. Do you recommend for every case of COVID to do initially an echo or later on follow-up to diagnose some undiagnosed coronary artery aneurysm or any other pathology?
There is 2 issues here. One of them is COVID, and one of them is Miss C. If you are only talking about COVID, you do not need to do COVID, echo for every single person who has COVID positive test, because you're going to make Dr. Sophie very rich and you're going to make me very rich.
No, I am not saying that.
However, if you admit a patient as an example and you suspect this is a Miss C, which there is a standard for it from the WHO, how do you diagnose it? And there is a criteria to follow to decide this is a Miss C or not. If you suspect this patient has a Miss C, then echo is an immediate need, because most of the time that you will have cardiac dysfunction, like Dr. Bata has mentioned that especially the left ventricular dysfunction will be very obvious even before the coronary artery anomalies. So yes, if you suspect Miss C, you should do an echo immediately.
But not only Miss C, for example, in adults, we are seeing post-COVID, they are getting tired and they are, there is a post-COVID symptoms also. So these are, you don't want to even.
Just I will add one comment, unless, yes, I totally agree with Dr. Suleiman, unless there is an indication, like, as you mentioned, the patient became unwell, hypotensive, another indication to do echo for positive or COVID positive patient, yes, ask for echocardiogram. Otherwise, only for MESI patient or signs of MESI, echo will be mandatory just to see the coronary and other cardiac anatomy. Yes.
Let's say it in another way, just for practical point. If you admit a patient with Miss C picture or suspected Miss C, do the echo.
Yes.
Make me rich. It's okay.
Can we take the D-dimer as a value, 3 times the value of the normal D-dimer? Can be one of the indicators for echo?
Dr. Dibata, do you like to?
Yes, actually anything of that whole panel, especially I would go for NT-proBNP first. I was just about to ask the panel of experts that what about NT-proBNP? Can we use that as a basic screening tool? Like if it is increased, then we go for echo. I personally have found quite a few patients with elevated NT-proBNP, but echo-wise, the function was okay. Even I did a strain analysis and I did all the forms of Simpson's method and all in echo, but at least in the 2D echo, the function was okay. But still the NT-proBNP was elevated. So if anybody can give any comments on that.
Usually, we don't have such experience that if the pre-BNP is high, that means it's 100% the myocardial function will be affected. Usually, we'll measure the pre-MP just to watch the progression, let us say, or the control of the heart failure. But it doesn't mean 100% that such type of patient has impaired cardiac function or vice versa.
Thank you.
Yeah.
I will say we continue to follow the guidelines of what we are going to do, the order of labs. There is a bunch of labs that you have to do in order to add them to your criteria to diagnose MIS-C. And it's not a single one lab. Now, the echo, the Kawasaki-like symptoms from the heart point of view, almost positive in about 90% of patients who truly have MIS-C. But the degree varies between one patient to the other. One of them will have dilated, left ventricle, and one of them will just have maybe mild MR or something like that. So the picture from the positivity of the echo is good, but it doesn't indicate how severe the patient. The patient may have some other symptoms related to the brain or related to his gut. The major symptoms is really the gut symptoms, the vomiting, the diarrhea, and we care about the heart because it has a long-lasting problem related to the aneurysm itself. Most of the patients who really get admitted, they pass through with inotropes very well. The death from MIS-C in children is less than 1 to 2% for all the international world. as far as I know. So, but it does have a significant morbidity that admit the patient to the hospital and so on. I don't know if that helped.
We have reached the time now, Dr. Amir, concluding comment.
I think we can have to conclude, and thank you, Dr. Mahmoud, Dr. Muhammad, Dr. Dibata for contribution, valuable contribution in the DPC conference. So I think we have to move to Dr. Kalbana for vote of thanks.
Thank
The
you.
screen is yours,
Thank
Dr.
you for
Kalbana.
having us here.
Thank you, Dr. Badr, Dr. Mahmoud, Dr. Suleiman, for excellent discussion, really. I mean, afternoon, we are having so many, like morning, people are staying with us and listening. Thank you very much. I would like to request Dr. Kalpana to give the final
Thank you. Am I audible, Doctor?
Yes.
Thanks to the speaker of the cardiology panel and cardiologists who have done this wonderful discussion. I think everybody has enjoyed. And now it's time to conclude our half day of the 7th annual DPC conference. I will take this opportunity to thank the NMC Healthcare who, along with DPC and Vitabiotics, are the main organizers of this half day event. We've had wonderful sessions with stimulating discussions. So thank you to all the esteemed speakers and the panelists, and not to forget rather, the DPC Executive Committee members who have contributed so well. Thank you.
So on my behalf also, on behalf of the Executive Committee, I would like to thank all the speakers, panelists, faculty members, viewers, for contributing. I would like to thank Mr. Tawfiq for sponsoring. This is the 7th consecutive year he's sponsoring and supporting us. And I would like to thank the management of NMC Specialty Hospital for collaboration and CMA accreditation. Thank you. I would like to thank all the viewers. The whole Friday they were sitting with us and supporting us. Thank you very much. See you in our next annual conference. Thank you.
Thank you. Thank you. Thank you. Bye-bye.
Thank you. Bye. Thank you.